wherein we are going to discuss organ specific cancer care. So we begin with GI, genitourinary, then we go ahead with gynec-oncology, breast, head and neck, some interesting sessions in the evening which will really spark you up. And then tomorrow we have head and neck session, hemato-oncology. So a long list to follow, and we would uh, begin on time. And uh, it's really wonderful. Last year we came with this idea of OncoSphere 1.0, and then with the success of that, we thought that let's do this yearly so that we keep on learning with each other, we keep on educating each other, because oncology is such a field that every 6 months new protocols come up, every 6 months new guideline follow up, and it's very important that we all of us are keeping ourselves updated with this. And along with that, it it's a great opportunity to learn from our fellow colleagues who have traveled across India. So we have doctors coming from Mumbai, coming from Delhi, coming from Bangalore, Hyderabad, Indore, Bhopal, and all across India. And then it's a good opportunity also for us to mingle with them, interact with them, and understand how they practice oncology in their area, and what good messages, take home messages we can take from them. So, with this brief introduction, I welcome you all to OncoSphere. Let's enjoy the academic feast of OncoSphere and enjoy the hospitality of Ramakrishna Care Hospital. So, before we begin with our first session, may I take this opportunity to invite uh, Managing Director and Chief Robotic Surgeon of Ramakrishna Care Hospital, Dr. Sandeep Dave, to give a welcome address. Thank you.
Good morning to all of you. Uh, on behalf of Ramakrishna Care Hospital, Raipur, I welcome you all for this academic feast. Uh, I thank Ravi, who has taken extra efforts to make this conference very successful. Uh, as you all know, India is witnessing a significant transformation in cancer care, and burden of cancer is increasing day by day. Uh, there are rapid advances happening every day in the field of the cancer, in the medical science, technology, and definitely nowadays what we are hearing is the targeted therapy, where it is individualized by according to the disease pattern and according to the patient type. Genetics is playing a great role in cancer care. So, looking at all those things at Ramakrishna Care, we thought that we should definitely go ahead and organize the second version of OncoSphere. As you all know, uh, on maybe might have heard or you might not have heard, we are coming up with a cancer unit and we'll be inaugurating it on 16th of August 2026. Uh, I've chosen this date because on the same date, my brother was born and I lost him because of cancer prostate. So, to dedicate this cancer unit uh, on his birthday, we are planning the inauguration of this unit, which is coming, which is a very high end, advanced uh, unit fitted with all advanced gadgets. And though the cancer surgery and medical oncology both have started, but and radiation will also start very soon. But the formal inauguration will happen on 16th of August. Thank you. And I hope wish this conference to be a great success. Thank you. Thanks a lot.
Thank you, sir, for your excellent remarks. Let's begin OncoSphere 2.0 with the first lecture From Symptoms to Staging The Art of Evaluating Gastrointestinal Malignancies. It's my pleasure to welcome Sandeep Pandey, sir, Head of the Department, Medical Gastroenterology at Ramakrishna Care Hospitals.
Sorry, his topic is overview of distal cholangiocarcinoma. To chair the session, I would like to invite Dr. Vivek Kesharwani sir, Dr. Gambhir Singh, Dr. Debajyoti Mohanty, Dr. Yusuf Memon, Dr. Pankaj Modghare, Dr. Hanish Sharma, Dr. Vaishali Dubey, Dr. Kautuk Lohia, Dr. Sunny Utmani, and Dr. Abhishek Jain. Please join the dais as a chairperson and over to chairpersons. Over to chairpersons. Go ahead.
Morning, everyone. I welcome all of you to OncoSphere 2.0. I would like to invite Dr. Sandeep Pandey, sir. He's a senior most gastroenterologist of Chhattisgarh, a very good doctor, very good clinician, and he would enlighten us about the topic distal cholangiocarcinoma. Thank you, sir.
Thank you, Vaishali. Good morning to everyone, and welcome you all to the OncoSphere 2. Uh, we'll be discussing art of diagnosing distal cholangiocarcinoma. As we all know, all the cancers arising from biliary epithelium are known as cholangiocarcinoma. They can be subtyped according to their location, like intrahepatic, extrahepatic, even gall malignancy, and malignancies at ampulla itself. So, what is distal cholangiocarcinoma? It is the carcinoma arising in the common bile duct between cystic duct and ampulla. Gallbladder and ampullary cancers are not taken into this classification because their biological behavior is different. Ampullary CA, most of them, about 80%, they have a pancreatic component. So, extrahepatic includes perihilar and distal. This anatomical classification according to location shows clearly. Peripheral is intrahepatic, perihilar is involving right and left hepatic ducts, hilum and common hepatic duct, and distal one is involving common bile duct. This is a morphological classification. The tumors can be mass forming or periductal infiltrating type, or they may be intraductal growing type. Interestingly, all these cancers arise from biliary epithelium, but yet they all have different molecular profiles. That is why their clinical presentations and treatment also differ widely. So, coming on to distal cholangiocarcinoma, the early detection has been very difficult, partly because of the complex anatomy of the biliary tree and frequent late presentations. The main reason for delay in diagnosis is most of these patients, they have very vague symptoms like simple lethargy or some loss of appetite and body ache, etc. So some of the studies have shown that from the onset of symptoms to the diagnosis, the average time duration is about 22 months. That is a pretty long time. And by the time these cancers are diagnosed, only 20% of them are resectable. And here I would like to stress that surgery is the only curative, potentially curative treatment option in these patients. But at the time of diagnosis, only 20% are resectable. And out of those patients who are resected, about 50 to 60% again recur. So for majority of these patients, mainly palliative, supportive, and systemic therapy is the standard of care. These patients present late with painless obstructive jaundice. As soon as we have a patient with painless obstructive jaundice, the first diagnosis should be malignancy until it is proven otherwise. Similarly, they have cholestatic pruritus, and weight loss and anorexia are quite late features. At the same time, we have to rule out other benign conditions also, like IgG4 cholangiopathy, which is a potentially medically treatable condition, and post-op strictures. As far as tumor markers are concerned, standalone, they don't have much of utility for diagnosis. They may have a utility in supporting the diagnosis if other investigations are in favor of cholangiocarcinoma. And secondly, in following the patients who are under treatment, in follow-up, they may have some role. Now, as soon as we suspect cholangiocarcinoma, immediately we should activate our team comprising of surgeons, endoscopists, radiologists, and oncologists to have the best therapeutic outcome for the patients. Now, since early diagnosis has been so challenging, so it is highly important to identify the patients who are at high risk of developing these cancers, like primary sclerosing cholangitis, choledochal cysts, Caroli's disease, patients with hepatolithiasis, they are prone. Then chronic biliary infections, especially liver fluke, they are not common in our country. They are common in Thailand, Southeast Asian countries like Korea, China. Similarly, inflammatory bowel disease, some of these patients can develop cholangiocarcinomas. Now, how should we start investigating these patients once we suspect? The sonography, the simple bedside handy investigation, cost effective. It is the best investigation to start with, and it will tell you the level of obstruction, one, whether it's a high block or low block, and secondly, it can show you hepatic mets and nodes. And secondly, MRCP with MRI, it is a very excellent tool to diagnose, to assess the longitudinal extent of the stricture. And apart from this, vascular involvement also can be seen. Then CT chest, abdomen, and pelvis should be done basically to assess resectability and to rule out distant metastasis, as well as lymph node staging. For staging this AJCC, American Joint Committee for Cancer, 8th edition, it is routinely followed across the globe. The tumor invasion, the depth of tumor invasion divides the T stage, T1, T2, T3, and any tumor that involves the celiac axis or supramesenteric artery is T4. Similarly, node, if they are up to 1 to 3 regional nodes, this is N1, and more than 4 or more are N2. Any distant metastasis, immediately it puts them into M1. So after having a fair diagnosis, probable diagnosis, and a fair amount of staging, now you need tissue diagnosis, which is of utmost importance. So ERCP is still the workhorse to begin with. The simple cholangiogram on ERCP can you some features which may be suggestive of malignancy or benign nature. For example, any stricture which is long, more than 1 centimeter, asymmetric with irregular mucosal surface, it is more in favor of malignancy. While aspiration cytology can be taken at the same time of ERCP, easy method, but drawback is very low sensitivity. Brush cytology, you can put a brush while doing ERCP and you rub it against the lesion wall and obtain brush cytology. It is better than bile aspiration cytology, but still it doesn't have very good sensitivity and it has got limitations. Now, other modalities, better modalities than these methods are intraductal biopsy. While doing ERCP under fluoroscopic vision, you can have biopsy from the tumor, especially for polypoidal lesions. But again, the limitation is lack of direct visualization and there may be sampling error. FISH and DIA are sophisticated methods which shows chromosomal aneuploidy and it is in this DNA probes are used. Similarly, digital image analysis, it is computer assisted DNA quantification, but these are usually not available. Now comes peroral cholangioscopy, spyglass. This is supposed to be a very good investigation as far as cholangiocarcinoma is concerned. This is a single operate cholangioscopy. You can acquire tissue under vision and you can have visual interpretation of the indeterminate strictures. We started this cholangioscopy at our center long back in 2012. First, I had seen this when I was doing fellowship at Charleston, US, at Peter Cotton's unit. The first time this was being demonstrated there. And after that, in 2012, we started doing cholangioscopy. And you can see in the picture, you can have very good quality images. The video is not running. So this is the spy scope. This looks like this. This has a 10th inch diameter. After dilating the sphincter, you can enter the bile duct. You can see left and right hepatic ducts. And now you can see the lesions. It is very clearly seen on cholangioscopy with very high quality images and under vision you can take biopsies. The morphological features are nodularity and branching and tortuous vessels. They are highly suggestive of malignancy. So biopsy already we have seen if you compare ERCP brushings, ERCP guided biopsy and cholangioscopic guided biopsy, definitely cholangioscopy assisted biopsy scores over other methods as far as diagnostic yield is concerned. This is a simple classification given for assessment of lesions on cholangioscopy based on form factor, that is the appearance of lesion, and the vessel factor, whether the vessels are dilated or undilated, irregular or regular, and whether they are tortuous or non-tortuous. Now, other advanced tissue acquisition and novel diagnostics are US, FNA, and FNB, fine needle biopsy. Intraductal US, it is available in very few centers, very expensive. Confocal laser we will be seeing later. Liquid biopsy, uh, it shows promise in the future, but not yet standard of care at present. Now, USFNA or FNB, it allows high resolution imaging of biliary tree and it has got a very good sensitivity. It is better for distal cholangios rather than proximal cholangiocarcinomas, and it is superior to MRI and CT for smaller lesions. And it is an excellent tool for nodal staging. 1 week back, we had an elderly lady who presented with short history of jaundice and weight loss. LFT showed cholestatic pattern with elevated CA 19-9. Multiphasic CT was done which showed interliminal soft tissue density in distal CBD extending 1.2 centimeter proximally from ampulla. In this patient, we took brush cytology and put in a stent. The brush cytology came out to be positive for malignancy. In this patient, we took her for ultrasound just for staging, not for biopsy, because we already had tissue diagnosis. And you can see beautifully this EOS image. There's a infiltrating, ductal infiltrating carcinoma growth at the lower end of the bile duct. The lymph nodes were negative, so the lady is practically, the lesion is resectable. We are planning her for surgery. Confocal laser endomicroscopic, again, evolving method. It has a beauty in the sense that in vivo you can assess histology in real time. It is available in very few centers. So key take home messages are: whenever you suspect distal cholangiocarcinoma, a patient presenting with painless jaundice, immediately you have to activate your team for further assessment of the patient. And there is no best endoscopic test. The optimal strategy is the right test at the right time. ERCP and EUS are complementary. One provides drainage if required and ductal sampling, and the other excels at mass diagnosis and staging. Cholangioscopy has come out to be a very good modality in diagnosing these patients in the last 10-15 years. And under vision, you can take very good quality specimen for histopathology as well as for molecular profiling. So the future of endoscopy is precision oncology. Our responsibility is not merely to prove malignancy, but to obtain good quality tissue with proper molecular profiling that enables personalized treatment in these patients. Thank you.
Any questions from the panelists and the audience?
Sir, as a medical oncologist, I would like to know, uh, most of the times, like we discuss this with you, most of these cases are challenging because in Chhattisgarh we see patients, they have advanced disease. So, though on the scan it look for our medical people that whenever patient is in obstructive jaundice, we always feel कि stent हो जाएगा, PTPD हो जाएगा. But most of the times, this procedures are very challenging and difficult. So when you're performing ERCP and then you're not able to get the stent in place, so what challenges you face, and in those scenarios, what new is happening so that whether your stents are getting better or the technology is getting better, so that your outcomes in this obstructive jaundice via endoscopic approaches get better.
Excellent question. These patients, you are right, they present quite late, not in our region only, but across the globe, their presentation is late. So, in distal cholangiocarcinoma, statting usually doesn't have much of a problem. The actual problem arises in perihalar malignancies, where multiple ducts are involved. Here, selective cannulation is sometimes important if you are doing it fluoroscopically. So in these patients also, as we have seen colonoscopically, you can identify different ducts, left, right duct, and even secondary branches you can visualize. And selectively, you can put in a wire in the desired duct and you can stent them. In unresectable patients, usually metal stents are preferred, but in resectable patients, the usual recommendation is to put in thin plastic tubes uh, percutaneously. PTBD is the choice in resectable patients. And other recent advancements, when you have to fail on your routine ERCP, another modality is EUS guided puncture of left hepatic duct and put in a state, and you can have a hepaticogastroscopy. So that is another way of training these ducts. A very pertinent question, sir. Usually up to 15, beyond 15, the surgeons are more comfortable with stenting. Bilirubin above 15. So above 15, we have to stent them. And secondly, if they are having cholangitis, then even before 15, if they are having cholangitis, even before at lower levels, we would like to stent them. And secondly, the second part of the question was at the same sitting, we have to take uh, biopsies and brush samplings. And diagnostic ERCP, only diagnostic ERCP is not recommended because we can introduce infection in these patients. So whenever decompression is needed, that is the time, that is an indication for ERCP, and at the same sitting, we will do sampling. And if you have cholangioscope, same sitting, we can put in a cholangioscope, and under vision, we can take biopsies.
One question from me, sir. Sir, there are certain patients where, let's say, there is a scenario where the patient has undergone an upper abdominal surgery, let's say Roux-en-Y gastrojejunostomy, where direct access to the ampulla of Vater will be difficult, or you cannot put a scope. So, as a oncologist, to confirm the diagnosis, what will be your options in these patients?
Two, three options are there. Either you can use a single balloon or double balloon enteroscope to approach the papilla in these patients. And once you approach the papilla, rest of the things are similar to ERCP. Or you can assess these lesions using endoscopic ultrasound also. In under endoscopic ultrasound vision, you can have staging involvement of lymph nodes at one hand, and on the other hand, if the diagnosis is in doubt, you can take samples also.
Sir, I had one question, sir. Sir, often we see patients where there is a distal narrowing. We do brush cytology, it's negative. We do EUS, it doesn't look like malignancy. So we just put a stent and come later. Often this patient present 1 year later with a advanced malignancy. So how you follow up this patient? Do you subject them to repeat brush cytology, or do you do a repeat cholangioscopy? Because cholangioscopy is quite costly. We don't do for every patient. So how you follow up such patients, sir?
A very good question again. This is a separate entity. Ms. Kautuk is asking is the entity of indeterminate biliary strictures, where you don't have full features of malignancy or so in these patients you have to keep them under close surveillance, and 3 monthly or 6 monthly you can reassess them by doing tumor markers and by doing cross-sectional imaging.
Thank you, sir. I request the chairpersons to felicitate sir.
I request Ravi Jaiswal also please join for the felicitation. Next round.
For the next session, I invite Dr. Sonal Asthana, Clinical Lead Hepatobiliary Sciences and Multi-Organ Transplant Surgery, Aster Integrated Liver Care Group, Bangalore, for current treatment landscape of HCC.
For the panelist, I request Dr. Deepak Purohit, GI surgeon from Raipur, Dr. T.P. Sahu from Bhopal, Dr. Ankit Lalchandani from Raipur, Dr. Hitesh Dubey, GI surgeon from Ramakrishna Care Hospital, Raipur, Dr. Ajit Mishra, GI surgeon from Raipur, Dr. Pushpendra Nayak from Raipur, Dr. Prashant Pote, Dr. Ripu Singhal, Dr. Vivek Mahavar, radiologist from Ramakrishna Care Hospital, Raipur, Dr. Puneet Seth from Raipur, and Dr. Manish Lunia, gastroenterologist from Raipur. Over to you, sir.
Good morning, and thank you to Dr. Jaswal, Dr. Dave, and the organizers of OncoSphere for this invitation. It's always a pleasure to be in Raipur. I was here last month and discussing HCC as well. But I'm very mindful that this is a different group and a different audience. So hopefully we'll delve a little bit more into the oncological aspects of HCC with the fantastic panel that we have here. These are my appointments. I do not have any conflicts of interest at this time. So these are the panelists, and this is a very good mix. And perhaps this is the first message that I'd like to bring forward, that this is not a conventional tumor board that we normally see in oncology, where we are talking about TNM staging and only radiation oncology, oncological medicines and surgery. We have to consider a lot of liver physiology, which is an integral part of the treatment for HCC as well. So HCC is rising in India and across the world. The incidence has broadly mirrored hepatitis B across the world. But of late, we know that HCC is being driven by non-serological factors as well. And this is being primarily related to metabolic syndrome and diabetes in our country. And the reason why this is important is that, in all other cancers, we know that we've actually got substantial gains in mortality in the last 20 years or so, except for very, very few differences. In liver and bile duct cancers, what Dr. Pandey was talking about, melanoma and esophageal cancer, these are cancers where we are not winning per se, but we still have an increase in mortality with our current forms of treatment. This is very important in India right now because the reasons why we are developing liver tumors are changing. It's less because of hepatitis B and C, but mostly because of metabolic syndrome. We know that mast-cell alcohol is rising. Most tumors are diagnosed at an advanced stage, and we don't have any systematic surveillance so far. This is probably the biggest reason why HCC is rising right now in India, because this epidemic of diabetes that we have a large number of people with diabetes, and diabetes itself is a risk factor for the development of HCC. So why is HCC different? When we're talking about a tumor, we are talking primarily about making sure the tumor is well treated with the margins, etc. But here we have to deal with not just the tumor, but the damaged liver as well. So the factors that we look at are the liver, the hepatocellular damage, as well as portal hypertension. So there are different modalities of treatment, and to make it easy, I've actually used the Dhurandhar team to understand this. You can actually burn a tumor either by RFA, microwave, or SERT, for example. You can cryoablate. You can use it. You can use resection or transplantation, which is the only curative treatment. And then, of course, you can poison the tumor when you're using either systemic therapy or immunotherapy. So again, to simplify it, because we are surgeons, we are very simple people. You can have a good tumor in a bad liver. You can have a good tumor in a good liver. You can have a bad tumor in a bad liver, or a bad tumor in a bad liver. And this, unfortunately, the second part, which is BCLC-D, which we'll talk about, is the most of the tumors that we have. Most tumors present to us with advanced liver tumors in a very, very poorly cirrhotic liver. So we don't have a lot of treatment options. However, when the tumor presents to us in a liver function that is well preserved, then we can potentially downstage these patients and treat them well. With this background, we're just going to start a little bit about cases. So this is a patient who is a 55-year-old male. He had hepatitis B-related cirrhosis, good performance status. AFP is a little bit high, 420. Well-preserved liver function, bilirubin of 1.1, platelets 95,000. The imaging shows a 4.2 centimeter lesion. So is Dr. Vivek here with us? Vivek, I just wanted to get your opinion on if you could read out the
Yeah,
4-phase CT that you can show here.
this is a patient with hepatitis B virus infection, and this lesion on the arterial face showing arterial non-rim type of enhancement, followed by a washout on the venous and delayed fate and thin capsular enhancement. So, in this patient with HBV virus in the positive patient, this should be categorized as LARAT 5 lesion, and directly should be taken as HCC. No need for biopsy in this patient, in this kind of patient.
That's you answered my next question actually.
Okay,
So
sir.
now can we diagnose hepatitis HCC just using imaging alone?
Yeah.
So using triphasic CT or MRI. So probably the first message that we don't need to biopsy all these patients in order to start systemic therapy, which is something that a lot of our oncology colleagues sometimes struggle with actually. And which do you prefer? What is the preferred modality of treatment? Is it CT or imaging, CT or MRI?
So if the patient is cooperative, we can do good respiratory getting. Then we usually prefer MRI. Otherwise, CT will also suffice in most of the patients. But in few patient when we are not very sure about the lesion, sometimes they say LRTIV lesion, we are not sure about the we cannot see very in the CT scan very precisely. Then we can go ahead with the MRI, sir.
Sure. So you had mentioned lyrides. I just want to get directly into that. Could you expand on that a little bit for our audience?
Yes, sir. Lariat's categorization is first thing is that on Lariat, 5 categorizations can be given only to the lesion who are more than which are more than 10 centimeter in size. No lesion less than 10 centimeter size could can be given the category of Lariat 5, and they should have the non-rim type of arterial enhancement. And if along with that, if there is a one feature of one major feature of peripheral non-rim type of a washout or capsular enhancement or threshold growth, then we can categorize accordingly to the LR5 category to that kind of the lesions.
Yeah. So basically, based on the degree of certainty of whether it's tumor or not, you can categorize it from 1 to 5. One being definitely benign.
One is
and
one is
5 being
benign.
malignant.
Yeah, one is definitely benign. LR2 is most likely benign. LR3 is of intermediate category. LR4 is most likely HCC, but LR5 is definite HCC, sir.
Just a point here. I'm a medical oncologist because you put forward a point that oncologists, why do they insist on biopsy?
Sure.
So there's a science to it and there's the evidence to it. So point here is whatever data we have as medical oncologists on systemic therapies has been based on all the trials had as histological biopsy proven. Point one, point two, if you go back to the data set from UK, when they did a retrospective analysis and proved that who were radiologically diagnosed as SCC, they found, not surprisingly, but 10% had intrahepatic cholangiomas. So
Yeah.
point to be made here is still we are not giving a systemic therapy. And we all appreciate that SCC, if you are doing a local therapy, local regional therapy, we also don't insist that you do a histopathology till you have a classical picture as told by the radiologist here. But once it comes to domain of a systemic therapy, we are somehow looking at these two data set. One, the trial evidence, everyone has done a histological proven. That's the inclusion criteria. Two, 10% will be in cholangio, and especially a lot of the non-oncologists do not do CA 19.9 as a marker, which they should always do. Once you have a SCC like thing and CA 19.9 is high, then you are more likely to do a biopsy that then you might be dealing with intrahepatic cholangio. So there are a few nuances which I thought I'll put it forward. Not that
No,
we
thank you. I mean, you've jumped ahead because immunotherapy is one of those things that is a little bit different now.
not only
Depends on-
immuno, even for sorafenib and lenva, the trials included that as an inclusion criteria to have histodiagnosis.
Okay, I mean, we'll come into that. There are certain reasons to do biopsy, but I would say that diagnosis is not one of them.
Sir,
Right.
actually,
So right now, like if to develop in it, this question, please jump in. It's for everybody. Where do you think PET scan fits into the diagnostic criteria for HCC right now?
no, sir, I don't think so. For the diagnosis of HCC, only triphasic CT and MRI is needed, sir, to make the diagnosis.
Okay. So I think that as you correctly pointed out, firstly, to diagnose HCC, probably you do not need a biopsy with high degree of certainty with a 4-phase CT. You cannot, while PET scans aren't very useful for diagnosis of HCC, they're useful for staging metastatic dissection if you're evaluating treatment response and prognostic recurrence. So a positive PET scan is useful, a negative PET scan does not rule out a tumor. So it's not a diagnostic tool. But that being said, now with newer research that are available. FAPI PET, for example, can sometimes diagnose tumors that have not been picked up on FDG. And very recently, we did a GPC3 PET. This is one of our patients who was negative on all other PET scan and even on a CT scan, a 4-way CT scan. And we were able to pick out a tumor on GPC3 because the only thing that he actually had was an elevated PIF. So, next question is for Deepak. I mean, how would you stage this patient? And like when you're looking at this patient, we talked about TNM earlier on. Like, what else would you look at to stage this patient?
So Dr. Deepak is not here, so I'll answer in his behalf. So this patient has child's A, BCLC. I would say it should be placed around somewhere around A. Looking at the size,
It's early tumor.
guessing at the size, less than 5 centimeters. I think I would put it in BCLC A, and again I would further certified as having portal hypertension clinical significant. Platelet counts are less than 1 lakh, which is very likely having a portal hypertension clinical significant. So probably the best line of treatment would again go towards a transplant rather than a resection in this patient.
Sure. No, very nicely done. I think you've picked out a lot of those different aspects that you need for staging these patients. Of
Yes.
course, you know, all oncologists are familiar with the child stage. We all studied this in medical school. And this is still a very, very useful mechanism of some rule of assessing liver function, so to speak. Child A being the best and child C being the worst. And this helps you to plan therapy. There's another score that most hepatologists and liver specialists use called the MELD score, which basically assesses the severity of cirrhosis. Now we are talking about severity of hepatocellular dysfunction, not about portal hypertension. So the worse the MELD score, the worse the child score, that tells you that the liver is not very good and it will not tolerate the therapy that you have. I'd like to take this forward. Anybody else about BCLC? Who, who, who would like to take this? Probably Dr. Mishra, would you like to speak about that? Hitesh?
Sir, BCLC is a staging system which gives us an idea about how we can proceed once a tumor has been diagnosed as SCC. So it's basically divided into very early, intermediate, advanced, and terminal. And depending upon the performance status, depending upon the portal hypertension, depending upon the bilirubin, the therapies has been directed because and the number of the tumor, size of the tumor, and metastasis and how infiltrative they are.
Sure.
So basically, if it is very early, the choice of the therapy lies between the ablation and resection. And if it is early, it's further we can the have to assess for the transplant workup has been done. If it is undergoing, if it's suitable for transplant, we do the transplant. Otherwise, the other therapies like ablation is followed. If it is advanced or terminal, then if it is advanced, then we have to proceed for the immunotherapy or TKIs. And if it is terminal, then it's best supportive care. So it's basically prognosticates and gives an idea about how we should proceed if the tumor has been diagnosed in SCC.
Sure. Thank you. I mean, the main advantage of the BCLC is, like you say, it combines both the tumor stage, the liver disease, as well as prognostic and therapeutic mechanisms that can be used for the particular stage. So this is very useful. Of course, we have a modification for India as well, which actually takes a little bit into account the kind of tumors that we see. We see large tumors which are non-cirrhotic, which may be resectable, and it also recognizes that these tumors can be stepped down potentially a transplant later on. Um, I mean, this is the question I'd like to sort of open out to everybody. I'll start with you, sir. Uh, what are the markers that you normally use in your practice?
So mostly the baseline what we do is alpha beta protein, and then if it is negative, then we always add PIVCA for the diagnosis. TCP we don't use it quite frequently.
Sure. I think one of the important things that Sir pointed out was that the CA19-9 should be done because there is a small proportion of patients who have a mixed tumor as well. And sometimes that can impact the efficacy of the treatment that we particularly use. Now, of course, biology is a very, very funny thing. We try to use, now we will introduce another element. We've talked about the TNM, the stage of the tumor. We talked about the liver, but we also want to see whether tumor is biologically aggressive or not. Fortunately, biology differs mechanism depending on how you use it. For a lot of our patients, for example, AFP is not positive. India has about 40% non-secretaries of AFP as compared to Western literature. So there are a lot of markers of poor biology which have become a little bit more relevant now. Now that we have trials of immunotherapy that are coming out as well. Thanks a lot, Priksha. Now coming to the big question, how are we going to manage this question? So we'd like to ask the surgeons as well as the IR people on what they think about this.
Sir, I would be speaking from the surgeon's perspective. So this is a child's A. Tumors likely less than 5 centimeters, solitary tumor. I would like to see the AFP as well in this case. Just to
AFP is 400.
400 borderline, I won't be going for a PET as of now. I think this patient can, we have to discuss the pros and cons of resection versus a transplant with the patient, because this a borderline case. It's not completely fitting for towards transplant, not complete towards resection. He has the factors to go for both these modalities. So I would discuss with the patient first, and probably I would still, if transplant is feasible, that should be a more favored modality, keeping in mind the clinically significant portal hypertension.
So, is Dr. Prashant here from IR? I have.
Yeah, I can talk it from here. So, if surgery is feasible option, that should be given a first chance. And if surgery is not feasible or somewhat risky, or patient is not convinced that it will benefit him, then we can offer tests with addition of microwave. Ideally, these patients benefit if we give combination treatment rather than selectively going for a test or selectively going for microwave. We definitely not using RFA because of some heat sink effect,
Sure.
but it will be the better choice. First, let's go for test, and after waiting for a 1 month and some size reduction, we can go for a microwave session.
So, just for
even
the
as a
purpose of
medical
discussion, for this patient, for example, let's say the performance status was poor,
Yeah.
right? So that's the reason why we are not going in for a surgery or transplant. So, like now you have a lesion that is approximately 5 centimeters in size. So, what would you prefer? Would you prefer a TACE or a microwave initially?
For microwave, size criteria is nearly 5 centimeter. So we may require to use two antennas in one session, or one session followed after waiting for 2 weeks or 3 weeks. We can go for second session, because size criteria, it comes as a borderline. 5 centimeters is just a borderline for microwave that's going towards test.
Sure. So you had a point.
No, no, it's okay. He spoke. I just told that this patient would be a case for a transplant because of the cirrhotic liver more so. Number one, if that is not done, although the 3 centimeters is the classical, but people have gone to higher sizes, especially the Chinese and the East Asians.
Sure.
So that's why the transplant is number one. Number two, resection, probably I would be putting the IRs way back in the third position for this patient at least.
Okay. I think we'll probably agree to disagree on that, because that's a little bit of a sweeping statement, to be honest. So, I mean, TACE, of course, there are some absolute contraindications. There are, places, for example, if you have a very advanced chance disease or if you have extensive PVT, these are places where you could not use it. These criteria vary a lot by technical expertise as well. And there is fairly good evidence that TACE can be useful. There are some advantages, like we already discussed. TACE can be combined with other modalities of treatment, and it can be used to bridge or downstage treatments as well before we actually give any definitive therapy. And that's basically what we did with this patient. We talked a little bit about microwave already. Suraj mentioned. I think that the data would support that if you had a smaller tumor, about 3 centimeters, probably microwave would be as good as a resection, especially in patients who have a poor performance status. This is data that has come out quite recently, and this is burnout. So if we actually combine the data for early stage, let's say, that is BCLC A and B, we can see that patients can either get a TACE, a microwave. You can think about a transplant if they're downstage, and even a resection, although resection has a higher rate of recurrence. We'll just move on to the second patient, which is a bank executive, had upper abdominal pain, unhealthy lifestyle, LFT was normal. I'm going to take Dr. Vivek's help again to talk about this particular tumor.
Uh, this is a ill-defined lesion uh, extending into the right branch of portal vein. Extending into the right branch of portal vein, and probably also in the left portal vein. And total vein thrombosis, this could be a multicentric HCC.
Yeah. It's a
Most
poorly
likely.
differentiated
Poorly differentiated, yeah.
tumor, etc.
Yeah.
That's going in. So, what are the modalities of treatment? I mean, I can start from sir at the other corner there, just to involve. So, would you like to say something about how?
Total vein tumor thrombosis, and right now he's having unhealthy lifestyle and performance status is not that good. So for portal vein tumor thrombosis, I will give SBRT to the tumor first, and if and tear if he's approachable.
It's multicentric. Multicentric
So we
HCC.
do low
Poorly differentiated
Yeah.
tumor.
Multicentric.
Yeah, more in the right lobe.
Yeah.
With the
So my point is, in such a tumor, multicentric, where do you have a level one evidence for what we are speaking through? In contrast, there is a level one evidence which was published 6 months back, read out first time, Atizo-Bev versus local regional therapy, and it has way down shown that local regional therapy in this category of patients is inferior to systemic.
There is no phase 3 trial as such. I mean, for this case.
It's a phase.
Also,
It's a phase 3 ABC trial.
Okay.
Okay.
So, I think that if you had shared the slides yesterday, we're just going step by step because I want to bring out certain elements of what we discussed. So, you're absolutely right that systemic therapy, I'm just coming to that because that's my next slide. I'll be talking about immunotherapy as well. So, when we talk about the regional therapy here, if we sort of talk about perhaps a tumor that is limited to one aspect of the liver, which is poorly differentiated, not very well defined, and involving the PVT, where would you prefer SBRT over TARE, for example? Hitesh needs to raise that point.
Sir, I will prefer SBRT mostly if it is a tumor having portal vein tumor thrombosis. Then I'll mostly go for SBRT. And if the tumor is if the size of the tumor is very large, then I will prefer firstly tear in that case scenario.
I mean, I will not prefer SBRT in this case. I mean, I prefer higher dose, and for that I need ablative dose, which is more than 200. So,
Yeah.
and because it's a resistance kind, and we have to spare the normal liver too. So, I will prefer transarterial radio embolization, which is personalized dosimetry where you give higher dose.
Sure. That it's very interesting that you say that because this is quite a controversy right now. Here is definitely a better situation when it comes to an intrahepatic tumor. And now with the newer tear regimes, we are able to deliver a large amount of radiation. And you can actually do radiation lobectomies. The legacy study actually had almost up to 400 days delivered locally. So when we talk about extrahepatic portal vein, for example, SBRT becomes a little bit better as opposed to and if it's a focal localized tumor, SBRT might be a little bit better. But tear is one of these options as well, and there's some trial on this as well. Now we come to the systemic therapy that Sir was talking about. Of course, this is something that is new and perhaps is pervasive and is currently first line as well. Atezolizumab is one of the things that we talked about, and nowadays we know that almost every stage of hepatocellular carcinoma can benefit from this as well. This is the data that we were talking about. I haven't included data on the Nevo IPU trial, the checkmate trial as well, which also is a new standard. So the current three regimes that are approved are Atezobev, Durva-Tremi, as well as Nevo IPI. So the key questions here are, firstly, is sorafenib or TKIs, are they still relevant in 2025?
This easy answer is no. For the afford patient who cannot afford, that's their go-to drug. Still, I would not go for sorafenib. I'll go for lenvatinib, which has a much higher response rate. And sorafenib is something which I will not even be okay with those who are not affordable. Lenvatinib cost is less costly. The important is, I was speaking that time of the trial, which was not this what you're speaking of. This is a totally stage advanced disease extrahepatic. This is a totally different trial. So number two, coming to this part of the Atezo-Bev versus Himalaya, people have to differentiate that there were few classical characteristics of Atezo-Bev, means they used patients with portal vein thrombosis, which IO-IO combination the Himalaya did not have. That's point one. Point two, you don't see larger responses. The responses are more common and larger, bigger in Atizobev compared to Himalaya. But in contrast, the Durva Tremi has shown the OS benefit, which the Atizobev trial has yet not shown. So there are subtle differences to this to the drugs. But yes, my own single TKI should be Lenva. Sorafenib can be still relevant, but it has shown to be an inferior protocol, and patient who cannot afford or Lenva has some toxicity, then only go for sorafenib.
So for this patient, would it be Atozobev or Durvatremi?
For this, it will be Atizobev for that patient, what you showed me, because the trial at this point. But if it is considered inoperable and you cannot go ahead and do any local regional therapy, then you can choose any one of them. But because the thrombosis were there, I will go for Atizobev as my number one choice.
Yeah, just going to run over a little bit. Sorry about this. Yeah.
2 minutes extra. That's enough.
Oh my God. Okay, I'd better get on then. Actually, so the question is that perhaps I can ask you on how would you sort of select the patients? How would you prep patients to give them immunotherapy?
So before starting any immunotherapy or anything, first we have to see whether there's decompensated liver disease or not, like upper GI endoscopy, and we have to rule out varices or not before starting the Atizobev. So if it's not there, of course, Atizobev will be the first choice. Also, we have to look for the autoimmune diseases, because if we'll give IU, there are more than like 40-45% of chances having severe toxicity due to the autoimmune diseases. Lowest will be with the stride regimen, but we'll still prefer Atizobev if there's no contraindication to the.
The next question was what Sir had talked about before. How would you time therapy sequentially? Would you give regional therapy and systemic, or is there any benefit to timing it that way?
I will
Okay, please.
prefer, sir, systemic therapy only for this patient.
I want to just pitch in because we are talking of two different trials and talking of the same setting. So these trial which are speaking of stride and the Atizobev were considered patient profile who were considered not eligible for any regional or IR modality. So people have to understand that versus the case which you showed us was somewhere in between. That is where I told that the only one trial has shown the benefit of systemic therapy in this multicentric so-called B, higher Bs and C. So this is what I'm speaking about. In this, what you're talking about, Atizobev versus the Himalaya, is totally a different patient.
About this patient, in this patient, suppose you had an option of tear with immunotherapy or immunotherapy with tear, how would you sequence your therapy?
There is for tear plus immunotherapy, there is no larger trial as such. There is only trials for TACE with immuno and anti-VEGFs. But that profile is very different from the patient profile which you showed. These are B only. And the B only, you have Emerald 1 and the Leap 012. There are two trials. And two things come out of it that these are traceable lesions. And this should be first criteria, non-metastatic or non-extrahepatic. Then the point is you can add the immune checkpoint plus anti-VEGF. The timing of the anti-VEGF is very important and tricky here. First, you do a TACE and immune checkpoint. So TACE them. After 7 days, start immunotherapy. That's what the protocol is. TACE it till 4 cycles max, not more than 4 TACEs in 16 weeks. And then BEV is started after the whole TACE protocol is over, because the TACE brings out the anti-VEGF more, and that's where the BEV starts.
Sure.
And that is where the advantage is.
So the point again I was making is that a lot of TACEs and tears will create new antigens and actually potentiate immunotherapy. So rather than going to specific protocols, that's basically what I was trying to do.
Excuse me if I can pitch in, if it's allowed. So, taking forward the same discussion, talent case study is there, which is a phase 3 trial, where there is an on-demand test. So regarding your question, where to sequence, it is probably flexible now with the atezolizumab and bev regimen.
Sure.
Either you can start with it and later you can introduce systemic therapy, or the much better approach would be, as Dr. T.P. Sahu mentioned, first starting with the systemic therapy, and then if the lesion becomes traceable, then you can intervene over that. So there, atezolizumab bev is good. And the other thing, the last question, I think those patients who have an increased risk of bleeding, that is where probably one would not think of atezolizumab bev and go for the dual IO regimen.
Thank you. That was the point that I was trying to make.
Point, if Ravi allows, the people make it a point that once there's esophageal varices, you do not give atezolizumab. That's not what the criteria is. Once you have varices, treat the varices, make it stable for 4 weeks, and then you can start.
So I'll just move on with the interest of treatment because I'll probably have to end here. We could not get to resection, but downstaging to liver transplant is one question here. Essentially, I'll just present one case here because immuno is. I was actually worried about this because immuno is such a swamp right now that it is very hard to get out of discussions, and there are many things that would go here. So I'm just going to go through all of this. Essentially, you can transplant patients with tumor. Milan criteria is what we use. You can extend the criteria beyond Milan, but there's obviously a price to pay for that. So we use something called the metro ticket. Patients can be transplanted either for tumor or for liver failure. You cannot offer transplant to patients who are extrahepatic disease. And I would probably again add one more point that SBRT is something that is underutilized right now and something that we should probably utilize a little bit more. So key controversies right now. Sorry about the timing, guys. But local regional therapy, TACE and TARE. If you look at a head-to-head comparison, TACE is a very useful therapy. We can use systemic therapy pretty much everywhere in BCLC A to D. You can downstage patients, although downstaging to resection is not proven, but the transplant is actually very well proven. Resection versus transplant, it should be determined by local requirements, etc. Combination therapies, TACE plus immunotherapy, we have discussed Emerald and LEAP. TARE plus immunotherapy, right now there are trials, but we do not have evidence yet. Of course, there is a lot of evidence on biomarker-based selection. We know that surgical innovation will play a part. Now with robotic and minimal invasive surgery, we can actually prevent patients from decompensation, take on patients who are a little bit sicker as well. So take-home messages, essentially surveillance is important. We should look at all of the liver function before we start treatment. We can look at the kinetics of biomarkers in order to assess our treatments. For transplant surgeons, of course, you can downsize these patients into transplant. Surgery in terms of either resection or transplant is the best therapy. LDLT can be done in our settings because we can actually time it very well. We've talked a lot about the oncological parts. I think that these are parts that are unfortunately or they're still evolving to a large extent. I must say that our immunotherapy response has not really been as good as has been reported in the literature because the metabolic HCC's response rates are about 10 to 15%. So, I'll just conclude that every HCC patient needs a multidisciplinary board which is larger than what we currently have. We don't need only surgical, medical, radiation oncologists. We need hepatologists. We need transplant surgeons in the team so that we're able to plan this better. And of course, while we have guidelines, the treatment needs to be personalized. Thank you so much.
Thank you, sir.
May I just have one comment, sir?
Yeah.
Sir, as a medical gastroenterologist, there is something I would like to add to it. The mast can have SCC without cirrhosis.
Yes.
When we are sitting on the epidemic of mast, probably if OncoSphere 25 will happen, we will only talk about SCC in mast. So it is very important that in the mast cell patients, even without cirrhosis, we look for SCC, early detection. So 6 monthly alpha fetoprotein and looking for SOL, dedicated sonography for SOL should be done. Because unfortunately, right now we see patients with the child class C and hepatocellular carcinoma, and there's nothing much we can do for them. So I think at this point, early detection of SCC is very important.
You're absolutely right. And unfortunately, I had to skip through the slides of resection because I think that resection is a bigger part of HCC management in the Indian population as compared to Western populations because almost 40% of the cirrhotics of the HCC that we see are in non-cirrhotic populations. In the West, HCC is predominantly a disease in cirrhosis, but it is not our experience. So we resect a lot more than is reported in the literature. You're absolutely right.
Thank you, sir. I request our panelists, please felicitate our moderator, Dr. Sonal Asthana, sir, with a memento, with big round of applause to all the panelists and our moderator. And I request all the panelists and speaker, please collect, chairpersons, please collect their mementos from memento podium which is just outside of the hall. And I request Dr. Rahman sir, he is a senior physician, HOD of Internal Medicine, Ramakrishna Care Hospital. Please felicitate with mementos to our panelists and chairpersons. Now we move to our next session.
Our next session is a new era in managing resectable gastric cancer with deflot regimen. And I invite Dr. Kshitij Dumadia, consultant medical oncologist and unit head at CG Cancer Center, Ahmedabad. There has been a change in the session. So the next session is evolving paradigms in treatment of gastric cancer and biliary tract cancer from evidence to clinical practice. And I invite Dr. Madhvi Indani Mohta, consultant medical oncologist, KIMS Kingsway Hospital, Nagpur, Maharashtra.
To chair the session, I would like to invite Dr. Manjula Beg from Raipur, Dr. Prashant Kaser from Raipur, Dr. Sabah Siddiqui from AIMS Raipur, Dr. Kesar Salim sir, senior physician from Raipur. And I request Dr. Arif Memon sir, please join the dais as chairperson. Dr. Shyam Sharma sir, please join the dais as a chairperson. As we are running short of time, please start your deliberation. Over to
Good
chairperson.
everyone. It's an honor to be a part of OncoSphere 2. So today I'll be discussing about the evolving paradigms in the treatment of gastric cancer and the biliary tract cancer, from evidence to clinical practice. I'll just go through the gist of it. So discussing about the gastric cancer first, we'll understand the disease, the burden, the current treatment landscape, role of pembrolizumab, and key takeaways. So we know that gastric cancer remains a major health challenge worldwide, with nearly 1 million new cases annually, contributing to more than 6.5 lakh deaths. It is a heterogeneous disease with most of the morphology being gastric adenocarcinomas, and there is a rising trend for the early onset gastric cancer among individuals less than 50 years of age. We know that there is a marked geographical variation in gastric cancer. We know we have higher incidences in Japan and Korea and increased incidence in India as well. So the major risk factors include modifiable and non-modifiable risk factors. In the modifiable, we have smoking, alcohol, coffee, obesity, red meat consumption. In the non-modifiable, we have genetics, family history, age, sex, blood group, diabetes, and other factors. So mainly the classification for gastric cancer and gastroesophageal cancer can be in various subtypes. Anatomically, we say it's a gastroesophageal junction versus a gastric cancer. Histopathology wise, 95% contributes to the adenocarcinomas. Apart from that, we have lymphomas, myeltomas, carcinoid tumors. Then we have the molecular classification, which we'll be discussing next. And then we have the TNM staging. So mainly two types when it comes to the adenocarcinoma. We see the intestinal types gastric cancer, which is mainly driven by chronic gastritis following atrophic gastritis, following intestinal metaplasia, and then leading to intestinal type gastric cancer. While when we see the diffuse type, which are the aggressive tumor, these are mainly driven by the TP53 mutations and E-cadherin mutations. So molecular subtype, according to the TCGA 2014 analysis, we have main four broad categories: the EBV associated MSI high tumors, genomically stable tumors, and the CIN type. Of these, the EBV type and the MSI type, they have high immunogenicity with high PDL1 expression and a better prognosis as compared to the genomically stable and the CIN type. So, in going for the burden of gastric cancers, we know that it is fifth most common cancer with one of the highest mortality rates. When we go to the treatment, when we see the stage 1 disease, they can be endoscopically resected and surgical resection is preferred option. While in stage 2, stage 3, we prefer a perioperative approach with flot, deflot, or a adjuvant chemotherapy based approach. And in stage 4 disease, systemic therapy is the backbone. So, when we see the survival around HER2 negative diseases continues to remain, have a very low survival of less than 12 months with chemotherapy alone, and 30 to 50% of the patient has to receive the second line chemotherapy. So we have emerging targets in gastric cancer. We know that 50% of the gastric tumors are PD-L1 high tumors, have very good responses to immunotherapy. Apart from that, we have targets like HER2, FGFR, for which we have targets available. Also, we have CHOP2 TIGIT inhibitors, and the landscape is still evolving. So, the rationale for the use of immune checkpoint inhibitors, we know that the tumor cells exploit the immune checkpoints like PD1, PDL1 to evade the host immune surveillance, and we can restore this immune activation by the use of immunotherapy. There is a blockade of PD1, PDL1 inhibitors causing tumor cytotoxicity. So, treatment guidelines NCCN recommends in the first line treatment chemotherapy with a backbone of immunotherapy in patients with PDL1 expression of more than one and HER2 negative gastric cancer. ESMO also recommend use of pembro with chemo in patients with CPS 5 and can be considered in CPS 1 to 4. And Pan Asian ESMO adapted guidelines also recommend the same. So, going for the Keynote 859 study, indication of pembrolizumab is first line and locally advanced unresectable metastatic HER2 negative gastric cancers with CPS more than 1. We also have this evidence in HER2 positive tumors with PDL1 more than 1. So the Keynote 859 study, the eligibility, it is a randomized double-blind phase 3 trial in which patients with a histology of adenocarcinoma of stomach or GE junction were included with a known PDL1 status of more than 1. Patients were randomized 1:1 in pembro arm, which was pembro 200 mg IV 3 weekly for up to 2 years with a chemotherapy backbone of 5-FU cisplatin-based chemo versus a placebo plus chemotherapy arm. The primary endpoint was OS and the secondary endpoint was PFS, ORR, DOR, and safety profile. So as we can see, the baselines are well matched in the study. All the patients had a PDL1 CPS of more than 1. When we see the results, the primary endpoint OS, there was a median OS of 13 months in the PDL1 arm as compared to 11.4 months in the placebo arm. And in patients with CPS of more than 10, there was a median OS of 15.7 months versus 11.8 months, which was clinically and statistically very significant. When we see the PFS status across the PDL1, there was a median PFS of 6.9 months for the pembro arm versus 5.6 months in the placebo arm. And in more than 10 CPS, we had a median PFS of 8.1 months versus 5.6 months in the placebo arm. The response rates are also higher in the immuno arm as compared to the placebo arm. And we see the treatment was well tolerated with grade 3 to grade 5 adverse events almost comparable in both the arms. And treatment discontinuation was 26% in the immuno arm versus 20% in the placebo arm. So the key takeaways, we have a very good OS and a good PFS with pembro with chemo arm as compared to the chemo arm alone. When we see the biliary tract cancers, we'll go through the overview, the treatment landscape, role of immunotherapy, and the short summary of Keynote 966. So biliary tract cancers, majorly we divide it into gallbladder cancers, cholangiocarcinomas, and periampullary carcinomas. In cholangios, we have intrahepatic and extrahepatic cholangiocarcinomas. So we know that biliary tract cancers are rising more common in female as compared to males. Even in India, we have a very high incidence in the gigantic plain as compared to the rest of India. The common clinical presentation include weight loss, nausea, vomiting, jaundice, loss of appetite, hypochondrial pain, and a palpable lump in the right hypochondrium. So when we go for the workup of these diseases, we have to see the anatomical subtype. It is important to distinguish it because each of it has a specific clinical and a molecular features. So we need to know the anatomical subtype. We need to know the liver function of the patients, and the various imaging which can help us to do that is a CT scan, thorax abdo-pelvis to know about the distant meds, MRCP, MRI to know about the anatomy and the hepatic status of the patient, and a biopsy which sometimes can be difficult, but now with the advent of ERCPs, EUS, we have good access to the tissue sampling. So we need to know about the pathology and molecular diagnostics. When we go for the treatment of biliary tract cancer, we will have to see if the disease is resectable or not. If the disease is resectable surgically, we go for the surgical resection followed by adjuvant therapy. Adjuvant therapy in gallbladder cancer, as we know, in cholangiomas, and come from the BILCAP study where we give adjuvant capecitabine for 6 months. And in if the patient is not resectable, we will go for the systemic therapy. So adjuvant therapy, as I've said, mainly it comes from the BILCAP study, which has shown a survival benefit with capecitabine as compared to surgery alone. Systemic therapy, as per the ESMO guidelines, we know that if the patient has an advanced or metastatic disease, we should go for the molecular profiling for further lines of therapy. And we start the patient on first line gemcitabine plus an immunotherapy backbone, which mainly include pembrolizumab or the durvalumab backbone. And in second line, we basically rely on the molecular analysis of the patient. If the patient does not have any actionable mutation, we go for the backbone FOLFOX-based chemo. If the patient has an IDH1 mutation, we have ivosidenib. FGFR mutation, we have pemigatinib. BRAF mutation, we have DABDA plus TREM. HER2 expression, we have TRAS2-HER2 combination. RET fusion, we have selpercatinib, and so on. So, going through the Keynote 922 study, so we have already seen how the immunotherapy works, and they need no introduction for this. So, Keynote 966 was a phase 3 study of Pembro and BTC. It was a randomized double-blind placebo-controlled multicentric trial in patients with previously untreated unresectable biliary tract cancers, where the patients received chemotherapy, gemcitabine cisplatin with Pembro or placebo. In this case, as compared to the Topaz one, where gemcitabine was stopped, we see here the gemcitabine was continued until disease progression or toxicities. So the baseline characteristics were well matched in this study. When we see the overall survival in these patients at 12 months, there was a OS benefit of 52% in pembro arm versus 44% in the placebo arm. In 24 months, it was persistent 25% OS versus 18%. Hazard ratio was 0.83, which was significant. There was a PFS benefit with a median PFS was 6.5 months with pembro arm versus a 5.6 month with the placebo arm. There was durable overall response, and the duration of response was also well maintained in the placebo arm. So when we see this benefit was across the patients with PDL1 less than 1 and those with PDL1 more than 1. So the benefit, as we see in this forest plot, is irrespective of the PDL1 status. It was a well tolerated regimen, and the safety profile was as comparable with the placebo arm. So conclusion, adding pembrolizumab to GEM plus CDDP provided a significant statistical benefit and clinically meaningful OS as compared to GEM CDDP alone. And towards the guidelines, ESMO NCCN also recommends the same thing. Thank you.
Any question from the audience? Okay. I request our chairpersons, please felicitate our speaker with the memento. The next topic is a new era in managing resectable gastric cancers with D plus float. For this session, Dr. Kshitij Damodia, I request, please. He is a consultant medical oncologist and unit head HCG Cancer Center, Ahmedabad.
So, good afternoon, everyone. Say at the outset, first of all, two apologies. First, for being late, as if it was late, and second, because of the voice. And thanks a lot, Dr. Ravi, for the kind invitation. So, this is regarding Matterhorn. Okay, so gastric cancer It is considered to be as the seventh most common cancer and the sixth leading cause of cancer-related death. And if we look into the 5-year survival rate, still it remains poor, often less than 20%, primarily because of the late stage presentation and the limited access to curative treatments. Now, in resectable gastric cancer, as of now, perioperative chemotherapy is considered to be as the category 1 recommendation as per the all standard guidelines, be it NCCN or ESMO. Now, the problem with the gastric cancer is that many patients they experience disease recurrence post surgery, and there is a high unmet need, as mentioned in this chart, that about 60% of the patients they experience recurrence post surgery, and 43% patients they report recurrence within the first 2 years of surgery. So initially it was surgery alone. Next came the era of chemotherapy, and this magic trial did magic, where perioperative chemotherapy was compared against surgery, and perioperative chemotherapy improved outcomes versus surgery alone in resectable gastric cancer cases. And this was the landmark trial, after which perioperative chemotherapy became the standard of care in resectable gastric cancers. Next, the regimen which was used here was ECF or ECX based regimen. And next, FLOT4 study came in about 2019, where FLOT was compared against ECF or ECX as a perioperative regimen. And if we look into the results, perioperative FLOT did better than the conventional ECF or ECX based regimens in terms of the response rate, in terms of the overall survival, as well as the PCR rate. The median OS being 50 months versus 35 months with the ECF and ECX regimen. So after which FLOT became the standard or ECF or ECX based regimen as far as the perioperative chemotherapy was concerned. But there were issues with FLOT, especially regarding the toxicities part, and there were institutes where different modifications of FLOT were tried. As mentioned here, a modified FLOT based regimen in which the dosing was slightly reduced and the duration increased from 24 hours to 46 hours from the original study. And what they found was the completion rates increased from 46% in the conventional FLOT to 77% with this modified FLOT. So it became more tolerable, and patients were able to complete, more patients were able to complete treatments. This was a matched pair analysis published 2023 from the Tata Group. 593 patients. They compared modified FLOT versus EOX, and what they found was yes, modified FLOT had better survival outcomes with better safety profiles. So it all started from surgery alone, perioperative chemotherapy, ECF or ECX, went to FLOT, went to modified FLOT, and despite all these advances, still there was a large unmet need. The reason being there were about 45% patients surviving at the end of 5 years and 15% patients receiving complete pathological response. So obviously more had to be done to improve the outcomes in this particular area. And that's where the role of immune checkpoint inhibitors were explored in a perioperative setting. The rationale being that if you give an immune checkpoint inhibitor, it can prime your immune system and it can clear the minimal residual disease quite early in the course of the management. So there were various trials which analyzed this particular hypothesis that adding immune checkpoint inhibitor to chemotherapy can improve outcomes or not. So 4 important trials are highlighted. One is Keynote 585, where perioperative pembrolizumab with chemotherapy partner what was either capecitabine, cisplatin, 5-FU cisplatin, or FLOT. All three regimens were in the main cohort. Didn't include FLOT. The main cohort had cisplatin, capecitabine, or 5-FU cisplatin. Unfortunately, it was a negative trial. Attraction 5, this was a pure adjuvant immunotherapy trial that was also a negative trial. Dante, that is regarding the perioperative atezolizumab, it is still ongoing. It is awaiting the PFS data. But as of now, the only positive trial in this particular setting is the Matterhorn data. So, as mentioned regarding the adjuvant strategy, attraction 5, it didn't meet the primary endpoint of recurrence-free survival. And if you look into the keynote 585, now this was a perioperative immune checkpoint inhibitor plus chemotherapy trial. And if you look into the chemotherapy partner, it was not FLOT. It was FLOT along with the other chemotherapy partners also. And if you look into the results, there was a PCR benefit which was noted. Unfortunately, it didn't translate a EFS benefit in this particular trial. And there was no statistical improvement in OS noted in pembro plus chemo compared to chemo alone group. So, keynote trials and the attraction trials, they were largely negative trials. Now, coming to Matterhorn trial, this November 2025, it got an FDA approval. And this was the study design, a very clean, large phase 3 randomized double-blind trial where resectable stage 2, 3, or 4A gastric cancer cases were randomized 1:1 to the neoadjuvant with the perioperative arm, that is durvalumab plus FLOT. FLOT was the only chemotherapy partner in this, followed by surgery, followed by again FLOT plus durvalumab, followed by 1 year total of durvalumab. Primary endpoint being the event-free survival. And if we look into the percentage of the patients who were able to complete the surgery, they were nearly equal in between the arms. So it didn't add to the toxicities. It didn't add to poor surgical completion rates. If we look into the demographics, there were about 65-70% in gastric cancer patients. Rest were gastroesophageal junction cases. There were about 1/4 with T4 disease. There were about 70% node positive cases. There were about 90% patients with PDL1, which was positive. And if you look at the primary endpoint of event-free survival, at the end of 2 years, 67.4% of the patients in the durvalumab arm were event-free versus 58.5% with a hazard ratio of 0.71, translating to 29% reduction in the risk of disease recurrence, progression, or death. So, if you look into the subgroup analysis, nearly all subgroup favored the experimental arm. Regarding the overall survival, we have 3-year overall survival. And if we look into the 3-year OS data, it is 68.6% in the durvalumab arm versus 61.9% in the comparator arm. Hazard ratio being 0.78, which is statistically significant. Again, OS subgroup analysis, it is showing a survival benefit irrespective of whether patients are male or female, age, PDL1 expression, node status, performance status, primary tumor location, or the histological type. If we look into the PDL1 aspects also, there were 90% of the patients who were PDL1 positive in this trial. OS was improved regardless of the PDL1 status. If we look into the pathological complete response rates, there were 19% with durvalumab plus FLOT versus 7% with an absolute increment of 12%. Safety-wise, there were any new safety signals which were known. So the key takeaway was that, yes, this was a positive trial. And if we look into the other immune checkpoint inhibitors trial in this particular area, it is showing a OS advantage, EFS advantage, as well as a PCR benefit. So addition of durvalumab to FLOT improved overall and event-free survival in resectable gastric and gastroesophageal junction adenocarcinomas. So to summarize, FLOT 4 was the one who established perioperative chemotherapy as the standard, but there were unmet needs, especially the relapse rates. About 50% of the patients, they were surviving at the end of 5 years, and something more needs to be done. And that's where the role of immunotherapy comes. There were other trials utilizing pembrolizumab, atezolizumab, and nivolumab. The nivolumab adjuvant trial and the perioperative pembrolizumab trial improved PCR, but it didn't enhance the survival outcomes. It was not able to translate to the survival benefit. The Matterhorn trial, it significantly improved event-free survival compared to placebo, which was consistent across all subgroups. It improved overall survival also, and there were no any new safety concerns. So I think that's it from my end. Again, I would like to thank Dr. Ravi for the kind invitation. Thank you.
Thank you, sir. I request our chairpersons, please felicitate our speaker with a memento. Dr. Ravi Jaiswal, please join for the felicitation.
For the next session on illuminating CLDN 18.2, understanding the novel biomarkers and treatment evolution with VYLOY. I call upon Dr. Imran Nisar Sheikh, Consultant Medical Oncology, Kokilaben Dhirubhai Ambani Hospital, Mumbai.
Over to you, sir.
Yeah. Good afternoon, everyone. At the outset, I would like to thank OncoSphere 2.0 team, Dr. Ravi Jaiswal, for inviting me here and giving me this opportunity to share my views with the wise audience here. I bring greetings from Kokilaben Dhirubhai Ambani Hospital in Mumbai. My brief today is to talk about this new biomarker, Claudin 18.2, and understanding how it works and the treatment with YLOI. It's YLOI, zolbetuximab. So to understand how it came into vogue, this is the timeline of events that has happened in the management of advanced gastric and G junction adenocarcinoma. So for a good 20-30 years, it was only chemotherapy till we found the role of trastuzumab in 2010. And then there has been a combination of this particular backbone with pembrolizumab in the last couple of years. There has been some more work done in the HER2 negative setting, where we have chemo plus other immunotherapy agents like Nivo, pembrolizumab, and tislelizumab. Here we are talking about a subset where none of this works, that is chemotherapy and zolbetuximab, which is the latest to happen. This is the ISMO guideline. It was released in September 2024, which shows that in this group of patients, locally advanced and unresectable gastric and G junction adenocarcinoma, broadly, the treatment is divided according to the HER2 positivity status. If the patient is HER2 positive, we look for PDL1 positivity as well. And if that is also there, the best treatment is cisplatin, the platinum-based therapy plus 5FU and the addition of trastuzumab. However, if it is negative, it is only addition of trastuzumab. In the other column, you can see the HER2 negative category of patients where if again the patient is PDL1 positive, one can think of adding the immune checkpoint inhibitors. If the patient is deficient MMR or MSI high, one can seriously think about adding immune checkpoint inhibitors. However, if it is Claudin 18.2 positive, addition of zolbetuximab is the therapy is the way to go forward. And last, if none of these factors are found, then we can definitely add docetaxel to our chemotherapy backbone. And very rarely, if they do respond very well, we can think of doing a surgery. What is this Claudin 18.2, which is marked by zolbetuximab? So it's a marker which is present in almost all gastric mucosal epithelial cells. It forms the tight junctions through which the cells communicate with each other. Most of the time, they are deep inside the gastric mucosa, but when a tumor proliferates, this receptor comes in large numbers on the surface and then it is easy to target. So zolbetuximab identifies this, flags it, and hence makes it susceptible to an antibody-dependent cytotoxicity or a complement-dependent cytotoxicity with the membrane attack complex. How is it administered? So there is a loading dose. On cycle 1, day 1, it is 800 mg per meter square. And then there is a maintenance dose of either 600 mg per meter square every 3 weekly or 400 mg per meter square every 2 weekly. And this is used in combination with a platinum and 5-FU based therapy and to be continued until disease progression or unacceptable toxicity. Important to remember is that there is no dose reduction recommended in case the patient has a toxicity with zolbetuximab. You can either alter the infusion rate, you can interrupt the treatment, or you can discontinue the drug, but you cannot reduce the dose of the drug. And then, why are we talking this to the medical oncologist? Because, as I said, there is a need to alter the infusion rate. One should know till what time the solution will remain viable. So, if kept at room temperature, the reconstituted vial can go up to 6 hours, the infusion bag up to 8 hours, and at 2 to 8 degrees centigrade, not more than 24 hours. So if you are altering the rate of administration of zolbetuximab and it is exceeding this time period, please discard the solution and prepare a new one. Now, this is how zolbetuximab came into its place. 2 trials, phase 3, each containing more than 500 patients, namely the Spotlight trial and the Glow trial. What they did was simple. Took patients who were previously untreated, locally advanced or unresectable or metastatic gastric and G junction adenocarcinoma, having Claudin 18.2 positivity. By that we mean more than 75% of the tumor cells should have a moderate to strong homogeneous staining, HER2 negative, good ECOG performance status, and adequate organ function. And they randomized these 500 plus patients in a 1:1 ratio in the Spotlight trial to receive Folfox plus zolbetuximab for 4 cycles, followed by zolbetuximab and 5-FU folinic acid till disease progression versus Folfox plus placebo in the control arm, followed by placebo and 5-FU folinic acid. In the GLOW trial, they replaced Folfox with Capox, other things remaining same. So the primary endpoint was the progression-free survival. Secondary endpoint was the overall survival and time to confirm deterioration. And additional secondary endpoints looked at the overall response rate, duration of response, safety, and the patient-reported outcomes. They also looked at region-wise differences, number of organ affected with the METs, and history of prior gastrectomy or not. So this is over a 3-year period, the data of PFS. You can see there is an improvement, 9.2 months versus 8.2 months. But you look at the hazard ratios, it leads to a 29% reduction in the risk of progression in favor of zolbetuximab and chemotherapy. This is the forest plot showing all subgroup of patients, irrespective of the number of metastatic sites, the histopathology, diffuse versus intestinal or others. All subgroups benefited from zolbetuximab and chemotherapy combination as far as the PFS was concerned. This is the OS data. Again, 16.4 months versus 13.7 months in favor of zolbetuximab and chemotherapy arm. And there is a 23% reduction in the risk of death or disease progression. So, statistically significant. Again, the forest plot is very similar to that seen in the PFS. Almost all subgroup of patients, irrespective of the type of disease, sites of disease, metastatic sites of disease, and histopathology, benefited by the zolbetuximab and chemotherapy combination. Now, how safe it is to give this drug? So, overall side effects were same in both the arms, but you see, grade 3 and more side effects were around 5% more, 80 versus 74%. Those leading to interruption of zolbetuximab were 54% versus 19%. And those leading to discontinuation were 10.5% versus 3.4%. Why is this? We'll see shortly. So, what are the major side effects one can expect with this new drug? Surprisingly, it is nausea, vomiting, and decreased appetite. So, these are the 3 major reasons why zolbetuximab is either interrupted or discontinued. Other side effects were more or less similar with the chemotherapy arm. The good news is zolbetuximab and induced nausea vomiting goes down with time. But other important thing to know is that it is during the first 1 hour of infusion of this drug whether it is used with Folfox or Capox, that you get nausea and vomiting. Other good news is the quality of life is not affected later on, but initially, during the first couple of cycles with zolbetuximab and chemotherapy, patient does need handholding. So Claudin 18.2 is here to stay in this 18.2 positive and HER2 negative category of patients. It's approved across the globe. So to summarize, this is a drug which binds to 18.2, Claudin 18.2, and flags for ADCC and CDC. Two trials have shown, phase 3 trials have shown its efficacy with PFS and OS. Side effect profile is well tolerated, and it is the standard of care. Last few slides, because the investigators wanted to look at what happened if you also censored those patients whom we had to discontinue the drug because of nausea and vomiting, and they found that there was further improvement in PFS and OS. So this is what we know, and this is what happened after censoring. So from 9.2, after censoring, the PFS became 10.4 months. Patients in whom steroids were used as part of antiemetic regimen had in better PFS and OS, 10.5 months. Pre-drug antiemetic regimen used prophylactically was the best in preventing nausea and vomiting, up to 58% in preventing nausea and for 64% in preventing vomiting. So to conclude, early identification of such patients is very important. Counseling the patient is very important, and altering your infusion rate and stopping at an appropriate time so that the patient receives the appropriate amount of drug which you have planned is the key to good outcomes with zolbetuximab. Thank you. If you have any questions, be happy to take it.
Thank you, sir. I request our chairpersons, please felicitate our speaker, Dr. Imran Sheikh, sir, with a memento. And chairperson का था सर. Thank you. Very good. Thank you, sir. I request our chairperson, please collect their mementos from memento podium at just outside of the hall. And I request Dr. Rahman, sir, please felicitate our chairpersons with mementos. Now we move to our next session.
The burden of colorectal cancer is increasing in India with approximately 69 to 70,000 new cases detected annually. So, for the next panel discussion on modern multidisciplinary care in rectal cancer, I invite Dr. Satish Pawar to moderate the session. He is Senior Consultant and Head, Surgical Oncology and Robotic Surgery at Care Hospitals, High Tech City, Hyderabad.
Thank you.
And the panelists, I request Dr. Yashwant Kashyap, Dr. Avdesh Bharat, Dr. Dheeraj Premchandani, Dr. Charu Sharma, Dr. Afreen Shams from Nagpur, Dr. Neil Jotsana from Raipur, Dr. Darshna Rane from Mumbai, Dr. Saurabh Jain, oncosurgeon from Raipur, Dr. Nivedita Verma from Raipur, and Dr. Suresh Tiwari.
To chair the session, may I request Dr. Suresh Tiwari sir from Manendragarh and Dr. Shankar Paliwal sir from Korba. Please chair the session for us.
At the outset, I thank Ravi for inviting me, and he's already cut my 2 minutes of time. So, without further ado, we'll continue. So, as you all know, rectal cancer is a complex topic as such, and rectum is around 6 inches, 6.5 inches, and that is 15 centimeters. So upper third, middle third, and the lower third rectum is divided into 5 centimeters each. So with all, will let us continue with the first case. It's a 60-year-old male. Presentation is bleeding PR from 15 days. Frequency of stools has increased from 8 to 10 times per day, and hypertensive, diabetic, and hypothyroid. No other history. So performance status is good. Circumferential growth involving rectum, 6 centimeters from the anal verge. Felt at the tip of the finger. Good anal tone. There was left inguinal hernia, and then colonoscopy was done. Polypoidal circumferential lesion distal to mid rectum, approximately 6 centimeters from the anal verge, and a sessile polyp was there in the cecum, which was dissected, and it came negative. Biopsy is adenocarcinoma moderately differentiated, and CEA was done 68.5. So, medical oncologist, any markers in on the biopsy?
So yes, apart from the routine markers like the CK20, CK7, CDX2 and all, we will do the MMR status, the molecular testing.
Yeah.
It's done
So,
for all.
okay. So you
We don't have the PET scan to see whether it's metastatic or no. Yeah.
okay. So it is DMMR on IHC, or you want to do any NGS?
So NGS is something that we prefer now
Okay.
because it's more affordable also. It tells about other markers. But if we can, then, I mean, though we don't have the facility, limited MSI or MMR by LC is fine.
How do we proceed from here? Surgical oncologist.
So we'll do a cross-sectional imaging in the form of
Yeah.
MRI. Yeah, so
Yes. So this is the cross-sectional imaging. You can see. So almost circumferential growth as you come lower down, you will see, you'll appreciate. And then the most important thing here is it is anteriorly placed. The growth is anteriorly placed. So with this, with CA of 60.5, 65, do you really want any other imaging, or you're fine with this?
no, we'll have to do a metastatic workup
Yeah.
because it looks like an advanced lesion.
Yeah. So we have done metastatic workup, whole body PET-CT, because the CA was high, and this is the whole body PET-CT here. Nuclear medicine, if you want to comment, you can comment. So in addition to the MRI pelvis, what we always felt is PET gives an additional advantage, especially for the nodes. So if there is uptake in the node, and if MRI also says it is suspicious, definitely we would go for neoadjuvant treatments rather than going for upfront surgery. Yeah. So whole body PET-CT localize disease, no local regional nodes as well. And then, so to combine both, I think PET MRI will be a better choice of imaging rather than doing two scans. So, so how do you proceed with the case, surgical oncologist?
So I would like to know MRI findings. Was the mesorectal fascia, what is the?
Yeah, so there is just a fat standing. Apart from that, I think it can be T3A or T3B, but then I mentioned that it is an anterior tumor.
Yeah. So we can do. There are two options that we can go ahead. One is to give a short course radiation therapy followed by doing a surgery, versus even in a early T3A, you can still think of doing an upfront surgery.
Yeah. So most of the times, if it is circumferential lesion and you have a good margin, CRM will be negative most of the times. You can go ahead with surgery, but then with a caution that, you know, if it turns out to be a node positive, and then giving adjuvant radiation will be a difficult job. So hence we would push more towards neoadjuvant treatment in anterior tumors. Medical oncologist, you want to add chemotherapy?
PET scan.
Yeah.
Can I have the PET scan report, please?
So except for the length, it is upper third going into the middle third, predominantly in the middle third. And apart from that, there's nothing much in the PET scan. So yeah, radiation oncologist, do you want to add radiation?
Yes, we go with short course RT as is upper and middle third rectum,
Okay.
and followed by
So
tube
based on what? Based on Swedish trial?
based on Rapido trials.
Rapido trial. Okay. So Rapido trial, again, you have to send the case to the medical oncologist. Do you want to overtreat this patient with chemotherapy? T3A, B, N0. Do you really want to add chemotherapy to this?
Yes, TNT is better always.
No, I want the medical oncologist to.
So I would like to know what is the MMR status, because that would then
It's proficient.
it is proficient.
Yeah.
Okay. Um, so the plan is to operate
Or to give SCRT and then
or to give SCRT and operate. Then I would we can consider only radiation.
Yeah. So we can still go with Swedish trial, although it was published in 97. It doesn't mean we cannot, and it had equal evidence to long course versus short course, except for the side effects. Yeah.
Yes, I also want to see the MRI findings.
I told you that it is circumferential lesion mainly anteriorly, okay, around 6 centimeters from the anal verge. The length is around 5 to 6 centimeters.
Okay. And,
No
sorry,
nodes. No nodes.
Okay. And what was the age? I just forgot the age. Age of patient and other, like
60 years.
60. Okay, because we have the other option of the prospect trial also, because if early
I'll
stage
come there. I'll come there to the prospect trial. So most of the times, what is happening is with these trials, we are over treating most of the patients. If it is T4 disease, yes, I definitely accept that prospect trial will come. Role of prospect trial is there, but otherwise, I don't see any role of giving upfront chemotherapy and then assessing the patient. I'll tell you. In that next case, we'll discuss all this. So MRI pelvis Mercury trial, it's a gold standard. MRI has to be done and then categorize them into low risk, intermediate risk, and high risk, and then only take a call. So this patient received short course radiation, 5 into 5 fractions, 25 gray. And in such situations, how long do you want to wait, surgeon?
Usually, we try to do surgery early. That was the earlier protocol, but now there are trials which are saying that even postponing surgery for up to 4 weeks is acceptable.
Yeah. So postponing the surgery for up to 4 weeks, but then the radiation side effects will add
get
to it.
yes,
So
yes.
that you need to always remember and take a call. And I told you that patient is having 8 to 10 times of motions
Right.
per day. So
Right.
that also you need to take take into consideration. So surgical approach, robotic, lab, open, what do you prefer?
So first of all, the most important thing is whatever the surgeon is comfortable to get the best oncological clearance.
Okay.
MIS is always better, and between robotic versus lab, whatever the surgeon is more comfortable dealing with.
Yeah, but then robotic has definitely, has definite advantages in rectal cancer surgeries when you go deep, and in lower third, there's a better clearance. So high ligation of IMV.
So, as such, not based on oncological principles, it is mainly to facilitate the reach of the colon. So, not per se oncologically, both are fine. IMV we always like it at the lower border of the pancreas.
Either you remove all the nodes and come and do a low ligation, or do a high ligation for better length.
But one must be cautious, especially in diabetic patients, the one who have atherosclerosis, then probably a low ligation would be preferred because perfusion may be compromised in those
Yes, definitely. Apart from that, even nerve injury is more when you have high ligation. Anastomosis, open.
So again, it depends. Circular stapler is a preferred.
Preferable. You want to use contour or do a lap?
So So if whatever, so contour, if you're doing an open surgery, contour would be better. Otherwise, circular stapler or is all right.
Cost of the endocutters coming down. I think I'm preferably using more of endocutters now. And then, yes, end to side, side to end.
So end to side is always preferable, but whatever surgeon's preference, if he's comfortable with end to end, but end to side is always.
Any experience with nose, natural orifice, this kind of extractions? Okay. So TME is the gold standard. Should always not forget that any form of neoadjuvant treatment, adjuvant treatment. So TME should be our aim to give CRM negative margins, because obviously you have seen that the overall survival also has rapidly decreased if you follow a good TME. And this should be your specimen, baby's bottom, and then patient underwent laparoscopic acid low anti-resection colorectal anastomosis. This is the T3 N0 14 nodes detected, margins free 3 centimeters proximal margin, distal margin is also adequate, and the radial margin is also free. So medical oncologist, any adjunct treatment?
Before we move to medical oncology, I just wanted to know 2 is just the radial margin. Probably we could normally we are able to achieve slightly more than 2 3
So
4
it is either less than 1 mm or more than 1 mm. Okay, it all depends on lot of things in it. If there is more fat, you will get more the perirectal fat there, and so it should be either less than 1 mm, which is positive, or negative. That should be the bottleneck. Yeah, medical oncologist. Sorry.
Can I have that histopath slide, please?
Yeah.
Yeah. The second one.
So T3,
So the next one.
mucinous adenocarcinoma, grade 2, moderately differentiated.
Okay. So no lymphovascular invasion. I mean, just
No LVI, no PNI.
lymph node.
Tumor Budge score is 0, low.
MSI negative.
Yeah.
So again, I will so because it's proficient MMR and T3N0, we can consider observation.
Perfect. So second case, 39-year-old male, 2 months of history of bleeding PR, history of constipation, no other significant history, ulceroproliferative growth, 4 centimeters from anal verge, non-circumferential growth, and then admitting one finger, anal tone is good, and colonoscopy also revealed the same findings, and modulated differential adenocarcinoma, CA is 4.8, and this is the MRI. Hemicircumferential lower rectal growth with minimal perirectal fat standing, no extratumoral mural tumor. Lower extent is 9 mm from the anal rectal margin. CRM is involved. EMVI is negative. Single small mesorectal node. Extra mesorectal nodes morphologically significant right internal and right obturator nodes. Yes. Next. What do you want to do?
So again, metastatic workup in this case.
Perfect. So metastatic workup, PET-CT done, nowhere else.
Okay, so now we are dealing with a locally advanced low rectal cancer with involved mesorectal as well as lateral nodes. So I would err on the side of neoadjuvant therapy, preferably a TNT if feasible.
Yeah. So preferably TNT. Why? Any reasons for TNT?
So now I want the best response, as much downstaging, and if possible, an organ preservation if feasible, because the patient I think is 35, so young patient. So we have to give that option to that patient.
Okay. Prospect. Any?
Like prospect is for T3, and that is for more for early stage patient, not for this patient. So it will be more for rapido or prodic kind of treatment, and we will do MSI also.
So remember one thing, Prodage, Rapido, it's all short course. Okay. So always lower thirds and
long course.
Yeah, long course. So that is about bottom line, long course. You can say Oprah.
Oprah, but Oprah issue is that this is also not a patient for Oprah, because Oprah will be early stage T3 till T3 patient and node negative or N1 like that patient. So this patient will not come in Oprah also. This patient.
Oprah is the wait and watch
it is for long course, but the inclusion criteria I am saying that they are more early stage patient, not such a advanced stage.
Okay. Sir, but there are high risk features, and for high risk features, better to go for with long course RT.
We are all using long course only for advanced disease. Long course only. Only discussion is if between chemo first or RT first.
Sir, since
That
the
is.
patient is symptomatic, having bleeding per rectum and some kind of obstruction, so I would prefer long course CCRT to relieve the local symptom. Further, I will proceed for chemotherapy.
Yes, only thing like this patient has node positive also. This patient, if he has some mucinous variety or some EFPI positive, then definitely chemo first, followed by chemo radiation.
Okay,
Long course radiation.
yeah, that is debatable. But then, okay, 50 gray RT and then 4 gray boost and concurrent chemotherapy with capecitabine, PET-CT evaluated after 6 weeks. There is still subtle changes. Thickening is present, and the right iliac node has definitely responded. It is faintly avid now. So again, MRI was done 7 weeks post neoadjuvant treatment. Mild thickening still present, but there is good response. Colonoscopy done 1 into 1 centimeters. Lesion is 5 centimeters frontal verge. Biopsy done negative. So now it's an young patient. Patient's is an IT professional, and then he discusses with you, comes to the OPD, surgical oncologist. What do you do? Where do you go from now?
So now, obviously, there are two options. One, patient has to understand that before giving any treatment, he had a locally advanced disease with nodes. So the chances of disease relapse is higher in him. And every time salvage surgery in the form of conservative rectal preservation may not be feasible if he recurs. So he has to be given that option and wait and watch. What people normally mistake is that wait and watch can be like 6 months or 1 year, but it has to be a very diligent wait and watch, diligent follow up.
So lot of discussion over 1 hour of time in the OPD, and now he has decided. He is already well read. He said, "I've read all the trials also, and now I'll opt for wait and watch because there is good response. My biopsy is negative." That is what the patient said, and now we have sent the patient to medical oncologist for. Obviously, we'll go for TNT more chemotherapy. What
Yes.
regimen?
So chemotherapy doublet will be the one which is used, but also we would like to know the MSI status and discuss with them about the options of immunotherapy as well.
Okay. So, when do we assess again?
Like, sorry, this patient need to complete its 6 month course of chemotherapy because with capecitabine it will be hardly 2 cycles, around 2-3 cycles. So we will give 8 to 10 cycles of FOLFIRINOX or FOLFOX. Young patient, so I will be more towards FOLFIRINOX, but this patient has good response, so FOLFOX is also fine for me.
Yeah. So he received 6 cycles of Folfox, and obviously Rapido, Prodish, Stellar, Opera all suggest go for TNT in these kind of cases. So better, so high organ preservation with chemoradiation followed by chemotherapy rather than starting induction and then consolidating with chemoradiation. So 5 year organ preservation is also better, 54% versus 39% when you give chemoradiation first, and then follow up again complete metabolic response, no new lesion. CEA slightly higher than what it was previously, was on surveillance. 4 months after completion of chemotherapy, again there was worry. No, the complete response, there was only thickening and no other lesion there. After 1 year of chemotherapy and 1.5 years of radiation, CT was done and there was a residual lesion. No other significant active lesion in rest of the scan. And then colonoscopy revealed 1 centimeter nodular lesion, 3 to 4 centimeters from anal verge. So this is where the lesion is. You can see clearly here, and it was close to the anorectal junction. Point again, almost 1.9 centimeters from the anorectal junction. What are the treatment options?
So biopsy is positive, right?
Biopsy is positive.
So again, so sphincters are free. It is just above the level of
Above
the level of the sphincters. then I think still rectal again one option is do APR, and the other option is to try for conservative rectal preservation is doing a
Will you opt for a transanal full thickness excision in such
no
cases?
no in these cases no.
So the other option is TATME, transanal total mesorectal excision, 1 minute, that's it. And then, or you go for a robotic ISR, introspective resection, and we went ahead with TATME. This is a lesion there you can see clearly. And this is a TATME is again hybrid procedure. You go by laparoscopy, mobilize the rectum, and then go down and take a 1 centimeter margin and resect from there. And this is how two surgeons do, from one from bottom, one from up. Okay, this is how it looks on the uh, from bottom. And due to lack of time, I'm just proceeding further. So this is a coloanal anastomosis. So the issue is with these surgeries, definitely you'll give this option for younger patients, but complications, LAR syndromes, how to prevent it, and then so a lot of counseling is needed. You have to sit, ask together with this patient and explain them. He's an IT professional. Although he has an option of work from home, he has to go to work as well. So we are done, and then obviously a lot of adjuvant treatment with uh, bulk cilium and all, diet modification, sit with the dietitian, nutritionist, and sort out. So it was T3N0, final histopathology, and then any adjuvant treatment, medical oncologist.
So he had received Folfox before.
Yeah, 6 cycles of
Six
Folfox.
cycles. So we can use like based on the fit. He's fit.
Yeah.
So we can use Folfree or Folfirinox.
Okay. Because there was residual lesion, you want to.
There was one response was there, and then there was a good DFI as well.
Okay.
So we can.
So basically, to start with this case, if it was an ideal case, I would have given neoadjuvant chemoradiation long course and operated this patient upfront, even if there was good response. Okay. Then
But what operation? APR?
no, that's what I'm telling you. Once you have the expertise of saving the sphincter with better robotic surgeries now, okay. So this patient was treated elsewhere and then came to me for TATME. But I am telling you, so giving chemotherapy, more chemotherapy is not an answer.
But this patient was locally advanced to begin with, and all the trials, barring SCRT and other, Rapido and Prodig is standard of care, and it clearly says that after NSCTRT,
No, after
you have
giving,
to,
so
we have to give
after
chemo.
treating with 6 months of Folfox, do you still want to add more chemotherapy? Is the
No,
question.
no. This patient, we can just give some capecitabine tablet or something close up, because
So
auxiliary will cause.
once the patient goes to, sorry to say this, once the patient goes to medical oncologist, they want to keep on treating the patient.
No, it's
So
not a civil surgeon also, but
so
This patient can be treated with immunotherapy and kept it as a maintenance if we want an organ preservation.
yeah, okay.
because the
Even
certain LAR, if we are doing, still the local symptoms can be very.
see, what happens is once you have done surgery for this patient, most of the times once the patient goes for adjuvant treatment with the medical oncologist, what really happens is patient has a lot of side effects with surgery. Okay. So this patient will not be willing to take any form of treatment further. Okay. And managing the side effects of the chemotherapy along with managing the side effects of surgery is a difficult task. And it's a difficult task for a medical oncologist also to convince the patient. So whenever such cases are there where, you'll see a lot of patients now with rectal preserving as an
That's why what we
intersected
do in
dissections.
our
Yeah.
tumor board, in day one only we give the plan to patient. This patient I will directly tell, we are starting NSCTRT, then we will give 6 cycles of chemo, then you will be operated. After operation, we will be giving 4 cycles.
Yeah.
of
So
treatment.
world over, we are going for de-escalation of treatment. So right from what we were used to do till 2020, multimodality, more toxic regimens, we are going for bimodal, less toxic treatments. And then if the response to chemotherapy, okay, along whenever there is locally advanced rectal cancers, if there is good response, then you add radiation and do surgery. Okay. So in such cases where you want to preserve sphincters, okay, it's always better to complete the chemotherapy and then send the patient to the surgeon for operating rather than giving them operative, that's adjuvant treatment, one thing. And wherever possible, decrease the treatment. Okay. Especially you'll see more working women coming with low rectal cancers, then you give short course radiation, give consolidation chemotherapy, and then operate. So shortening the length of treatment and giving the adequate treatment, that is the goal you need to be in rectal cancer rather than adding everything to each patient. Thank you.
But in case of low-lying tumors, I will prefer long course CCRT as compared to short
Yes,
course.
definitely. So imaging is the gold standard. MRI should be done. Neoadjuvant treatment has to be decided based on CRM, MRF, stage. Evidence is going more towards TNT as to get maximum PCR rate, but over treatment should not be. And PCR is not the surrogate marker for overall survival. TMA with CRM negative margin is the most important in surgery, which will result in local recurrence and transform the DFS and overs. Thank you all panelists, chairpersons, and participants. Thank you, Ravi.
Thank you. I request our panelists, please felicitate our moderator with big round of applause. And I request our panelists, please felicitate our moderator with the memento. I request our panelists, please collect their mementos from the memento podium, which is outside of the hall. To felicitate our panelist, I request Dr. Neha Jain from Ramakrishna Care Hospital, Department of Pathology. Felicitate our panelist with mementos.
For the next insightful session on mastering the art of TURBT, transurethral resection of bladder tumor, uro-oncologist preview, we are delighted to invite Dr. Ajay Parashar sir, consultant urologist, neurosurgery department, head of the department at Ramakrishna Care Hospitals.
To chair the session, I would like to invite Dr. Prashant Bhagwat sir from Raipur, Dr. Ashish Sharma from Raipur, Dr. Sandeep Agrawal from Raipur, Dr. Amit Sharma from Raipur, Dr. Harsh Jain from Raipur, Dr. Murli Badwani, and Dr. A.G. Sheikh from Dhamtari. Over to its chairpersons.
Yeah. Good afternoon, respected chairpersons, seniors, delegates. Welcome to OncoSphere 2.0. Participate in a speak on a subject, which is surgical oncology. Mastering the art of TURBT or any surgery requires time and experience. TURBT is required because it is a procedure which helps in removing resectable or non-muscle invasive bladder cancers, whether they are one or two or more, but in small in size, and at the same time provides for high quality tissue to pathologists. Why it is necessary? Because it helps in making diagnosis, which is helpful in further management. We remember that by doing cystoscopy and TURBT, not only evaluate the disease, not only map the available uh, uh, amount of tumor, but also gives a specimen available to pathologist for making a tumor histology diagnosis. Extreme left is a papilloma, then is a transitional cell carcinoma, to squamous cell carcinoma, and so on. go directly to the instruments which are required. We do cystourethropy and then resectoscopy. The urethrocystoscopy trolley looks like this. There are different sizes of sheets. Generally, the 17 or 21 or 22 French sheet is used because if you want to take a biopsy, you have to use a sheet larger than 17 French. This is how a receptoscope set sees. You can very well appreciate the presence of dilators. See, urethra is to be cannulated because the receptoscope is larger in diameter. So, avoid the risk of structure, you first put dilators or sex urethrotomy, calibrate the urethra, and then only go for the PRBT. The Carlstage Image 1 Spice camera platform or any other platform which helps in doing endoscopic procedures. This is important because some of the programs of the camera itself help in diagnosing the neovascularization of tumor. The energy sources, the electrosurgical unit, or the laser. We will discuss in detail later on. So let us go first to cystourethropy. What is to be in our mind? Assess the tumor, the size, distance from the orifices, whether it is a broad-based or a sessile tumor, or pedunculated, its location, single, multiple, abnormal positions like in diverticulum. You have to map and record it because it is a reference in future management. Start from trigone, see right ureteric orifice, then left ureteric orifice, right wall, left wall, anterior wall, posterior wall, dome, neck, and prostatic urethra. It is a systematic way of recording. Cystoscopy will show whether a tumor on left side, which is a large one, or a small one, both fronted. You can see tumor which is not large in size but difficult to manage because it is in diverticulum. The right upper one is a large tumor in the anterior lateral wall, right side. The lower one is a tumor which is close to the trigone, and the right lower tumor is actually over the anterior wall. Let us take cases. This is a patient, middle-aged, hematuria, cause not known, ultrasound done, so thickening at the level of trigone. When we enter, we see the unhealthy mucosa and there is a possible lesion close to the right ureteric orifice. Cannulation of orifice avoid risk to injury and a small cut kind of a excisional biopsy done. Biopsy was also taken from the bladder neck. This is the Clara and Chroma setting of the image 1 spice, and this is a spectra setting of the camera which helps in seeing the neovascularization of tumor vessels. Another patient, a female who presented with urosepsis due to left renal stone, but at the same time incidental detection of a mass at the right trigone. See, we did the left RVP stenting and a resection of the tumor. The tumor resection is of two types: antegrade movement of loop and retrograde movement of loop. What we saw earlier was an antegrade movement where from tumor we come to our side. This is a retrograde movement where we go from normal to tumor side. The advantage is a more controlled resection, but the disadvantage is a disturbance because of the air bubbles. Gradually, the tumor was separated from its stalk. Whenever we cut or use cutting current, bleeding will be there. Keep on coagulating so avoid red out. This is a final picture. This is a final picture. ये रन नहीं हो रहा है. ये रन नहीं हो रहा. रन कर दूं. This is the final picture. The tumor is out. Margins are coagulated carefully, and you will see right ureteric orifice very close to the area where we have resected. See, in the end, we take a deep biopsy only after careful hemostasis, so as to send it separately for muscle invasion. Next case, another patient, but here the tumor was sitting over the left ureteric orifice. In spite of efforts, we were not able to see where is the orifice. So sometimes we try doing a blind resection with the help of retrograde, like these movements, and integrate, like these movements. Gradually, the tumor was deburred or removed, and hoping that we will be able to see the orifice once all the tumor is out. In all cases, you must have observed that there is no charring. So the setting is to be such that the tissue is not damaged, because then only the histopathology report will be proper. Otherwise, mostly the pathologist will say that the tissue is not available. It was not possible to see the orifice, but finally, at the end of the complete removal of tumor, we could see, and after putting a guide wire, digestion was put. This is a patient who was operated for multiple tumors, then came with a recurrence. The recurrence was at a bad place. This was an anterior wall, angry looking tumor. Problem with anterior wall is that it never comes directly to you. The ergonomics is such that you have to cut from 12 o'clock rather than 6 o'clock, from where we were cutting by now. So we used the laser with help of our assistant to bring the anterior abdominal wall lower down, how to stabilize and cut. Finally, the whole tumor was removed. So, mastering KRPT requires understanding how you are going to do resection. For pedunculated tumor, try to clear the sites and reach to stop, cut it, and then take out the lesion. Use of cautery or bipolar or laser is actually important. One is because of the availability. If it is available, bipolar is good. Monopolar has got high collateral spread of current, deeper tissue charring, while bipolar is better. Best is definitely laser. However, all modalities are not available, so even monopolar is good enough. Why laser is best? Because the overall advantage of there is no obturator jerk, there is no floaters, and specimen is clean. Whatever you have your own set of complications. Remember, the perioperative dreaded complication is a perforation. Extraperitoneal is not that difficult or serious than the intraperitoneal. Shuriken nerve reflex causes perforations, increases bleeding, and chances of partial TRBT. TR syndrome, another problem. Post-operatively, hematuria, clot retention, needing blood transfusion, UTI, urethral stricture, injury to ureter. One has to be careful. Oncologically, endostaging or incomplete resection is a risk. It is to be kept in mind. Please for getting a marrow into diabetes, preoperatively, see whether the urinary is sterile or not, get a cytology, ultrasound, CT, MRI imaging, so that before surgery you have a mental understanding of disease. Cataract evaluation and ergonomics is to be calibrated. Operatively, you see urethra properly, bladder assess, macroscopic appearance of lesion, number of lesions, map them well, involvement of trigon or important areas like urethric orifice. See whether at the end of procedure macroscopically the tumor is completely removed or not. Avoid surgical complication, especially perforation, and send a specific specimen labeled properly if you have taken. Post-operatively, the pathology report is to be evaluated for the prognosis of the patient, stage it properly, and sometimes you have to go for a second look also. Thank you.
I would like you to highlight, say a few words about the N block TURBT as well.
Yeah. What we have discussed is a transurethral resection of bladder tumor with monopolar or bipolar or with laser. Most of the cases you must have seen the tumor is cut into pieces and taken out. When you want to take out tumor en bloc, single unit, then this procedure is known as en bloc resection of bladder tumor. The best way to do it using laser. Why? Because laser is more powerful, hemostasis is good. The risk involved is that probably sometimes you go deep enough to perforate. However, en bloc dissection of bladder tumors is existing and people are doing it also. Only problem is taking out the specimen. If the specimen is large enough, you have to either modulate it or try to extract it in total as possible only when it is small.
We'd like to have your expertise on how to avoid operator jerk and if the patient had in while doing monopolar TRP. And second thing, if a patient has a large prostate with bladder mass, would you go for the TRP simultaneously with TRBT?
Yes. So obturates jerk is mainly because of the spoolage of current what we are using. While cutting, we use current. Patient has to be under general anesthesia with muscle relaxants is one way of reducing the risk or the briskness of obturator jerk. The patient bladder has to be partially full. If you fill the bladder with irrigant too much, it will reach close to the obturator nose, and the moment you try to use cautery, there will be obturator jerk. There are specific areas where if the tumor is sitting, this problem will occur. So you are safe while doing posterior or anterior. While lateral wall you will have. So if possible and if available, laser can be used because laser avoids totally the risk of obturator jerk.
Would you do TRP with TRBT?
Yes. Where's the second question? See, there are two odds for it. If the raw area is created and if the tumor or floaters are there, then the chances of implantation over there is a possibility. But if you see from follow point of view and if the patient is having retrospective symptoms also, it is recommended that because the patient is symptomatic, TRP can be done. However, with flexible cystoscopes, in follow-up cystoscopy is possible even with the large prostate also.
Thank you, sir.
Any questions from audience? I'm happy to answer.
Only
UHG, actually, if we go by the histopathology, adenocarcinomas are generally occurring at the urethral level, which is the apical portion and reaching to the umbilicus. So that area is generally felt clinically the hard area in the infraumbilical area. where you can go and take a biopsy sonographically extra cycle, but not into the bladder. Bladder you can always go cystoscopically and take a biopsy.
Right. You are doing cystoscopically excision or biopsy, but what I am saying is the USD guidance. Avoid the perforation as well as knowing how much depth you are cutting. One thing. Second part of my one question is whether these devices, the cautery devices, laser and others, don't they destroy the histology of the tissue which you are taking out?
Yes. So as I mentioned, monopolar cautery definitely destroys if the settings are very high. But if you have seen our video, every time when the cut is taken, the tissue was white. It was not black. So high current setting is to be avoided. Otherwise, charring will be there. Monopolar, more destruction of pathology specimen. Bipolar, less. Laser, very less.
And why monopolar is being used if it is going to be risky?
It is the availability of the resources.
It started way back 35, 40 years back when I was in the college. But now every equipment has got a bipolar.
Yes, yes.
Yeah.
Correct.
Thank you.
Yes.
Thank you, sir. I request our chairperson, please felicitate our speaker with a memento.
इसको निकाल लेना ना.
आपको फेलिसिटेट करना है सर को तब वो सर प्लीज
एक छोटी सी अनाउंसमेंट है, अभी तक जिस भी डेलीगेट्स ने अपने अपने रजिस्ट्रेशंस ऑनलाइन नहीं किए हैं प्लीज कर लें. इस ऑनलाइन रजिस्ट्रेशन के बाद ही आपको सर्टिफिकेट्स ऑनलाइन डिलीवर होंगे. आई रिक्वेस्ट अगेन, प्लीज register yourself for this OncoSphere 2.0. Now we move to our next session.
For the next session on redefining outcomes in bladder cancer, evolution of PADC, which is enfortumab vedotin EGFV, as the first line treatment for locally advanced metastatic urothelial carcinoma. We invite Dr. Madhavi Indani Mohta, consultant medical oncologist, KIMS Kingsway Hospital, Nagpur, Maharashtra.
Good afternoon, everyone, once again. So, I'll be discussing the role of redefining outcomes in bladder cancer, the evolution of PAD7 first line locally advanced and metastatic urothelial carcinomas. These are my disclaimers. I'll be discussing the EV302 study, which is open label randomized phase 3 study of enfortumab vedotin in combination with pembrolizumab versus chemotherapy in previously untreated locally advanced or metastatic urothelial cancer. So we all know that cisplatin-based chemotherapy have been the backbone in urothelial carcinoma stage 4 diseases. This combination is a chemo-free combination that we are going to study. So the design of the study was the inclusion criteria included previously untreated patients of locally advanced and metastatic urothelial carcinoma, which were eligible for platinum-based chemo, EV, and Pembro. The PDL1 inhibitors were naive. EGFR was more than 30 and the ECOG PS was less than 2. So the patients were randomized into 1:1 ratio to EV plus Pembro, where EV was used as 1.25 mg per kg day 1 and day 8, and pembrolizumab was given 200 mg Q3 weekly. The comparator arm was chemotherapy, which included gemcitabine with a cisplatin or carboplatin, maximum up to 6 cycles. Here, EV was continued till progression and pembrolizumab up to maximum of 35 cycles. The primary dual endpoint was PFS and OS. The secondary endpoints were ORR as per the RACIST and the Central Committee review and safety analysis. The patients were stratified based on cisplatin eligibility, PDL1 expression, and liver metastasis. So the key demographic features, as you can see, they were well balanced between both the treatment arms. Male patients were 77%. The median age was 69 years. It included Asians as well as white population, and ECOG PS of maximum patient was within 0 and 1. They were further subclassified into cisplatin eligibility, the site of metastasis, and the PDL1 expression of more than 10 versus less than 10. So 33% of the patients in the EV plus Pembro arm still remains on treatment at the time of analysis. So 442 patients were randomized into EV plus pembro arm and 444 patients in the chemotherapy arm. So as we can see, the PFS of the patients, the risk of progression or death was reduced by 55% in the patients who have received EV plus pembro. So this is huge. The hazard ratio was 0.45 with a very significant p-value. When we see the subgroup analysis, the benefit was seen across all the subgroups, irrespective of the age, sex, ECOG PS, site of the disease, presence or absence of liver metastasis. When we go to the primary endpoint of overall survival, the hazard ratio was 0.47 with OS at 12 months was 78% in the EV pembro arm versus 61% in the chemotherapy arm, which was persistently maintained even up to 18 and 24 months. When we see the subgroup analysis, we can see how beautifully the curves are still separating, irrespective of cisplatin eligibility, irrespective of the primary site of origin and liver metastasis. So when we see the PDL1 expression in PDL1 high population patient, the median OS was 31 months versus 16 months in the chemotherapy arm. And in even PDL1 low expression patients, we can see that the EV pembro arm had median OS which is not yet reached versus 15.5 months in the chemotherapy arm. So irrespective of the PDL1 expression, we see that pembro EV arm is benefiting. This same continues even in pan-Asian population with the EV pembro arm having a median OS of around 23.8 months. When we see the exploratory analysis about the patients with age of 75 years, we can see that even in this subgroup of patients, EV pembro arm had a better PFS and OS. Similar applies to the patients with diabetes and across various age groups. So this is the forest plot showing the same. We can see the graph favoring the EV pembro arm and not crossing the midline. When we see the overall response rates, the overall response rates were significantly higher in the EV pembro arm as compared to the chemotherapy arm. 30% of the patient had complete responses in the EV pembro arm as compared to 12.5% in the chemotherapy group. And the median duration of response is not reached in the EV pembro arm. The duration of response was the estimated duration at 24 months was 50% in the EV pembro arm as compared to the chemotherapy arm. And this was persistently maintained even during the further analysis. So when we see the CR and PR, the patients who have achieved CR and PR, the OS was, as you can see, the OS is 76% versus 59%, favoring the EV pembro arm. So time to response, when we see the time to response was similar, we think that maybe the immuno arm will take time to respond, but the combination of EV with pembro, we see that the median time to response was 2.1 month for the EV pembro and chemotherapy, both arms, and the median time to CR was 4.3 months with the EV pembro and 4.2 months with the chemotherapy arm. So the duration of responses, as we can see in this curve, is higher in the EV pembro arm. The OS in patients achieving CR was not reached. The median OS was not estimable in the EV pembro arm, which was clinically significant. I'm sorry. So subsequently, 59% of the patients in the chemo arm received PDL1 inhibitors. So what were the treatment-related adverse events? So grade 3 adverse events were 56% in the EV pembro arm and 70% in the chemo arm. The majority of the treatment-related side effects in the EV pembro arm were asthenia, diarrhea, immune-mediated toxicity, MODS. While in chemo arm, they were febrile neutropenia, myocardial infarction, neutropenic sepsis, and sepsis. So the most frequent side effects, as I've discussed, peripheral neuropathy, pruritus, alopecia, rash, fatigue, diarrhea, decreased appetite, and nausea, vomiting. There were no new safety signals with the EV pembro arm even after an additional 1 year of follow-up. Frequency and grade of TRAs remained consistent with the primary analysis. So, bridging trial to real practice, we know that EV pembro arm has a very safe, tolerable safety profile, but real world data is very limited as of now. So, we need a real world data in older population in patients with higher burden of comorbidities and impaired renal and hepatic functions. We have to monitor for the skin reaction, which can be early onset, peripheral neuropathy, which can be cumulative of the EV and the pembro, and have to watch for pneumonitis. So we have discussed the side effects. We can see that the onset of the selected side effects, within 15 days, we can have hyperglycemia, we have ocular toxicities. Around 3 months, like 3 to 4 cycles, can develop pneumonitis, and peripheral neuropathy is a delayed side effect. So when we see the current guidelines, ESMO recommends that in the patient who is treatment naive and where EV pembro is accessible, it is the first line treatment options. It is the first line preferred option, and on progression, patient can receive platinum based chemo. In patients where EV pembro is not available, gemcisplatin still remains the backbone. Nivolumab can be added based on the patient profile, and if the patient progresses further, we have second option of pembro artiso. On non-progression, we have maintenance avelumab as option. Second line treatment options in bladder depend upon the NGS status of the patients. We have FGFR inhibitors, HER2 inhibitors, and various other options. Thank you.
Thank you, ma'am. I request our chairpersons, please felicitate our speaker with the
Just a
momentum.
question to Madam.
Okay.
We have suppose a patient is there who had a recurrence of bladder tumor, high grade TCC, and he is a 60-year-old diabetic patient. So, what instruction or how will I advise the patient, or what I have to tell about this EV plus pembrolizumab? What all side effect I have to tell them? What is the cost of the therapy? How long will the therapy? And how it is better than the chemotherapy? Just as a clinical guide to us. Thanks.
Thank you, sir. So the cost, I think the company people can explain better. But apart from that, sir, we have to explain about the peripheral neuropathy. As you said, the patient is diabetic. Delayed onset peripheral neuropathy is a common known side effects. So we have to guide the patient about the peripheral neuropathy and supportive treatment options controlling diabetes. Other than that,
Chemotherapy also. So
yes,
how
sir, but with chemotherapy, neutropenia and sepsis is more common. But with EV pembrom, we had more amount of sensory neuropathy, not even motor, which is likely to happen with diabetes as well. So,
how we going to deal with that?
so we have to take if grade 1, grade 2, we can still continue the drug with the treatment-free interval. But if grade 3, grade 4 adverse events not responding to treatment, we have multivitamins and supportive care, then we have to stop the drug.
Cost?
So
I will tell. So Sharma sir, answering, adding 2 points to your question. So this regimen we have started for two of our patients. Of course, Ajay sir and Harsh sir have referred to us. So one patient is coming from Rourkela, and this patient after 4 cycles in relapse is in complete remission. We have never seen this. I mean, I have not seen in past 7 8 years relapse bladder cancer having this. Second patient, Dr. Harsh also knows that this patient was on oxygen. She's not fit for chemotherapy, but desired to live. 78-year-old gentleman coming from Bhilai. So we have started him on 2 doses. Gentleman has fatigue. फटीग रहता है इसमें, न्यूरोपैथी है, न्यूट्रोपेनिया उतना ज्यादा नहीं है. द टिपिकल कीमोथेरेपी साइड इफेक्ट्स वी आर नॉट एक्सपीरियंसिंग. साइड इफेक्ट्स तो है, बट it is a game changer. This combination is game changer. I've not seen this previously in our practice. क्योंकि कीमोथेरेपी इसमें सेकंड लाइन में नथिंग, 2 3 महीने से ज्यादा it doesn't work. Now we are talking about curing some of these patients, which we have never ever seen. Cost बहुत है, 3 लाख रुपए 4 लाख रुपए लगते हैं, but there is a support program, so you buy one and you get two free. So you have to do treatment whenever you are talking about immunotherapy. So we are treating them at least for 1 to 2 years, and that means these patients are living for 1 to 2 years, which we have never heard. So the entire cost would come around 20 lakhs. लेकिन 20 लाख में अगर जिंदगी बच रही है, and if you have money, then I think it's worth trying. Thank you.
What is your opinion? Both of you can answer that question. As far as EV Pembro combination as a neoadjuvant,
So we are having data actually, sir. Upcoming studies are going on.
It's coming up. It's coming up.
Neoadjuvant.
It is not yet established.
Yeah, it's coming up. I
Positive
mean,
results are there.
it's coming up. So I think very soon we'll be using this first line. Chemotherapy slowly will go down, and we are slowly coming up with this newer options. Thank
Last
you.
question.
Last.
Bony metastasis, soft tissue metastasis. Both have same effect or one is better than other?
Difficult to answer. Difficult to answer. I think with more experience, we'll be able to answer that question.
Yeah, I think it is equally well in all the subgroups.
Yeah, but
something
our experience is new with this molecule. So I think
another thing I would like to add is peripheral this Steven Johnson syndrome,
yes.
though it and skin related toxicity. So if patient comes to you with Pembro and EV combination and says that I have got a rash, don't brush it under the carpet. Allergy hoga, chhod diya ya bhaga diya. It might be a harbinger that it might later on develop into a proper Steven Johnson syndrome or a TEN syndrome, which can be fatal for the patient. Second thing is the interstitial lung diseases. So these two things, though not very prominently mentioned, we have seen in real world practice. Each cycle is 4 lakh rupees with Pembro. Pembro is going to continue for 2 years and EV is going to continue till disease progression. So a very costly therapy. So please be vigilant for skin related toxicities and lung related toxicities other than what madam has just mentioned.
And one more point to add in this, whatever the studies we are mentioning about this immunotherapies, most of these studies are done in the Western populations, and we are yet to know the effects, side effects, especially side effects of this drugs in the Indian population. And one of the gentlemen has said the cost is around 20-30 lakhs. But for an Indian population, most of these patients are 60, 70 years, and they are dependent populations. For family to spend 20-30 lakhs.
So currently the price
Yeah.
checks, but I think over the time, this is the initial
Yeah,
stage.
and second thing, we don't know which patient will respond or which patient will not respond with this treatment.
Population subgroup in this, sir. Apart from that, as we compare the data for other immunotherapies, we did not have that much of Indian inclusion in that. But the real world setup, we have a lot of evidence supporting that the side effects, it's similar to the phase 3 studies which have been quoted.
Yeah, these are all phase 3 studies. That's why I'm.
So we'll need more experience, definitely.
And second thing, most important about this immunotherapy is that we are still in a phase of molecular biology. Once we have that, then we can categorize which patient should be given this drug more rationally rather than just saying one or two patients living 4 months, 1 year. Because in Indian population, it is very hard to prescribe these drugs with such a cost.
That is what the cost is, and if
We have
currently
to accept it. This is the future. These molecules are the future. We have to accept it.
2 to 3 lakhs now. For the biosimilars,
Whether you like it or not, this is the future, and we have to learn it.
yes.
We all have to learn this thing.
Once a molecular biology develop, then
If the population. So, but still, the data very much supports the use of immuno combination with EV as compared to chemo. So, they have shown that they do better. Yes. And definitely further ahead, molecular markers will support this data.
Yeah, exactly. I totally agree. Initial data are very much supporting, but to generalize the treatment, we required another molecular biology so that we can be able to segregate which patient should be given this drug or that drug.
Yes. Thank you, sir.
Thank you, sir. Madam, please, I request our chairpersons, please felicitate our speaker with the memento. Give a big round of applause, please. Audience. I request our chairpersons, please collect their mementos from the memento podium, which is just outside of the hall. And I request Dr. Ravi Jaiswal and Dr. Gaurav Gupta felicitate our chairpersons with mementos. Dr. Gaurav Gupta and Dr. Ravi Jaiswal. Now we proceed to our next session.
Good afternoon, everyone. And next, we are proceeding to gynecological malignancies. And the gynecological cancers collectively represent one of the leading causes of cancer related morbidity and mortality in women worldwide. We all know, with cervical cancer being largely preventable, while ovarian cancer, which is most lethal due to late diagnosis. So, I hereby invite Dr. Maur Roy, Madam, for context setting and to tell us about the journey ahead. Madam is MS and MCH in surgical oncology. She is a senior consultant and director oncology at Ramakrishna Care Hospital. She has fellowship in plastic and reconstructive surgeries, and she has done uro-oncology from Gujarat Cancer and Research Center, Ahmedabad. She has presented various papers in national and international conferences, and she has Times of India Icon Award to her credit and Nari Ratna Award also. She has special interest in oncoplastic breast surgery and gastrointestinal oncology.
It is not my
So over to you, madam.
talk nahi hai. Talk nahi hai. It is just a speech, short speech. So, good afternoon, everyone. I am here to just give you a preview on what changes have taken place in management of gynecological cancers, which constitute a global burden of cancer for women. Initially, as we all know, that cervix was the number one cancer, gynecological cancer in women. Now, because of the preventive strategies like vaccination drive in adolescents and the screening tests like pap smear and HPV DNA co-testing, there is a decline in the incidence of cervix cancer in our OPDs. Cervix cancer has also undergone a sea change in the management with integration of immunotherapy in the treatment for locally advanced cervix cancer. Endometrial cancer has also undergone a vast change in the treatment protocols, with molecular classification being integrated for deciding the treatment line in a patient. Moment patient steps in the OPD with endometrial thickness, and when we do endometrial biopsy and it is a suspected case of endometrial cancer, we are supposed to send the biopsy for molecular classification to define whether it's a low risk, intermediate risk, or a high risk endometrial cancer. Sentinel lymph node mapping is also integrated in the treatment, in the surgical management, because if the sentinel nodes are negative, then we can avoid pelvic lymph node dissection, and if they are positive, then we go ahead with a pelvic lymph node dissection and a periaortic node sampling in those patients. Ovarian cancer, as we all know, is the most lethal of all gynecological cancer. It has also undergone a lot of changes as far as treatment part is concerned. We know that it has two types of treatment modalities. One is primary debulking surgery, which we do upfront if the Fagerty score is less, depending on the diagnostic laparoscopy and the findings of peritoneal carcinomatosis in ovarian cancer, and neoadjuvant chemotherapy followed by interval debulking surgery and integration of HIPEC to give a survival advantage in those patients as per the trials. There are also a lot of treatment changes as far as medical management of ovarian cancer is concerned, with the evolution of use of PARP inhibitors, anti-angiogenic therapies, and the chemotherapeutic drugs. So let us now delve and understand all the recent practice changing things that have come up in the management of gynecological cancers. I would like to invite the first speaker, Dr. Yashwant Kashyap, for his talk on Ruby trial.
So we welcome you, Dr. Yashwant Kashyap. Dr. Yashwant Kashyap is a senior consultant, medical oncology, hemato-oncology, and bone marrow transplantation at Balco Medical Center, Raipur. And
Outset, I will thank Ramakrishna Hospital and Dr. Ravi and team for having us here and for a good session.
To
So,
chair the session, I would like to invite Dr. Rajkumari Paliwal Madam from Korba, Dr. S.P. Srivastav from Indore, Dr. Sunita Kanoi from Raipur, Dr. A. Shanta from Hyderabad, and Madam Dr. Jyoti Jaiswal. Please join the dais as a chairperson. Over to you.
so Dr. Yashwant is going to speak about Ruby trial and the survival impact of Jemperli in 1L EC, that is endometrial carcinoma. And he'll update us about recent advances in C endometrium.
So we all have heard the story of rectal cancer, where dostarlimab, a magic bullet, which has shown the wonderful responses. So here comes the dostarlimab in endometrial cancer. So I will discuss about the Ruby trial and some survival impact of dostarlimab in endometrial cancer. So these are my disclaimers. It is GSK sponsored session, and I will discuss about the immunotherapy and chemotherapy rationale. So this combination is coming in big way in almost most of the patients, where immune checkpoint inhibitor in combination of chemotherapy has done wonders. So in this trial, in advanced or recurrent endometrial cancer, we have added immunotherapy agent dostarlimab with standard chemotherapy backbone. So regarding the biomarker testing, this is our routine practice. We are doing MSI and basic biomarker for almost all of our patients. And why endometrial cancer is special? Because incidence of MSI high is quite high, 25 to 26% patient have. And IHC is also not a costly test, and it has very good concordance with NGS. So the 25 percentage patient are MSI high. So this is a very big population, and it has very significant implications. So I will discuss about the Ruby trial part 1 results. So in this trial, there were two arms, like 494 patients. They were recurrent or advanced endometrial carcinoma patients. They were like MSI high patient were around 118 patient, and proficient MMR was around 376 patient. One arm was given dostarlimab 500 mg immunotherapy with standard paclitaxel chemo backbone for 6 cycles, followed by maintenance of dostarlimab 1000 mg 6 weekly for 3 years. Comparator arm had standard chemo alone. Then major efficacy, it was OS and PFS was the endpoint. Regarding the inclusion criteria, regarding the measurable or non-measurable disease, in patient, if patient has R1 resection or something, stage 3A or 3C, here also for all comer there is role of including apart from chemoimmunotherapy. For patient who are carcinosarcoma or serous, we know that, or clear cell, we know that this histology they do bad. So in even if they are R0, then also we should be based on this trial we can say that dostarlimab plus chemo is standard of care apart from our radiation and other therapy. So what were the included characteristic? It had 54% endometrioid, 14% other histology, 20% around are serous, and 10% are carcinosarcoma. We know that carcinosarcoma and serous they do badly. So there is lots of unmet need, particularly in such population. So at 40, it has shown 44.6% median OS compared to chemotherapy of only 28 months. So we know the immunotherapy tail of curve. So all this has shown that it is significant benefit. Regarding the 1 year PFS also, immunotherapy was better compared to chemo alone arm. Regarding the overall response rate, immunotherapy plus chemo has done better compared to immunotherapy alone. And this curve of the regarding the PFS, you can see this curve, the separation, which we know that how immunotherapy takes over survival and PFS. Regarding the OS also, here also it has shown, and this is the MSI high patient. MSI high patients, they are still doing well in a stage 4 cancer for so many years. Regarding the other overall response rate also, immunotherapy plus dostarlimab has done better compared to chemo alone now. Regarding the OS difference in across the group is also better with dostarlimab. Regarding the chemotherapy, this we do is standard our paclitaxel. Other arm was paclitaxel plus dostarlimab. And in sub-analysis also, patient who are MSI high, they have done markedly better, which we know that dostarlimab patient with immunotherapy patient will do. Uh, patient who are NSMP or TP53, they have also done better with immunotherapy combination because TP53 is a mutation which leads to the accelerated disease. So there was a lot of unmet need. Here also this population immuno works very well across the group. Immunotherapy has done better compared to chemo alone. Regarding the MSI high patient, they had very good responses with dostarlimab plus chemo. And PFS2 was also better with chemo plus dostarlimab. Regarding the adverse therapy, adverse they are there, but we are now using the immunotherapy from almost 10 years. We have lost few patients, but we have uh, prolonged the PFS or increased the survival OS for many of our patients. So regarding the adverse side effects, it is the standard immunotherapy side effects which we face. Few only had grade 3 extra compared to chemo arm. Regarding the neurologic side effects, we are always in a uh, correlation with our gastroenterologists, endocrinologists, neurologists for all these side effects. But most of the patient, we are able to recover from these side effects also. Regarding the dosage recommendation, uh, dose reduction is not recommended for dostarlimab. These are the grade 1, grade 2 side effects, which over the year now we are able to handle it more better. Regarding the adverse effect, uh, Imran sir was saying about the Steven Johnson syndrome. That is also there, but that is very rare side effect and it occurs in few of only patients. Regarding the infusion reaction also, now we are giving immunotherapy for many of patients. So most of the patients are now able to, we are managing well only. So to summarize, the dostarlimab plus chemo combination has shown statistically significant OS benefit in all comers, irrespective of MSI high, though the benefit is more in MSI high, but the other group, carcinosarcoma, serous, and patient who have measurable disease, still it is a wonder drug. These are the other populations also where it is not used dostarlimab. So with this, thank you everyone.
Thank you, sir, for your pearls of wisdom. And any questions?
Okay, I request our chairpersons, please felicitate our speaker with memento. I request Nakvi ma'am, please join the dais for a felicitation. And I request our chairpersons, please collect their mementos from the memento podium, which is outside of the hall. Please be seated for next session also.
So moving on to the next session, which is a cervical and endometrial cancer, a case-based discussion. So if cervical cancer teaches us the power of screening, endometrial cancer teaches us the power of listening. Listening to that one red flag symptom, postmenopausal bleeding. As I said, it often whispers first, so we need to have our ears open. So for that,
I'm already there.
So I would invite Dr. T.P. Sahu from Bhopal. He is a director and senior consultant, Department of Medical Oncology at Silverline Hospital, Bhopal. And the panelists are
Dr. Suman Mittal, madam, please join the dais. Dr. Bapuji Meher from Raipur. Dr. Vivek Patel from Raipur. Dr. Krishna Divya from Raipur. Dr. Hemu Tandon from Bilaspur. Dr. Rajendra Patel from Raipur. Dr. Parvati Joshi from Raipur. Dr. J. Karthik from Raipur and Dr. Vikas Agrawal from Raipur. Over to you, sir.
And we also welcome Dr. Jyoti Jaiswal, ma'am. So she is on the phone. So she is joined as a chairperson. So welcome, ma'am.
एक बार सबका नाम पूछ लेना ना। हाँ मैं पूछ लूंगा मैं तो
Dr. Himu, she's a radiation oncologist. Very dedicated. Very comfortable.
आप यहाँ पे
नहीं आप वहीं बैठो ना, ये बैठ जाएगा ना. Because of so radiation. Surgeons, raise your hand. Both of you.
Thank you. That's all. Okay. 30 minutes.
No one can stop you.
Yeah, that because I was given 30 minutes and I'll take my 30 minutes. Traveled overnight. So I think what I will do is rather than a dialectical lecture, the panel discussion is meant for discussion, and we will have case-based discussion. And let's see where we go. So thank you, Ravi. When Ravi gave me this topic, I thought to make it more into the non-metastatic because we have a panel which is really surgeons, radiation, and medoncs. So doing a metastatic really keeps the others out of the picture. So I'll make it more interesting. I'll start with the endometrium, 3 cases, and then probably go to the cervix if time permits. Otherwise, we'll stop at 30 minutes. So why endometrium? I felt because it was so important with the newer classification. There are a lot of gynects here, and endometrium is no more about FIGO staging. It is a lot more about the molecular staging, and I'll show you in case studies what was to be done with the older classification. Suddenly, when you do molecular, how things have changed. So that is my purpose of this panel. So I think that will be what the people want here. So to my medoncs first, Suman or maybe Krishna, any one of you can take it. Systemic chemotherapy in operable endometrium, do you think it is, does it have a level 1 evidence, point 1? And do you practice it? I'm talking of operable endometrial cancer, no way metastatic.
So, in adjuvant setting or no?
In adjuvant.
So, definitely in stage 3, when nodes are positive,
Okay.
then that is one condition. Another, when TP53 mutation is there,
So you
and that is another condition we consider adding systemic therapy in C endometrium postoperative.
So point which I want to make it on a level based discussion is chemotherapy as such has not have a single trial which has prolonged the overall survival in endometrial cancer. We as medical oncologists have been doing it, but there is nothing as a level 1 evidence even in stage 3 that chemotherapy in addition to radiotherapy has prolonged the overall survival. Best it has done is to prolong the DFS or the PFS as we can call it. So all the trials, even the GOG trial 249, if I'm correct on it, looked into this particular issue, and they found that it only prolonged the disease free at the PFS. It did not prolong this overall survival. So as such, if there's a patient whom you feel that is very poor, likely tolerable to chemotherapy, you are within your rights to write this. But all of us believe the recurrences are so high, especially in the group Suman spoke about the node positive and maybe the TP53. We all want to give it. The guidelines recommend it, but be careful. There is no survival advantage of adjuvant chemotherapy till date in endometrial cancer. So that is what I wanted to make point 1. Point 2, radiation, surgeons, medical oncologists, gynecologists all put together. How many of you have really started asking molecular testing for all your patients whom you have operated? Every patient now? Okay. So quickly, if I can ask maybe Karthik. So is it for all your patients and is it the full profile NGS or you want something very specific which you want to be done?
I'll go for full profile. Basically, on IHC, I look for P53 and MS.
Profile NGS, the broad panel 35, 43.
No. I look for I'll get a NGS for pole mutation.
Mutation.
And on IHC basis, I can go for P53 and MMR genes.
Okay.
Retained.
3 things. I will come to 2 more. Anyone wants to add? What?
ERP are also based on IHC.
Yeah. So Karthik spoke about very specific. This is something people have to remember. One is a pole mutation. That's the best possible thing that could happen to the patient. You spoke of TP53 by IHC. Anyone in the panel thinks that he or she would love to do NGS TP53, not a IHC? Or are you all satisfied with the IHC? Very specific question.
It's concordant with NGS.
Okay. So point here is NGS is now more convenient because in one sample you get everything. There is a discordance rate of actually 5 to 25% across trials. of IHC negative NGS positive. So TP53, don't be surprised if your IHC is negative by a local pathologist and suddenly the NGS report comes TP53 positive because there's a truncated TP53 where it won't express the protein. IHC really takes up the protein. So it won't, IHC will be not positive, but the NGS will pick up those truncated TP53. So my take home number one here would be that please try to do one go NGS. You do the TP53, you do the MMR, and you just do the poll anyway by it. Okay. The ERPR will come to that story in a minute. So this is something take home. Anyone who treats endometrium, let it be a gynecologist or let it be a surgical or a medical radonc, should do this molecular. Without that, it is a disservice to the patient. Very quickly, because in my practice, I see, sorry, nothing against any particular gynecologist here. It's a discussion of academic thing, which I want it to go academic. But many times I see a patient referred to, sent to, comes to me for a gynecologist, operated for maybe a DUB, did not look into the ultrasound, which had the thickened endometrium, did not do a biopsy, just did a hysterectomy. And now it has come as carcinoma endometrium. Less than 50% or more than 50% of the invasion will go later to my surgical oncologist, both of them. Vivek and Vikas, any one of you can take it. What do you do in such patients who have come to us in incomplete surgeries? I call this incomplete because nodes has not been addressed. How do you think this should be managed? Into the mic. Into the mic.
Hello. I would like to do the PET CT scan
You
to
do
assess
PET CT scan.
yes,
Okay.
to assess the any disease present or not in a
So
pelvic
PET CT
aortic
scan
process
is
or
in
the
two
steroid.
cases. There is no local disease because the uterus has been taken out very well by the gynecologist. PET scan shows in two scenario. One scenario it shows absolutely okay. The other scenario it shows a CT scan. Let's say a CT scan. Why PET scan? It shows a lymph node which is the smallest diameter of 12 millimeters. I've given you two scenarios. What do you do in there?
Then what is the pathological stage of the uterus?
Pathological, it is 50% in metrometrium invasion, endometrioid carcinoma.
Then I would like to do the bilateral pelvic lymph node dissection.
You would like to do the bilateral. Any difference in opinion? Radiation oncologist? No. Actually, if you see, this is something very beautifully done in NCCN. Here, the persons who come to us, this is a very practical scenario. You do a radiology. If the radiology is not showing a lymph node enlargement, you just can get away with the radiation oncologist covering that area. But if the lymph node is enlarged, it is more likely easy to go ahead and do the lymph node dissection, complete, stage it and go forward. So this is a quick thing I thought will be done. Okay, to my redoncs, before I go to the case, do you do EBRT or do you vaginal brachytherapy or where do you do a EBRT plus vaginal? Quickly, anyone? Anyone can
According
take it.
to stage, sir, we
Yeah, tell me which stages would you add a EBRT? I'll be more specific and direct to my question.
so according to current guideline, if it is high risk, then
What
only
would you define that?
just like a pole negative and a P53 is mutated. In that
Okay.
case, that comes into high risk, and we will add external beam radiation. Otherwise, if it is low risk, uh, then we can deliver vaginal brachytherapy.
I'll give an example. Stage 1B, TP53 mutate. What would you do?
And pole, sir.
You are now confusing yourself now. If I do a pole positive and TP53, what will you do? I'll now give you two questions. A TP53 alone, pole mutated and a TP53 mutated. Two scenarios.
Pole mutated means it is.
Pole and TP both are mutated.
Then it is pole mutated.
Okay.
We consider it as.
So you won't do anything.
Yeah.
And if it is TP53 alone?
Alone, then
You'll do EBR.
Yeah.
For this stage 1B.
Yeah.
Okay, we'll see this. Okay, so here I just go to my first case. 56 years old lady, operative hysterectomy, BSO, biopsy of the lymph node was done. Madam spoke about sentinel before this session. The myometric invasion is more than 50%. The negative sentinel node was bilateral. So as per old FIGO, it is 1B grade 3. So, Papuji, what would you do? What would you have normally done?
Normally, we will go for EBRT with brachy.
This one is EBRT with brachy.
Yes.
Can you support and back your evidence for molecular to do a EBRT in this patient?
As per POTEC 3.
So point here is, here there are two options. Either you can go for vaginal brachy versus EBRT plus vaginal. The only difference would be there is lesser pelvic recurrences with the EBRT addition, but nothing as a survival benefit. So that has to be very clear. So now you do that. So now I did a molecular, it is pole positive. What would you do now?
So
Same
we can
patient.
observe only.
Now it's a pole positive. What would you do now?
We can have option of observation only.
You can have it. Still, you would inch towards brachytherapy.
Yes, sir. Yes.
Where did we get this evidence from? Of going for brachytherapy in this patient now with this mutation? Okay. So you will differ?
Yes.
Observation. So this is a classical case. If this case would not have gone and done a molecular, the radiation oncologist would have gone for brachy for sure, plus minus EBRT. That is something controversial. The time is short. I won't go into depth of it. But once you do that, and 5 to 10% are pole mutated, you suddenly come to observation as a choice. And this comes from the POTEC studies, the retrospective analysis. When they looked at the pole, if you look at it, the highlighted part, no one relapses at all. There's no relapses even after 5 years, 8 years. So they're so good. So this is something that is very important. So from radiotherapy, chemoradiotherapy, whatever you could tell this is, let's come to observation just with a mutation. Number 2, I'll just skip and go to something. Pole. My medical oncologist. Look at poles, and we all love to write pole mutations. What are you looking at? And what mutations are you looking at? Do you read that green and red written by the lab reports, or do you also read the mutations in the pole? And
we
honestly,
should look into
क्योंकि
the
मैं
mutation.
एक महीने पहले तक देखता नहीं था. So be honest, what we see red and the green, or do you read the mutations?
Especially when it comes to pole mutation, we have to be careful. What is the mutation that is the pole mutation is showing, whether it's a pathogenic or not.
Yeah, don't remember this. Put it in your lab, in your on your table. This is the only 11 mutations. It is important. Rest pole mutations are not clinically important. So when you get a pole mutated, please make sure it is one of them. If it is not, it is null pole mutated as per our criteria. Okay. So we go to case number 2. Hysterectomy, BSO, sentinel lymph node, again less than 50% to my surgeons because you have operated FIGO 1A grade 3. You send it to Medon or you send it to Radon? You send to Medon, we will give chemo.
Just as an initial, you said in all cases of endometrial carcinoma,
What did you do pre in this?
I'll do the mutation analysis.
No, before that, in 3 years before, what did you do?
Oh, I'll send to radiation oncologist.
And you will do a EBRT plus brachy or only brachy? Only brachy. So this is only brachy, and now we did a mutation. It is TP53 mutated. Suman or any of my medonks, now you want to jump in? Because TP53 mutated, FIGO 1A grade 3.
So definitely chemotherapy has a role with TP53.
We are so happy to see
So
TP53.
different 3 years, 4 years back when we were not doing.
So I showed you a second example where it was just a brachytherapy and vaginal brachytherapy, 321 grays, if I'm not wrong with the doses. That's what it is normally. I'm not expert on that. But once you do and it's a TP53 mutated, suddenly my medonc, radonc also wants to give EBRT plus the brachy. And we want to give chemotherapy. That's it. Any difference?
So pole mutated na?
No, TP53 भाई.
Okay.
हमको कुछ तो करने दो यार. खाली तुम सब. So now this is a case suddenly from a vaginal brachy versus observation, we have jumped with the TP53 to everything because this is the worst category of patients actually. So this is case 2. Case 3 is what was already spoken about. Don't be surprised, 3 to 5% of patient, you can get multiple mutations. Means both MSI or the pole and the TP53 in combination. I'll just, because lack of time, I'll just tell you. If it is pole and MMR deficient, take pole as the most important. If it is pole plus TP53, take pole as the one. If it's MRD plus versus TP53, take the Means the example is take the better prognostic one. Do not take the worst prognostic. In endometrium, in contrast to other cancers, it is good prognostic that predominates. So anything that is better than the other, that has to be taken. And these are called multiple classifiers. So this is again something people have to remember. Once you do start doing NGS, 5% you will get these multiple classifiers, and you have to do that. So last thing what I will do is I will just go ahead and skip this to this last case and then go to cervix in the last 10 minutes. Anyone wants to take it? Madam. One lymph node is positive. Surgeon has done a beautiful surgery. One node is positive, and now it becomes FIGO 3C, if I'm not wrong. 3C. So now, what would you have normally done without the pole mutation?
Pole mutation would have definitely thought of giving chemotherapy and radiation. Even
And
radiation, yes.
But now it is pole mutated.
So I think we'll go ahead with the observation.
No radiotherapy? Where is the data? I showed you the POTEC data. My take home here will be, if there is a pole, don't do anything. Just observe the patient does not require actually anything. You may give radiotherapy. There could be little lesser loco-regional recurrences, but those are statistically not very clinically significant. So my take home from this last endometrium thing, looking at the adjuvant part is, even the lymph node positive, this falls into actually the new guidelines of ESGO into the plus minus lesser evidence. This falls into the incomplete evidence. I'll tell you something. I'm not telling that this is a pure called science because the level is not there in this. This falls into the gray zone. But what the authors have concluded, they would more likely for a pole mutation to go for observation and treat on recurrence and relapse. So this is something which I thought would be my last slide for endometrium. Just look at it. Look at the pole, look at the TP53. If it is pole, do nothing. If TP53, give everything to the patient. And if it is MMR deficient, chemotherapy does not work well. Immunotherapy, there is no evidence at this point for adjuvant. Radiotherapy, you can still go on. So for my medons, if it is deficient MMR, still chemo doesn't work. That's what Protect told us. So this is my take home from endometrium. Anyone wants to make any quick point before we jump to cervix? Yeah, please.
Here that I think we can say that endometrium is after lung. It is one of the disease where it is the disease is the king rather than
Biology is the king.
Biology is the king rather than treatment. So treatment takes the
It is changing everywhere so much.
seat back.
If you look at pancreatic cancer, this ASCO, the Virat thing has, sorry, that that the targeted therapy has made the best significant response. So everything biology is likely to be the king. Madam, you wanted to say quick.
Sir, one take home before closing about the endometrium CA, that as you already said that many a times patient of DOB operated comes and later on diagnosed as. So here the gynecologist is already there and I am from a gynecological forum. So I will like to say that before going for any hysterectomy, where a bit of suspicion is maybe there for the CA, then the diagnosis is a must, whether it is cervical or endometrial. The screening and biopsy is a must.
So I told that first thing, look at the ultrasound report that gives the story. If the endometrial is thickened, especially in the postmenopausal, please do get that biopsy done before we jump into surgery. That should be a very important take home message. That's what I started. Thank you, ma'am, for again reiterating that. 2 minutes, 2 scenarios quickly to my surgeons first. Yeah. I'll come to that. Sorry. Excuse me. That I understand. I had questions in the endometrium actually. Just quickly, ma'am, because we have to. What are the? Why do you think we have moved from the pathological classification, FIGO based classification, clinical pathology to a molecular? 1, 2, 3 reasons. Why do you think that the world has moved towards a molecular classification? And which are the two important histological types where you would be more inclined to give chemotherapy, radiotherapy more than the endometrial? So, two questions to you.
The world has inclined to the more toward the biological or molecular type because the the pathological classification is not sufficient, and the molecular classifications gives you that over the time we saw in the
Okay.
classification the pole mutation gave the favorable diagnosis.
And which
P53
and which two histological types do you think are very bad?
histological type it is actually the serous, and if high grade serous carcinoma is there,
And
clear
clear cell.
carcinoma is there. So if we get in biopsy, we should go for a aggressive.
So 2 points here, I'll just brief it. Why we went to molecular? There was a study where the concordance was seen between pathologists for even the pathology reporting. Surprisingly, there was 36% discordance between pathology centers. Point one. Molecular classification, in contrast, is more reproducible. And number three, it has changed the way we treat. So these are the three things why the world has moved on to this type of classification. For the poor thing, which is not applicable to this type of things, clear cell, she told very clearly, serous high grade and the undifferentiated. These are three varieties where we will err towards going for a chemotherapy and treating it much more aggressively, because they still will do bad, but they will do better than if you don't give it, they will do much worse.
One point
Yeah, quickly.
that we do MMR and all these things by molecular straight away. So I would suggest and take home message for all you fuel that the MMR should be done by IFC also. Sometimes there's a deficient, partially deficient MMR is also there.
I understand.
Be picked up in the your in
Okay. If there's time, I'll come to that part in the last, because I have to move on with 6 minutes, two cases. To my surgeons, cases there in front of you. Anything which you want to tell, what will you operate, and what is your surgery type? Very clear. Into my
Family is completed or not?
everything.
Completed.
Yes. I don't want to get into that fertility preservation. It will be another 5 minutes otherwise. Family part you leave. Let's put to oncological point. Family is complete. Patient tells you do what is best for her. What surgery? Operate? Yes. You agree. What surgery? Vardhans?
Radical.
Radical.
Yeah. Even the simple is possible, but
You are going for radical. I want a commitment here.
yes.
Yeah.
Vadaim's.
Okay.
Type 3 radical hysterectomy.
Any gynecologist want to take this and answer this? Vardhans. I knew this will be the answer that has come up. I'll put you the evidence and then I'll ask you what it is. This is the important data set. So simple versus radical hysterectomy, there is one big randomized trial. And the inclusion criteria is very, very important. And people have to remember, included stage 1A2, 1B1. So the maximum size could be 2 centimeters and not more. So I put that as 2 centimeters in my point. And the invasion should be less than 10 millimeters. Or on the MRI, it should be less than 50%. So, madam, surprisingly, if all of you look at it, there is no difference between a simple hysterectomy versus radical hysterectomy. And actually, it is in guidelines across the world that in this patient group, you need not go for a Wertham's. It is just a simple hysterectomy, which is sufficient for oncological outcomes. So this was my message number one, that don't look at cervical cancers and tell I will go for Wertham's for every type. Look at the 1B1 and 1A2. Once it becomes B2 and things, these are different, but till 2 centimeters with the stromal invasion, and look at MR, no one has, you have every right to offer the patient a simple hysterectomy, and this is a randomized trial NEGM publication. Number two, would you do a MIS or would you do open? Again, my surgeons. Commitment. Because this is an era of micro
2 centimeter MIS possible.
MIS.
MIS
I
preferable.
love when people commit, and then the slide will come something else.
Both can be possible, but data is not
against तो तुमको पूछता है और तुम ही बोलते हो सर मिनिमम इन्वेजिव करो मजा है 2 दिन में घर चले जाओगे यही बोलते हैं हम लोग ना
That's what MIS can be done, but data is not.
But open because you felt that something else was coming. Okay, this is the trial, and this is something important in endometrium. It is all MIS. In endometrium, there's nothing that trial which has shown that the open was MIS. It is inferior. But once you come to cervix, and I'll show you the guidelines, and this is the trial, again a phase 3 randomized trial. Look at the inclusion criteria. It is A1, A2, and B1. That same case which I told. Actually, MIS was oncologically inferior to open. So, take home 2 for people who operate. First is simple versus radical is well proven now. The MIS versus the open story, it is actually contrary to what people believe. The oncological outcomes is worse for MIS versus the open. So here we should be very careful for that group which I told less than 4 centimeters. Here the 2 has become 4. Please go ahead and do your open. Don't do MIS. Okay. This is the guidelines, and this guidelines is actually everything that I have told. That look at it and look at the evidence of harm, role of minimal invasive surgery on the last slide. There's evidence of harm if you do that. And this is something people have to remember. Don't jump into MIS for cervix at least till 4 centimeters. There you will do more harm than good, and your outcomes will be inferior, proven, and you will be legally liable. Yeah, I'll stop in 2 minutes. I know that. Last case, because radiations are there. Parametrium involved, stage 3C. I'm very sure my surgeons won't operate this. Okay. Still many operate, but they won't operate this. At least in the panel, they won't operate. MHARD is done. Common cell carcinoma. मजाक कर रहा हूँ यार. So now, please, anyone in the radiation oncology will ask you, there's a trial called Interlace. हम medical oncologists बोल के थक गए. Why are you not sending us for weekly Pacli Cabo? Just simple discussion.
We are sending, sir. If it is
Okay, accepted Interlace?
not in all cases, but in advanced cases, yeah. In these cases, we will. 3 week cases, we will send.
Okay. So if I
Not
take it,
2 week up to 2 week, we will not sending.
So stage 3.
We are bulky if there is bulky node or paratic node.
So you are telling it's a bulky node. Will my medoncs agree to interlace in a bulky node, large number of lymph nodes? Okay, I'll come very quickly. Time nahi hai. Are you convinced about interlace? My radiation oncology. Interlace is neoadjuvant chemotherapy followed by RTC. Yes. Tell you very quickly because time is not there. Interlace, the fiber OS is 80%. Embrace 2, which is the most top trial in radiation oncology, the fiber survival exactly 80%. So we are talking of 2 parallel trials. There is a lot of resistance because of rightful reason. I'm not criticizing it. But why should we do neoadjuvant chemotherapy unnecessarily for patients, which is there? The take home should be is that the Embrace actually embraced adaptive brachytherapy, which is MR guided. And MR guided brachytherapy ke bagair Embrace protocol is not there. I'm finishing. This is the mainstay, and no trial has been done to prove a CT guided adaptive brachytherapy versus the MR guided adaptive brachytherapy. Till now, there is hypothesis generating. This may be similar, but there are studies that it might be inferior also. So my point here is to everyone, till we are able to achieve this gold standard, which is MR guided adaptive radiotherapy, although there is still a doubt. A paper came out from Tata 3 months back. It was a propensity score match, not a randomized trial. They proved it to be similar, but वो conclude करते हैं, it is a hypothesis generating, and we need more trials to prove MR guided is equal to CT guided. So basically, the level of evidence for radiation oncologist is, if you can do MR guided adaptive brachytherapy, Embrace is good enough. You don't need neoadjuvant chemo. But if you cannot, for a country like India, where most of the patients with cervical cancer are poor, NSCT is covered by Ayushman Bharat or other government schemes, it would be very pertinent to do this. But the take home should be for interlace, give the radiotherapy within 7 days. The last point which I wanted to just tell you, interlace had low bulk lesions, mainly 2Bs, 3 where lymph node load was very less. If you have large lymph nodes, then immunotherapy really comes. So in a bulky node, I don't think interlace is a very good protocol. So I differ from that. Okay, I'll just conclude. So I conclude for 2 things on my cervical part. Sorry if I've done by 2 minutes. In the early, very early, 1A1, 1A2, B1, please 2 things I brought out: hysterectomy versus simple versus radical. It did not matter. Actually, simple was as good. And MIS is inferior to open. In others, Worthims is the standard of care. In endometrium, one can do MIS, one cannot do MIS in cervical cancer for the point which I told. CTRT, if someone can do adaptive MR based brachytherapy and a CT guided planning or MR guided planning, because the organs at risk will be much spared. It is good to do only CTRT as per the embrace. But if you cannot, in India, you can adopt the interlace, which is a neoadjuvant chemotherapy followed by CTRT. So this is where I'll end. And if there is any last message from the house, they can give it. Otherwise, I'm done. Thank you.
I would like to add to what Sahu has said. Ours is a high volume center for cervical cancer, and we have treated with interlace after this new information has come over 150 patients. It's really difficult. Please do not send any of your patients because the standard of care is concurrent radical CTRT. I can tell you only less than 10% have completed their EBRT with concurrent. They have so much of neutropenias and thrombocytopenias that if I remember, I don't think beyond third weekly, we could not give to any patient.
So two things here.
So we could not
So two things here.
take away the patients from a definitive treatment and
No, I partially differ here on evidence. When you look at interlace, it has its own lacunae. This is for some other day. We can discuss it over online Zoom also. Interlace is a not easy protocol. It is not for everyone protocol. One has to choose this patient. As I told, lymph node, large volume, don't do interlace. I'm very clear about it. Second point, which is there, is mainly a stage 2B tumor and a small 3A tumors. It is not meant for the larger tumors. We make it very clear. Number three, I do not stand by the thing that CTRT is the standard of care anymore. If it is standard of care, it has to be through a brachytherapy, MR guided adaptive brachytherapy. This should go as a message. Whether we can do it is our thing. If you cannot do MR adaptive brachytherapy, then interlace definitely comes in. That is my take on the evidence as it is. It is difficult. And interlace mandates a radiotherapy starting within 1 week of the last dose.
So same
maybe
kind of
immunotherapy may add.
same
Immunotherapy
kind
is
of
coming up that may add than chemotherapy. I feel.
So I totally take your point. It's a difficult protocol. But
Sir.
what I meant to say is conventional CTRT is no more a standard of care.
Sir,
That's my take on it.
I
stage
might
2B,
agree to that.
in stage 2B, size is very less. So we can do without MR guided also. Brachytherapy, in
सर
brachytherapy, we cover.
एम्ब्रेस ने जो बोला आपके लोगों ने जो बोला मैं उसी को बोल रहा
Okay.
हूँ और आपकी एस्ट्रो में जो गाइडलाइंस है मैं उसी को पढ़ के बोल रहा हूँ जिस दिन वो बदल जाएंगे मैं बदल
Dr. Sahu, one small comment on the trial which you have showed less than 2 centimeters, okay, for simple hysterectomy. So that's trial is a shape trial. So in that, you'll not believe 86% were with MIS. And the disease recurrence-free survival was similar to the open patients. So again, the problem with LAC trial is no uniformity, using uterine manipulators and exposing the vagina. Okay, so if you take due precautions, you can always do MIS.
One thing.
Yeah.
I totally know the criticism of the trial. I was aware of it when I prepared for it. What I wanted to do in this panel is I cannot bring in every nuances into it. I wanted our medical community to be safe from legal hassles. This is the recommendation. If you do a MIS in this select group, they go to court. I'm very sure the doctor will lose that case. So this is the guidelines. These are guidelines which are recommended by societies of society. And look at the evidence of harm is very clearly visible. We criticize the trials in a scientific forum, but what the message should go is there should be a standard of care. You can do it on one-to-one basis after discussing with the patient, but do not impose our thought on the patient. The patient should also be aware of this harmful thing.
No,
So I think they're telling me to stop.
Yeah. The problem, I'll tell you what, is with our own community. Say, for example, a surgical oncologist operates on a patient if he does MIS with explaining to the patient taking this thing. The patient goes to a radiation oncologist,
Parik sir is there.
He'll always say this the job which was done is inferior.
Parik sir is there. I will have one thing.
Yeah.
Produce the evidence and then we'll change. If the evidence is not,
Evidence itself is there in shape trial. 86% for MIS.
Sir, this is a subgroup analysis of something. Sorry. Yeah, thank you. Sir, Parik sir कुछ बोल रहा है.
So I must endorse what Sahu has said. that if we have to cover our ass first, we have to say that MIS is inferior, take the patient's consent and then do MIS.
That's what I told. Thank you.
Thank you, sir. I request all the panelists and chairperson, please felicitate our moderator and give a big round of applause. Audience, please.
किसी साउथ सरकार ड्यूटी चेंज करके सूर्यवंशी वैभव सूर्यवंशी
Here we have some announcements. We have a short lunch break here. 20 minutes, I think, good enough. So many of us, I think, hyperglycemic. And one important announcement.
There's an inaugural ceremony after CME at 7 p.m. where the chief guest will be our health minister, Mr. Shyam Bihari Jaiswal ji. So I request all of you after CME to attend this inaugural ceremony as well.
And I request all the panelists and chairperson, please collect their mementos from the memento podium. And I request Dr. Subi Noki madam and Dr. Chetna Ramani, please felicitate our panelists and chairpersons. And for the next session, just after lunch, we have a very important topic. And I request the chairpersons for the next session, please join their desk as Dr. Sarita Agrawal madam, Dr. Tabassum Dhilla madam, Dr. Preeti Agrawal, Dr. Divya, Dr. Ajay Sahai sir, and Dr. Sunita madam. Please assemble here in this hall after 20 minutes. I request 20 minutes for the lunch session.
Jimbal.
hello, 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 check, hello, hello, hello,
कैसा आ रहा है मॉनिटर में कैसा आ रहा है आ नहीं रहा है आवाज
hello, 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 check, hello, 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 check, hey, hello, check, 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 hello, check, hello, check, hey, check, hey, check, 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 hello, check, hey, hey, check, check, hello, hello, check, hey, check, hello, hello, check, hey, hello, hello, check, hello, check, hey, check, hello, hello, check, hello, hello, check, hey, hey,
अब अंदर घुस गए आ रहे हैं
check, hello, 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 check, hey, check, hello, check, 1, 2,
Yes.
So I welcome you all for the post lunch session. and I hope that you all don't doze off. For the session, I invite the chairpersons, Dr. Tabassum Dalla, who is a senior consultant at Jubesta Hospital, Raipur, Dr. Preeti Agrawal, who is director at Arogya Hospital, Raipur, Dr. Divya, who is associate professor, Department of Radiation Oncology, Raipur, Dr. Sunita Kanoi, director, Shashwat Hospital, Raipur, Dr. Ajay Sahai, sir, who is a senior physician at Sahai Hospital. So I would like to invite Dr. Amit Kumar Agrawal for his talk on the evolving role of immunotherapy in the locally advanced cervical cancer. Sir is assistant professor at Department of Medical Oncology, AIMS Hospital, Raipur.
So, good afternoon, everyone. First of all, I would like to thank my chairpersons, and I would like to thank Dr. Ravi Jaiswal sir and whole organizing team for giving me this opportunity. So, I'll be discussing about the evolving role of immunotherapy in the locally advanced cervical cancer. So, we know that immunotherapy is rampantly now being used. Various molecules are there in different indications, but this is one interesting thing, locally advanced cervical cancer, where the CTRT, conventional CTRT, has remained the cornerstone of treatment for decades, and now there is some change in the outcomes with the addition of this molecule. So the slide decks are provided by MSD team. So I'll be discussing about the unmet medical need in the cervical cancer and why there is need of multidisciplinary management and discussion. Also, how the addition of this agent, pembrolizumab, the Keytruda, can be a game changer in this scenario. So we know that cervical cancer is a very common cancer amongst women, and as per the Globocan 2022 data, it was the fourth most frequently diagnosed cancer, and with the third highest mortality rate across the globe. And by 2040, the projection is that the incidence is expected to increase by 31%, and the estimated deaths will increase by 38%. So despite of having so much of improvement in the armamentarium against the cancer, and probably the scope of improvement in this tumor or in this cancer is huge, because we are seeing the estimated deaths are going to be increased by 38% by 2040. So, as I told you about the epidemiology, the more than two-thirds occurs in the low to middle income countries, LMICs. And for last 3 decades, since 1990s, the concurrent CTRT, concurrent chemoradiation, remains the cornerstone or standard of care of this tumor for locally advanced diseases. And though it is a very effective treatment, high rate of recurrence is there after CRT. Almost 45% of patient will recur within next 5 years. And once patient becomes metastatic, either de novo or as recurrence, the outcomes are dismal. The 5-year survival rates are less than 20%. In India also, it is the third most frequently diagnosed cancer amongst women as per the Globocan 2022 data. And one systematic review suggested that around 37% of the cervical cancer are the locally advanced. Risk factor, we know that HPV remains the key factor for the genesis of this cancer, and that's why we have a very effective vaccine against this cancer. Apart from HPV, other risk factors like smoking, HIV, chlamydia infection, sexual history, all these are there. So why chemoradiation? So I'll just tell you about this chemoradiation for some of the non-oncology colleagues, because here in the chemoradiation, radiation remains the mainstay of treatment, and the chemotherapy is just to enhance the effect of radiation. So radiation shows its effect by directly doing the DNA damage, and also by the virtue of some of the free radicals. And chemotherapy, although it has its own effect as per the systemic effect, but it is mainly there to enhance the effect of radiation. So it is acting as radiation sensitizer. And as we know that chemotherapy, different chemotherapeutic drugs have different mechanism of action. They do it by the tumor cell killing through the deregulation of DNA, affecting the cellular metabolism or microtubule assembly, different mechanism of action. But they do have effect on normal cells as well. The cells which are proliferating, they will have this effect on all these cells. The mechanism of immunotherapy, if I have to tell you in the simplest term, will be like in our body, our immune system normally is able to take care of any foreign thing. Maybe it is any microbe or any foreign things. For that matter, the tumor cell are also a foreign thing or unwanted thing in our body. So normally, if immune function is proper in place, so it should be able to take care of any foreign thing, including the tumor cells. But the problem is these tumor cells have certain ways or mechanism to escape these immune phenomena. So this is called as immune escape mechanism, and that's why they persist and ultimately they proliferate. So if by any means we can inhibit those mechanisms of the tumor cells, probably we'll be able to, or our immune system will be able to take care of these cancer cells. So Keytruda or pembrolizumab is one such molecule. It is immune checkpoint inhibitor. It is a high affinity antibody against PD-1. So PD-1 is expressed in the T cells, and the PDL1, PD ligand, programmed death ligands, they are expressed on the tumor cells, antigen presenting cells. So if there is generally what happens, the tumors containing the PDL1 expression, this PDL1 will bind to the PD1, and this interaction will inhibit the T cell from activation. So these, though T cells are there, they will not be activated. They will not do their effect or their job. But if we inhibit this interaction, so we have anti-PD1 drugs, anti-PDL1 drugs. So Keytruda is a drug against PD1. So what happens? This blocks this interaction between PD1 and PDL1. So now T cells remain active and they will be able to take care of their action, and their job there is in the tumor microenvironment is to take care of foreign cells or to kill the tumor cells. So, what is the rationale to pursue immune checkpoint inhibitors in cervical cancer? So, we are talking about chemoradiation and adding the immunotherapy. So, cervical cancer, because it is a virally HPV driven cancer, so these virus, they have many ways of evading the immune system. So, probably if we do the immune system or if we check the immune system in place, probably we'll be able to take care of it. Then PDL1 expression is high, tumor infiltrating lymphocytes are very high in number there. And also, the cervical cancers have shown to be having high tumor mutational burden. So, this is probably the rationale that the immune checkpoint inhibitor will be active in this case. So, and how the synergy between radiation and immune checkpoint inhibitor plays. So, radiation does the damage of cells, and this damaged cells will release new antigens, and these new antigens will be expressed and they will be presented by the antigen presenting cells to the T cells. Apart from this, the RT also increases the tumor infiltrating lymphocyte density by inducing the kind of inflammatory state or chemokine release. And ultimately, it will facilitate the T cell infiltration into the tumor microenvironment. So, this is the synergy how it plays. So, Keytruda has been approved for use in the locally advanced cervical cancer along with concurrent chemoradiation, and it was based on the trial that was Keynote A18 trial. So, the eligibility I will be discussing in brief about this trial. So, in this trial, the locally advanced cervical cancer patient were chosen, and it was according to, the at that time there was FIGO 2014 staging system was in place. So they included stage 1B2 to stage 2BA patient with node positive disease. So a bit earlier stage with node positive, or FIGO 2014 stage 3 to 4A patient. They could be node positive or negative, whatever. And patient were treatment naive. no treatment received for cancer. And the exclusion criteria was autoimmune disease or any condition which excludes or which inhibits the use of these agents. So, and these patients were given treatment. There were two arms. So these patients were randomized into two arms into 1:1 fashion. In one arm, Keytruda was given along with chemoradiation. So in chemoradiation, we know that the radiation therapy is given for almost 5 weeks. And along with that, generally we prefer to give weekly cisplatin. And there was another agent. So in one arm there was Keytruda, and another arm, it was, since it was a placebo controlled trial, there was placebo. So Keytruda during the chemo radiation duration, it was given 3 weekly, 200 mg every 3 weekly for 5 doses. And after that, it was given as maintenance 400 mg every 6 weekly for 15 doses. So total treatment was approximately 2 years. And the other arm, in place of Keytruda, it was placebo. So this picture actually shows how the dosing was done. So initial, we can see the Keytruda was given every 3 weekly for 5 doses, and after that 6 weekly for 15 doses. And the chemo radiation, during the chemo radiation treatment, the EBRT was given for nearly 5 weeks, and during those 5 weeks, 5 weeks of cisplatin were given. So the baseline characteristic of all patients, we can see here the median age was 51, and the patient were of good performance status. The 93% of patients were having CPS score or composite the CPS score of 1 or more. And the patient of squamous cell histology, which is more common in the cervical cancer, was around 84%. Around 71% were the patient were having lymph node positive status. So the PFS and OS were the primary endpoints. The PFS with Keytruda at the interim analysis 1 and the second interim analysis both, it's shown to be improved by the addition of or by the Keytruda in the Keytruda arm. So at second interim analysis, the hazard ratio for PFS was 0.57. It means that there was 43% reduction in risk of progression with addition of Keytruda compared to placebo. And this is the subgroup analysis for the PFS. We can see here almost almost all subgroups, it is favoring the Keytruda arm. However, one important thing is we can see the stage wise, the figure 2014 stage wise, the stage 3 to 4A, the diamond as well as the it is completely towards the pembro arm, and it is not crossing the unity. The hazard ratio was 0.58. So it is favoring the Keytruda arm. So addition of Keytruda is favoring the improved progression-free survival especially in stage 3 to stage 4A patients. Now coming to overall survival, again at second interim analysis, the PFS, the hazard ratio for OS was again 0.57. So there was 43% reduction in risk of death. The overall survival subgroup analysis, again the stage 3 to stage 4A subgroup, it is favoring the Keytruda arm. Although in other subgroups also, many of the other subgroup also, it is favoring Keytruda arm. Now objective response rate. So objective response rate was slightly better in the pembrolizumab arm. The important point is 63% of patients of Keytruda arm were having complete response rate compared to 56% in the placebo controlled arm. So now coming to the response duration. So response duration was also at 24 months. Almost 77% of patients in the Keytruda arm were having maintained response compared to 67% in the placebo controlled arm. The important point, the patient reported outcome or the quality of life measures, they were similar in both the arms. So addition of another agent is not leading to decrement in the quality of life. Now coming to the safety data. So this table actually shows the different the adverse events, any grade as well as the grade 3 or more adverse events, and we can see almost similar adverse events. And since pembrolizumab is in use for almost I can say 5 to 10 years for last 5 to 10 years, we are well versed with the toxicity of the diagnosis as well as management of the toxicity of immunotherapy. So any new toxicity was not reported. So whatever we are well versed with, we come across those toxicities only. So based on this trial and evidence, the NCCN has approved addition of pembrolizumab with the concurrent chemoradiation for stage 3 as well as stage 4A cervical cancer. So this is, they have mentioned that FIGO 2014 base staging. So stage 3A, stage 3B and stage 4A. If patient is ineligible for cisplatin, we can use carboplatin instead. I know at present there is huge shortage of these drugs. Cisplatin is completely unavailable, especially in my setting at least. And carboplatin is, I have heard that it is going to be out of stock in near future. So Keytruda is a treatment option for these locally advanced cervical cancer patients. And I have told the evidence, there's good evidence that it is improving progression-free survival as well as overall survival in this set of patient. So this will be an addition to the WHO global strategy for cervical cancer elimination, because this elimination strategy by the WHO, it rests on three key pillars: vaccination, screening, and the early treatment. Vaccination, we know we have good cervical cancer vaccines available. So the WHO target is 90% of girls to be globally vaccinated by the age of 15 years. Screening, which is very important and time tested tool for cervical cancer. 70% women should be screened by the age of 35 years and again by the age of 45 years with high performance tests. So we use a pap smear. Early treatment, the goal is or target is to do 90% of women should be identified with the pre-cancer and they should be treated if they are diagnosed with invasive cancer. So this 90, 70, 90, this target, if we can achieve, then probably cervical, we can reduce the burden and the WHO goal is to eliminate this cancer. So this was all from my side. Thank you.
Thank you, sir. I request our chairpersons, please felicitate our speaker with a memento. I request our chairpersons, please collect their mementos from the memento podium. And I request Dr. Subhi Nakvi madam, please felicitate our chairpersons with the memento.
Next, we will be having panel discussion on current perspectives in ovarian cancer. And for that, I invite our moderator, Dr. Mehboob Basare. Sir is past president, ISMPO and Director of Medical Oncology, Jaslok Hospital, Mumbai. For panelists, I will invite Dr. Sudha Sinha from Hyderabad. She's a medical oncologist. Dr. Yashwant Kashyap, a medical oncologist at Raipur. Dr. Bharat Bhushan Khurse, surgical oncologist from Raipur. Dr. Rohan Tewani, medical oncologist from Hyderabad. Dr. Pradeep Chandrakar, medical oncologist from Raipur. Dr. Vikas Agrawal, surgical oncologist, Raipur. Dr. Karthik Che, medical oncologist, Raipur. And Dr. Kalyan Pandey, surgical oncologist, Raipur.
And I request Dr. Devpri Lakra madam also join the dais as a chairperson, and Dr. Nisha Jethani, Dr. Sushma Agrawal.
Good afternoon, and at the outset, let me thank the organizers and Ravi for inviting all of us over here and giving me the opportunity to discuss the advancement in the ovarian cancer. Okay, so we'll be having 20 minutes and I will try to stick to the time. We'll be discussing what's new in the advanced ovarian cancer precision pathways. So, what's the precision era, molecular profiling, what we are doing. The surgeons are also there, the surgical timing, and the maintenance therapy also will go on. So, everybody's there. Sudha, okay, so Yashwan, Bharat, Rohan. So, there are 3 surgeons and rest are the medical oncologists. So, 2 surgeons. Okay, so you are on this side. So, I know now whom to ask. Okay. So the current algorithm for all ovarian cancer patients, those who are in the early stage, the surgeon's role play a lot. So you will go ahead with the upfront surgery, adjuvant chemotherapy, and then observation, right? So you agree with that protocol. And when the patient comes to you in the advanced stage, so because most of the patient first come to the surgeons and then they come to the medical oncologist. So how do you go ahead with that? Is there any change in your upfront surgery approach for such patients?
So, if the patient comes with advanced ovarian cancer, you mean, so we'll assess whether we can achieve an optimal cytoreduction in such patients or not. And if in the general condition of the patient allows that extensive surgery, if that is okay, we'll still go ahead with the upfront surgery.
Okay, so you will see that whether optimal cytoreduction is
Yeah.
possible or no. How do you define optimal? Now, what is in your mind? Do you have some criteria to decide that?
R0
All those
resection,
indices?
R0 resection, I won't leave any visible residual disease if I'm operating upfront. That will be my criteria. More than whether the patient is able to tolerate the surgery or not, how much resection means, how many bowel resections is needed. All these things will play in my mind while I am planning for the surgery.
Okay. So there is a role of an upfront surgery, but majority of the patients who are in the advanced stage will go with the neoadjuvant chemotherapy. So at the time of initial diagnosis, let me come to my medical oncologist colleagues that apart from, so I will give one case scenario. Here is a 65-year-old female who presented with the bloating and distension of abdomen. She also had diabetes. And I straight away jumped to the PET scan, showed bilateral adnexal masses with omental caking, peritoneal lesions, and lesions over the liver surface. And there is an ascites. CA125 is 2000 and CA is 23. So how will you go ahead? Such patient comes to you, will you do only tapping for the diagnosis or will you ask for the biopsy?
Considering the patient presentation, I would like to get a biopsy also along with the ascitic type of
Okay.
for future molecular testing.
So future, that means you don't want to do you want to do
I
the
mean,
biopsy, but you don't want to do the test now.
most of the time I offer the molecular testing in the upfront, but because of financial constraints, they won't be able
No,
to.
don't discuss finances. We are discussing science. So just say
We'll
that
do biopsy for molecular testing in the beginning only, sir.
at the diagnosis. So do you see that CEAs and CA125 ratio as also is important, more than 25? It fits in that criteria. So your diagnosis is there, tubo-ovarian malignancy, typically.
Yeah, so this patient looks like a likely ovarian malignancy only.
Yeah.
So here I would be doing two things simultaneously. First, I send to the surgeon because they are the ones who have to decide resectability. So even though some things look clearly unresectable or interval cytoreduction, I always send the patient to the surgeon once.
Okay.
And then biopsy also. And if there is enough sample, I prefer to send the initial biopsy sample for HRD testing and all that.
So 2 people are saying biopsy upfront and they will send you that. The other 3 colleagues.
Inoperable upfront, sir, no doubt biopsy is required.
Okay. So only ascitic fluid cytology is showing cell block showing ovarian malignancy, adenocarcinoma.
No doubt, sir. So as we said, finances apart. So HRD testing and other, if we do upfront, I think that's going to favor the patient.
Will you do it?
Yes, sir.
Okay. So what are the things will you do upfront?
So at least BRCA and HRD testing, sir.
BRCA and HRD.
Sir, I will also do biopsy, and I will also, like few surgeons are they are saying they sometimes do diagnostic lab to reassess for PCI, because the post neoadjuvant, this patient will require further debulking surgery. So baseline PCI, they can do diagnostic lab or biopsy, but definitely we have burnt our finger. So we know that 5% cases it can be Krukenberg or something. So we if it turns out to be, so even if patient is going for upfront surgery, I will go tell them to do biopsy also.
You will go for the biopsy, but this cannot be Krukenberg because of that CA 125 to CA ratio.
Yes, sir.
Which is favoring of ovarian because it's more than 25. And obviously by IHC, we will prove that it is the ovarian malignancy origin. So we
Especially this ratio is important for some histologists like mucinous. It is very important if this ratio is high. And biopsy and molecular markers are important. We should go for, and especially BRCA1 and HRD.
Okay, so it's very important at the time of the diagnosis, one should do the BRCA as well as HRD, right? So the consensus has been that it has to be done, but practically, if I see that only 10% of the oncologists are sending at at the time of diagnosis, do you really send at the time of diagnosis, or you do at the interval?
So, if I'm taking the patient for neoadjuvant, then the first test I do is in a practical way. The first test I do is I send for germline BRCA mutation testing for the patient. And then once they start chemotherapy and then they are settled, I tell them about HRD testing and how it will be useful later. And that after surgery, it might be difficult to get the sample. So we'll send this and check if HRD is positive or not. Send it for HRD.
So this is the practical, that we are asking for the HRD to be done probably on the cytoreduction when it has been done on that sample, right? Not on the initial biopsy.
So sometimes patients have a very good response. And then when we do the cytoreductive surgery, we might not be able to get enough sample for the HRD testing.
Okay, yeah.
So that's always a conundrum that is there.
So what percentage of HRD positive patients will have good kind of response where you will have a PAXIA?
I would think about 30% of my patients will have good.
Okay, so 50% of the patients are HRD positive, including BRCA. So out of that 30% will have PAXIA. So at the time of surgery, with my surgeon colleagues, how do you see that on the table? Do you understand will be PAXIA, or there will be a lot of fibrotic tissues and residual tissues you will be able to see?
So for ovarian cancer, we definitely try to remove whatever tumor we see, and the fixed organ, like we have to do total abdominal hysterectomy and BSO omentectomy. We try to remove the general protocol, and any tumor, whether it is looking fibrosis or which is evident on pre-chemo scan, we try to remove.
No, my question was that when patient has received neoadjuvant therapy, vis-a-vis earlier wherever you are going for surgery, is there any difference in the handling of the tissue? Do you feel that there is a lot of fibrosis or other
The
things?
major bulk of the tumor is gone. Now the surgery is little easier than what you do. So because of less bulk, you have to go for a laser morbidity. We can say sometimes when the patient have smaller tumors. So if there is adhesion with the ball, which can be separated without injuring the mucosa and all.
Okay. You have any other opinion on that?
Post neoadjuvant, we find the difference whether there was previous disease or not. There will be a lot of fibrosis at the site of previous disease. Usually, but sometimes it becomes difficult how to map whether the disease was there or not. So total peritonectomy, probably I'll do for all the cases.
So the take home message is that one should do the HRD. BRCA, you can do the germline anytime on the blood, but the HRD testing should be done, and best is done on the initial tumor tissue because of the various reasons. Because it actually gives you the good yield. Because there are chances that post neoadjuvant chemotherapy, as these HRD positive patients are very sensitive to platinum, so response rates will be very high, and there will be a lot of fibrotic tissue even in the best labs, including the foundation one and the myriad. There are 20% times that HRD positivity at the beginning to the end can turn negative. So it is better that we get an HRD, and once if the HRD is negative, then probably these patients will be not receiving the therapy like that. So this is an example of a patient of the similar kind. So say 65-year-old lady, which we had diagnosis, HRD was positive at the time of diagnosis. Look at the pathologist may be able to tell you the dense tumor architecture of pre-neoadjuvant chemotherapy and the post-adjuvant. There is very scattered remaining. There is a lot of fibrosis and HRD came negative. Now this patient, if the HRD, if you are testing now, probably the HRD will come negative. Sorry, you will not start the patient on the other therapies, right? So how many of you look for the KELIM score, medical oncology colleagues? Have you heard of KELIM score?
I don't. I heard, but I don't use it at all in practice.
Other colleagues?
No.
No, from the audience? So Killam score is very easy. It's a mathematical equation. It just you have to look at the CA125 at 4 intervals, baseline, after second cycle, third cycle, and fourth cycle. So there are apps available. Just put the figures. If the score, Killam score is more than 1, then that and less than 1. So that's how it has been defined, and it gives you that those Killam score with more than 1 has a favorable prognosis. That means that these patients will do well, and that also correlates with the HRD. This is just simple CA125. This is nothing to do with anything. And that Killam score more than 1, the surgeon colleagues will be happy because there will be lot of what we call as the chemotherapy response. And this is the data from the Killam score that the score is more than 1. In the blue, you can see the survival is good as compared to yellow. And this Killam score has now being incorporated into the ISMO guidelines. So one has to be aware of the Caleb score, and it's a mathematical model of dynamics of the CA125, how much it is reducing and what interval it is reducing. So we are anyway doing CA125. You have to just put that into the equation and do that. And that also predicts the chemotherapy response score 1, 2, 3. And we all know that chemotherapy response 3 is the best one, that where less than 5% of the tumor is remaining, while chemotherapy CRS1, where 95% of the tumor is still there. So surgeon colleague, so let me ask you, how many times you see that CRS1 is achieved after the initial chemotherapy?
In our data, we get in around 60% of cases.
60% of the patients. So no response at all. More than 95% of the tumor.
No, means response we get CRS3 we get more than
So CRS2, you may be in between coming that.
Yes, sir. Around
60% is it's huge because by standard 50% will be HRD positive, and HRD positive will show some response. So that's CRS3 will be the response. And the other thing what I was also going to show you, that if the patient has HRD positive, including BRCA, so I will not keep the BRCA separate, but HRD positive, achieving CRS3 is almost 88% chances there. So that's where this 50% of patient you should be doing the testing at baseline, right? So that's an important message. Which this is the MD Anderson cohort, and which has been found that, and they have put it in mathematically that those patients who are having the HRD, there is a 5 times more of achievement of CRS3. So yes, so this is an important. So the surgeon said that they will like to assess and go ahead with the surgery. So there is a trust trial. Okay, this trust trial has shown that if you go ahead with the surgery upfront, there is a better PFS and there is a better overall survival. But the patients have to have the all those indices. I can't pronounce also the indices. Do you see all these indices? Value and Vesely score and Fagotti and predictive score.
No, sir, not routinely. We look for whether whether the patient can tolerate this much surgery, depending upon the imaging. Yeah, so these values we don't practice on a day-to-day basis.
So this was presented last year in ASCO, and this is the slide from the last year ASCO, and showing that the patients have to be evaluated from this scores point of view to assess Now your assessment is based on radiology and what is your gut feeling. But these are the objective selection tools. Any one of you follow that? My other medical oncologist colleagues?
No, sir, we routinely don't follow.
Practically, what we do if there are peritoneal deposits, hepatic deposits, liver surface deposits, peritoneal deposits, if CA-125 is more than like 1500 or 2000, general condition of patient is poor, we directly submit them for chemotherapy after biopsy. If general condition is good, if the patient's general condition is good, if there is doubt whether we can operate or not, then we go for Fagotti score.
So do you believe that neoadjuvant chemotherapy and going ahead with the upfront surgery will have similar progression-free survival and overall survival?
No, we know.
With medical oncology, yeah. Because they decide about the giving the chemotherapy or no.
Both, first I want to address this trial, sir. This is a negative trial. Actually, there is no OS benefit with this trial.
There is no OS benefit. Definitely, yes.
The hazard
PFS benefit is there. Hazard ratio is not.
OS benefit was negative in this trial. Hazard ratio was crossing the confidence interval of 1 in this trial, actually.
Yeah, I agree with that.
And before this trial, there was no difference with the NACT and the upfront or primary debulking surgery.
Okay, last two minutes. Let's discuss about the HIPEC is also an important in the current era. Okay, so my medical oncologist colleagues. So HIPEC, how many of your patients go in HIPEC? Right from the right side.
Not routinely, sir.
No?
No.
Selected patient post NACT.
Post NACT.
If very
Because data is maximum in the post NACT rather than upfront and in selected patient. Which are selected patients?
stage 3, or HRD negative, BRCA negative.
Okay, surgeons?
Yeah, and patients go for a HIPEC, provided finances are not issue. Post chemo with good response, HRD platinum sensitive, all cases we take for that.
So there is a trial going on from the GOG group called as HUT trial, and because this hyperthermia is there, those patients who have an HRD positive, HIPEC has given doubling of the survival at the end of the 10 years. So HIPEC works best in HRD positive. HIPEC has no data in BRCA positive, and HIPEC in proficient patients of the HRD, means HRD negative patients. That depends on your regular data. But even in the select patients, probably it may be used in that. So let's come to the maintenance therapy, and last 2 minutes we will cover with that. So my colleagues from the right side. So if the patient is HRD positive,
Yeah.
so which maintenance you go ahead and give?
Basically, drugs like rucaparib, like we can go ahead, and BRCA1 we can think for other PARP inhibitors.
Okay, so for HRD, yeah, go ahead. Everybody can comment on this.
Sir, olaparib and bevacizumab option.
For the HRD positive, yeah.
It all depends upon how good your patient tolerated. Gives me a pointer. Plus, discuss both single agent plus dual agent. Both looks to be similar, but given a choice, no doubt, if possible, then Bev plus ARP inhibitor maintenance.
So if it's a high risk patient, HRD positive, I do Bev plus olaparib. If it is a regular run of the mill ovarian cancer, not very high risk, then I do only olaparib, even though the data is for niraparib in HRD positive patients. But I more from an ease of use, I think I do olaparib more out of.
So we have the data from the Paula one. So if patient is HRD positive, so we have the highest record with the BRCA positivity. If the patient is BRCA positive, patient doesn't need other than any PARP inhibitor. So olaparib is the best. But those patients who are not BRCA positive, but they are HRD positive because of the other genetic, they are not as strong as BRCA NACE as compared to the BRCA. So they need one SAHARA of the bevacizumab. So if the patient is HRD positive, olaparib and bevacizumab are must. You cannot give single agent. Niraparib has a different data altogether. Yes.
Paolo one trial, actually, I agree with you, sir. In the bevacizumab has not shown any OS benefit before PARP introduction also.
Okay.
It only in a selected subgroup of stage 4 and incompletely resected stage 3, it had shown a OS benefit. In follow one trial also, they had a post hoc analysis of risk stratification based on the clinical. Whereas high risk and low risk. Low risk is the stage 3, which is completely resected, but had shown a PFS benefit, but not a OS benefit. OS benefit with adding beva and olaparib was only in high risk, like stage 4, incompletely resected stage 3, and residual disease of more than 1 centimeter. And if patient had received bevacizumab in the upfront, then we can add a bev plus olaparib. If patient had not received a bev in the upfront, then we have to use only single agent olaparib.
No, they all of one trial patients have included who have received upfront surgery also. Not necessarily that you have to receive. 3 cycles should be including the bevacizumab. Not at all that it is that they have to receive the new adjuvant therapy. Even the adjuvant therapy is also.
Adjuvant only.
And if you say that OS advantage, you in postmenopausal women, you ER positive, you use letrozole instead of the tamoxifen, right? Everybody uses. What is the advantage? OS advantage is there over tamoxifen. There is no OS advantage. So we always look for the disease free or progression free or relapse free survival. So bevacizumab has a role in PFS. OS benefit is seen in only those patients who have a residual disease at the time of surgery. But bevacizumab has a role. Yes.
Use bevacizumab with chemo.
Yes. Which trial you are saying? Paula 1 has the patient included, including the new surgery upfront followed by later.
Surgery upfront, those who are inadequately dissected or had stage 4 to start with, those were the subgroup who received bevacizumab. But those are the group in ICON GOG which benefited. So what he meant, I just want to, that's what he meant, that if you have not given bevacizumab with chemotherapy, let it be in pure post primary cytoreduction or maybe neoadjuvant, whatever condition, you just think of a scenario of giving only chemo, completing the chemo, then you had a BRCA positive, and then you add Bev Pola. That is not what Pola tells you.
So, but upfront only now you are doing. For example, stage 3 patient. See, we are talking of stage 3, stage 4.
Inadequately resected.
Inadequately resected.
So you can give.
So you know initially only why you are not going to give bevacizumab.
Yeah, you will give. So
you will give.
But if you only give chemo, then there is no role of adding Bev as a maintenance. And then that's what
You should not give only that. Bev has to be added from the beginning.
So I think
That's the group where it has shown the OS benefit, not just PFS, but the OS benefit also. I think the probably time is getting over, and thank you, my panelists, for the discussion. Thank you very much.
Thank you, sir. I request our panelists and chairperson, please felicitate our moderator with a memento. And I request our panelists and chairpersons, please collect their mementos from the memento desk. And I request Dr. Chetna Ramani, please felicitate our panelists with mementos at the memento podium. Next week. How are you? Our next topic is panel discussion on identifying and treating high-risk early breast cancer patients. The moderator for this session is Dr. Ghanshyam Biswas from Bhubaneswar, and the panelists are Dr. P. Gopal Mohanty from Bhubaneswar, Dr. T.P. Sahu sir from Bhopal. I request Dr. Sarita Agarwal madam, Dr. Bhimra, Dr. Anshu Gupta, and Dr. Manisha Sharma. Please join.
So all 3 ODIs in the stage. So सोफे वाली चेयर तो पखाल लाना पड़ेगा फिर. Oh, so madam belongs to ourselves. So thank you, Ravi, and thank you, Lily, for this opportunity. So straight away we'll start with the first case. And before that, so I'll ask TP. So before Monarchy, before Natalie, so who are the patients and how do you qualify high risk node positive HR positive disease? So
Before the monarchy and all the CDK adjuvant came in, we all used to look at node positivity, T size higher, grade higher. These were the main three things what we used to look at. These were the high risk where we used to give prolonged endocrine therapy.
age, menopausal status.
Age menopausal, the LHRH agonist usually used to come in, although we believe that the younger used to do much worse. But I think the benefit of LHRH agonist is much better, which we are underutilizing it. For me, it is more of the T size, the more of the nodal and the grades.
So probably monarchy brought those concept of high risk in a HR positive disease, and then then slowly understood that probably it's all node positive are not the same. So this is a 51-year a postmenopausal lady, fit and healthy. So December 2024, a right breast mass of 2.1 centimeter on an ultrasound, enlarged nodes. So IDC grade 2. So ER strongly positive, PR low positive, HER2 1 plus. And node FNSC was done, invasive cancer, CT staging workup. So no metastasis. So ideally, this patient went into a surgery, a BCS with axillary lymph node dissection, and in the MDT, so molecular profiling oncotype was asked for. So Sri Gopal, so in these patients, so will you do a molecular profiling?
So in adjuvant setting, in this T2N1 with high-grade tumor, upfront, I'm not going to do any molecular testing. But yes, so as per the data, we can do like to see the the post hormone therapy, the high risk feature, like any chance of progressing to hormone therapy, we should do the study like
Yes.
particularly ESR1 and those big three mutations.
In this, with the present era, present evidence, I will do.
Right.
I will do the oncotype or the mama print at least, and now we have the Optima, which we discussed 2 days before.
Right.
She is postmenopausal, she is above 50, she has N1, so below 3 nodes, and this is the right candidate group where I will do a genomic classification of the risk score so that she might be saved off chemotherapy.
Absolutely. So now, so we look at the pathology post surgery. So post surgery is a grade 3 tumor. So LVI positive. So 2 out of 18 nodes positive, ER strongly positive, PR low positive, and HER2 2 plus. PI 67 up 25 to 30%. So Sri Gopal, so on a core biopsy, it was grade 2. On a histopathology, it is a grade 3. So how do you act on this? So you'll take the higher grade.
I'll discuss with pathologists. So post-op specimen, I will be more preferring. I'm sorry, the previous one you're talking about the RX responder. Yes, the oncotype X. I should be doing.
So TP, so
I think I'll take the higher grade
Higher grade.
because core biopsy is a representative tissue which is limited tissue. So if the upfront, if the grade 3, I'll take the grade 3 as the highest grade.
And there are many a times you have seen 10 to 12% discordant among the receptors also. Then what do you do? Without treatment, because on treatment of especially HER2, so there is a downstream, there is a down regulation, but sometimes the hormones.
So as per my understanding, I will take the things which is positive and the higher thing. If there is a HER2 negative and the others whole specimen, there is a section which is HER2 positive, I'll take it as a HER2 positive disease.
So this was basically a stage 2 T2N1 M0 stage 2B, and so oncotype DX showed a recurrence score of 23, and so according to oncotype, so 6% the 5 years risk of distant metastasis with AI or tamoxifen, and average absolute chemotherapy benefit is less than 1%. So now, so again, Sri Gopal, so now you have done an oncotype DS which is showing 23, but grade 3 tumor, 2.1 centimeter, 2 nodes positive, LVI positive. So will you act on what the oncotype DX, or you will bring into the clinical features?
So now separately, if we are thinking about adding chemotherapy, so I won't be considering grade 3 because already we have the if you look at the mama print, the MINDEC trial also, like from that
So DBs with like patient with high clinical risks and lower genomic risks, still they don't get much benefit from adding chemotherapy. But while deciding for adjuvant CDK4/6, so at least in this high grade tumors, when there is a high grade tumors, even as per the Natalie, I can go ahead with adjuvant CDK4/6. Although with monarchy in this cohort, if it's a low genomic risk in a grade 3 tumor, 2 centimeter tumor, and N1, yes. So still we can go ahead with the monarchy data.
So
Like
TP now,
basically.
so you'll go with the Oncotype DX, or you rely on the clinical and
Oncotype DX, what to my understanding is something that only gives you the benefit or quantum benefit of addition of chemotherapy.
Right.
It has nothing to do with this, and even monarchy post hoc analysis did prove that it did not matter. Although naturally, in the super low T score, T stage, stage 2, that early one, they had this which we don't know the benefit as such. But here, I won't consider my CDK4/6 based on the genomic assessment score.
So we do understand that high nodal burden is a high risk. So TP, so do you buy now? By this time, the Natalie reports are out. So do you buy N0 high risk in clinical practice?
This patient is high risk.
No, N0 I'm talking. N0 high risk.
N0 high risk, I believe, yes, there is a group.
So you started offering Ribo?
If I get the right patient with deep pockets, I do offer, because I think the patient has the right to it. Although the quantum of benefit is lesser, but I still believe the Natalie has shown, or at least on limited survival follow-up, that there is a benefit of on terms of IDFS. So I would be more inclined. And the latest Natalie, which was read out last few months back, the last one, it showed similar benefit in both the N0 and N1. So I'm little more convinced now that there is a group of patient even in N0 which can be high risk, and the relapses can be much common.
So Sri Gopal, so early TNBC and a high risk node positive, HR positive. So in terms of recurrence and mortality, so they behave the same way. So do you agree to that?
Completely agree to that.
So this slide shows recurrence in a high node positivity is almost the recurrence are almost like a TNBC, which is supposed to be a bad and aggressive disease. In terms of mortality, you see the graphs are almost the same. So TNBCs and the N positive high risk HR positive disease, so they behave the same thing. So now TP, so N1 high risk versus N1 low risk. So are they different biologically now?
Unexpectedly, yes, they are different, and you do see in these curves that they are
So
doing.
we have seen, so monarchy shown that 1 to 3 nodes. So either with a grade 3 tumor or more than 5 centimeter tumors, so they were considered as a high risk. And this slide shows that. So in one high risk, can see the 5 years recurrence of 25% vis-a-vis 10% in the normal risk. In terms of mortality also, that remains the same. So Sri Gopal, so what is your view on now 7 years? So we are talking about monarchy 7 years, crown trial 7 years. So 7 years is a landmark in last 25 and 26. So in terms of monarchy, 7 years IDFS and DRFS data.
So you are having the longest data of this monarchy, 7-year follow-up data, IDFS delta of 6.9. So definitely it's looks very interesting and promising. So yes.
So TP, you can see the curve. So 3.2, 5.2, 6.2, 7, and suddenly 6.2, there is a drop. Again, there is a 6.9. So we have seen this in COVID times. So probably many patients died of this. So nothing was happening here. No COVID time. But
I understand, but I don't read too much into that. What I read consistently is there is a increase in the delta over from 2 years onwards, 2 to 3 years onwards, seventh year, and it has been only staying, getting better or at least similar. So the benefit is there, and it gives you a confidence that, and you are stopping the hormone CDK4/6 at 2 years. So mind you, so these are patients, most of them post 5 years also, there is a carryover effect.
so why that is happening? So you have stopped the drug now 5 years back, and in terms of IDFS and DRFS, the benefit is continued. So the delta is still maintained. So what is the reason for that?
So that's what I'm talking. There is a carryover effect. Like if you stop hormone therapy, we saw that carryover effect. Even in stoppage of hormone therapy, also we saw the carryover effect, which is there now with CDK4/6. And last point is that metastatic free survival also gives a confidence that you are having lesser patient with incurable disease. So that is also a benefit.
So with Monarchy, so after the trial results are out, so we did not buy KI67. And suddenly Natalie came in, and then so they bought the importance of KI67. So Sri Gopal, what is your take on this slide?
So irrespective of everything, K67 is a bad prognostic marker. So K67 more than 20%, anyway they are going to do worse than K67 low. So so far as monarchy is concerned, irrespective of K67, so in both the cohort, they got benefited by adding CDK4/6 in the early high risk category. So even if K67 low in the monarchy cohort, they are going to get benefit with CDK4/6.
So if you see this slide, so of oncotype DX, those patients, so those scores were less than 25, but you see the because probably the physicians took the clinical and the pathological into consideration. So the monarchy, the patients were benefited. So patients who received CDK4/6 with Abima got benefited. And you can see, so 0.59. So that was in favor even in the patients who had a recurrence score of less than 25. So how important is the significance of OS and endpoint in adjuvant treatment for early breast cancer, TP?
It is. It is. All of us.
So we are waiting for that.
Yeah, it is still maturing. It's a operable hormone positive breast cancer, and we know that relapses can happen very late in hormone positive. There's a two times the relapse happen once in the first 2 years, and then most of the disease can happen after 10 to 20 years. That time.
So when was the last OS for any regimen in a HR positive? So that was positive.
So I was coming to that. So point here is the OS is an important factor. What you asked me is OS important? It's very important. IDFS is supposed to be a surrogate marker where it is already positive. If OS comes as positive at later point, it will be very good for the drug and the patients. But there are many confounding factors, post progression treatments and everything else, which has to be factored in. So my point is, I would love to see the OS positive. If it doesn't, the quantum of IDFS benefit also will be important to me. That is my answer.
Right. So the irony you can see in a metastatic disease. So the palbociclib came, so PFS benefit, but could not show over the years of OS benefit. So ribo came later, but showed a benefit across all subsets in a metastatic. Again, so there were plus minus in Abima in a metastatic disease. But this drug in a adjuvant setting, at least after so many years, they have shown a advantage. So if you look at tamoxifen versus no tamoxifen, so there was almost 10% at 5 years. Then AI versus tamoxifen was Dr. Mehboob was alluding to. So at 10 years, almost 2.1. But an extended AI, so it was not even a 1%. So Ravi, want to say something or no? So what is your view on the latest monarchy OS data, Sri Gopal?
Looks okay, sir. Delta up like 2%. So like okay. Maybe still waiting for the more mature data. The hazard disease looks still okay. 0.83 is not less, not too good. So maybe I feel like we are in a like juncture where we need more longer follow-up data. Still the delta, if you see 2% is not less when you talk about the adjuvant setting in breast cancer, HR positive, HER2 negative.
So TP, now the $1,000,000 question. So what next in an adjuvant setting? So we discussed 2 days back in your webinar only. So in an adjuvant setting in a high risk population, a similar situation. So what next after monarchy?
We are looking at ESR ones
Right.
front.
So
But
probably
point here is I would love to see our patients premenopausal, especially getting all of them getting the LHRH agonist. If you look at that and if you can implement that much, I think it will create much more impact on the IDFS and OS in contrast to what monarchy. This is definitely useful, but all of us are forgetting the addition is still dismal in our practice. Sirs, there are others, I don't know. That is dismal. We don't think of it. We don't think that node positive should be receiving LHRH agonist, even if you're giving TAM. I would love to see that LHRH agonist effect be there. So I strongly believe that is one area we need to work upon in the society. This definitely for those patients who can afford it. This is definitely a drug that should be offered, and now we have to achieve it.
so Lidera is a positive trial. So now probably Gardescent along with CDK4/6. So that
we spoke in that it is still needs further data.
No,
It is still very early.
something on the horizon. It looks
Yes,
like.
so only good thing about Geradistant is that the tolerability is very good. So that is something that probably will work in his favor, but I don't think I'll change practice.
Right. So now the guidelines, Indian guidelines are there. So the guidelines people are here. So TP is also part, and I was also a part of this. So ASCO guidelines. So strong evidence for both Natalie and Monarchy, but probably the strength is more for Abima. And these were on the Indian ISMPO guidelines, and so where you can see, so 2 years of Abima and 5 years of AI still. So now dose, Srigopal, so dose reduction. So we have seen this in a metastatic disease. So did not matter much. So as you go on, so there is a first level dose reduction, second level dose reductions. So how does it?
So dose reduction basically doesn't affect the outcome, but still what we do is like start with the maximum dose, then you step down as per the tolerance. Not to start with 50 mg, to start with 150 is for the standard recommendation. Then if the patient doesn't tolerate, then come down with the step down the dose.
TP, if the dose doesn't matter, then why don't you start with the lower dose? So we have to prove a trial. Do a trial.
I think I would start at a lower dose as such till it's a very old, frail patient. Other than that, 1 to 1, I think I agree with my colleague here. Start with the full dose, but what this trial gives me the confidence is be careful for the toxicity and do not hesitate to give a gap when the toxicity is grade 3 and restart at a low dose. You would not be affecting the efficacy to start at a low dose, because I'll tell you one thing, nearly 50% or more of these patients tolerate the full dose. So we are forgetting the other part of it. So what my take is, be careful, counsel the patient well. Diarrhea is a very important side effect. Weakness, generalized asthenia is very important. So be careful. Do not hesitate to reduce the dose, but do not start it at a low dose.
Srigopal, really has the diarrhea bothered you in a metastatic setting and in an adjuvant setting?
Really, it's well managed conservatively, but sometimes like in very frail subset, then like elderly frail patients, sometimes like one case didn't tolerate 150, 100, I had to go down to 50, but most of them tolerate 150.
So maybe in ODI population, dahi and pakhala has helped. So
I'll tell you one thing. I totally have a little different viewpoint. Mehboob sir is there. Others that have given more Abima than I have. Adjuvant Abima is not as well tolerated as a metastatic. I feel for two reasons. In metastatic, the disease load is too much. Patient is worried about a lot of things. Here, patient has completed the chemotherapy. They are mentally out of it, and suddenly we are giving something that is toxic. And these patients usually are young and has a, so I feel what in my limited experience that adjuvant part, it is doable, tolerable. You need not stop. You may reduce it, but it definitely bothers the patient because mentally they feel chemo khatam ho gaya, I am out of it. And suddenly you're giving a drug that has this toxicity. I don't know how sir's
so
experience.
finally nail in the coffin for you.
Sir.
Yes, sir. So by the time sir answers, so for what is your
Sir,
choice?
agreed with sir that in adjuvant setting we are facing more toxicity. I would like to hear from patients. Yeah, expectation is better.
So as far as ribociclib is concerned, in my whatever the patient I have used in adjuvant setting, people are not tolerating. But abemaciclib they are tolerating because most of the abemaciclib patient where we have given they are high risk. Remember that it's like metastatic where we tell the patient that you have to receive.
So do they have more do they have more adverse events also and more concern in adjuvant than in metastatic is the question.
Yeah, that's why I'm saying, the patients in the adjuvant setting where they are receiving abemaciclib are more than 4 nodes positive, right? So they are high risk. So I always prime them from the beginning that this is a part which is going to extend for 2 years more.
So TP last question, last N2 and 3. So your choice, ribo or abema?
Two things. One is the data, evidence of data, because it has more mature data set for Abima. I think that is a green tick for Abima. If there is a patient with irritable bowel syndrome, has diarrhea as a history, I'll probably be more comfortable with the ribo. If the patient has more predominance for liver toxicity, I'll be more comfortable with Abima. So what I mean to say is the patient also important, and also if I look at a patient who doesn't have any risk and is still eligible for both the drugs, I will probably go for Abima for two reasons. It's a shorter duration of time, 2 years alone versus 3 years of Ribo. And this has 7 years follow-up, and ribociclib unfortunately is 2 years behind. So that's my take.
So Srigopal, last question. So N0 high risk, the patient is contraindicated for ribo because of a cardiac event. So will you replace with abema?
I'll go for substitute data in spite of Abhima.
You'll go for?
Like in high risk N0, still I'll go for substitute data rather than going for Abhima.
Okay.
But I would agree with Mahbub sir that in N2 and 3, I'll be more inclined to Abhima because of better tolerance what in my practice I have encountered. And also like the
Mature data, so you are looking at an
Also,
OS.
so- and step-
Every medical oncologist halves for an OS.
and step down dose schedule is there. We can adjust the dose.
Don't retain N0. So that was a hypothetical situation. So that's why I asked. Thank you.
Thank you, sir. I request our panelist, please felicitate our moderator with memento. And I request our panelist and chairperson, please connect their mementos from memento podium. I request Dr. Neha Jain, again, please felicitate our panelist with mementos at memento podium.
नहीं तो इसके यही लोग हैं। So we continue with breast cancer sessions and next ये क्या? Next topic is 5 practice changing है ना? Sorry. Practice changing updates in breast cancer, for which I would invite speaker Dr. Sudha Sinha, medical oncologist from Hyderabad, and the chairpersons for these sessions are Dr. Madhuprita Agrawal from Ashoka Hospital, Raipur, Dr. Preeti Singh from Devi Hospital, Raipur, Dr. Subhash Agrawal from Devi Lakshmi Hospital, Raipur, Dr. Reshu Agrawal, Dr. Shilpa Pawar, please join us. ये नहीं है।
Over to chairpersons.
A very good afternoon to all of you. Today, the topic of the session is 5 practice changing updates in breast cancer. And we would like Dr. Sudha Sindha ma'am to further throw light on this.
Thank you. And firstly, thank you to Ravi for inviting me second year in a row. The conference is going bigger and it's really nice to be here. So the 5 practice changing updates. I think all of you are very esteemed oncologists and most of you know this. So I won't take too much of your time. I've divided it into HER2 positive, ER positive, and triple negative breast cancers. So this is the first one is the Destiny Breast 09 trial, where they had patients with metastatic breast cancer and randomized to TDXT with pertuzumab, and the standard of care, which is THP arm. And the primary endpoint was progression-free survival. And stratification factors of HR positive or HR negative and PIK3CA mutations, which are known to be poor prognosis in patients with HER2 positive breast cancer. And here what we saw is a whopping improvement in progression-free survival in the TDXT with pertuzumab arm. The median PFS was 40.7 months compared to 26.9. So this is definitely a practice-changing trial. This combination has been approved by FDA. We are still waiting for the solo TDXT arm and to see what the results will show. But amongst all subgroups, the HR positive, HR negative, the PIK3CA mutation also, where we worry about, there too we are seeing a duration of response of close to 3 years. In the current ASCO update, where they presented the subgroup analysis, they showed that patients who had complete response and even very good partial responses had very long duration of responses. And the time to response is just 1.5 months. So there are some issues here. I think we are all used to giving TDXT and know that it's not an easy drug to give. So giving somebody TDXT for 3 years with the fatigue and the nausea, not fun for the patient at all. So how do we use this drug? Do we give it to everybody? Can we choose patients, maybe patients with brain metastasis, the PI3 kinase mutation, or high visceral burden? This is something to look forward to and see what happens. There is a lot of talk and trials about induction and maintenance. Can we use ctDNA to see maybe we can give TDXT for a while and then stop it? So these are all works in progress, and bigger question is what to do in the second line once somebody progresses on TDXT. Moving on from the metastatic to the neoadjuvant and adjuvant settings. So this I am going to present both the trials in combination. In the neoadjuvant setting is the Destiny 11 study. So this was a randomized phase 3 study where they took high-risk breast cancer patients. So the breast cancer patients, high risk was defined as T3 and above. Whether they had node positive or not, and if it's T0 to T4, nodes had to be positive, or inflammatory breast cancer patients. And these patients were once again randomized to 3 arms: the TDXT arm, TDXT THP, 4 cycles each, and the standard arm of dose dense AC and THP. The TDXT arm, they thought that it is not going to show any superiority, so that arm was stopped early. So we have only 2 arms to look at. Primary endpoint was not PFS, the primary endpoint was pathological CR. And in the Destiny 05, this study is like the Catherine study. Here you're again choosing high risk patients, but here after the surgery is done, based on the pathological complete response, you're choosing the patients who don't have a PAT CR and randomizing them to TDXT or TDM1. So what happened in the Destiny 11 trial, the neoadjuvant trial? The PAT CR was 67.3%, very impressive. More impressive was the PAT CR in HR negative patients, which was close to 80%. That's a very, very good number. In the HR positive patients, it was around 60%. Event-free survival, EFS, also there was an early favorable signal, but this drug was so good, I think they haven't had enough events yet. So that's the Destiny 11 trial. And the Destiny 05, where they looked at PAT CR patients who did not have a PAT CR. Again, a 50% reduction in the risk of recurrence and 92.4% invasive disease-free survival. So these are really good, exciting numbers. So what do we learn from this? We have 2 options, and TDXT is something that is available in India. Which way do we go with our patients? Do we choose the Destiny 11, which might be in a way a cheaper protocol also, and also safer for the patient, because we are giving them only 4 cycles of TDXT and many of them are going into a PAT CR. So that is something definitely to think about when we see these high risk patients. If a patient does go on the other road where we are giving THP, then the Destiny 5 trial is of course there, and we should be talking to our patients about this too. I will not talk much about this because we've had an excellent panel discussion about Monarchy. So both Monarchy and Natalie trials. So there is nothing much to say other than that these drugs are here to stay in the adjuvant setting. We have to choose our patients carefully. We should know the inclusion criteria in the trial. And what we have learned is that abemaciclib has shown us the overall survival benefit. Ribociclib is slightly behind, like sir said, 2 years behind in its numbers. Hopefully, we will be seeing similar benefit in the ribociclib arm also. The giredestrant trial is very intriguing, but how it will fit in the era of where we are, for most of our patients, we are giving some sort of a CDK4/6 inhibitor if they are in the high-risk adjuvant setting is something to be seen. These trials are nice trials, but we don't have any access to them. This is triple negative breast cancer, metastatic setting. For a long, long time, we used chemotherapy as the standard of care for TNBCs. Now we have then came using immunotherapy in those who had a high PDL1 score. So here now we have 2 ADC trials, both using sacituzumab, one in the PDL1 negative group and the other in the PDL1 positive group. So the Ascent keynote study is for patients who are in the PDL1 positive group, where they compared chemo with Pembro to sacituzumab with Pembro. And the Ascent 03 is the PDL1 negative group, their chemotherapy alone with sacituzumab. And both were positive trials. So ADC is here to stay in this setting When will we get it across the shores to our country, and will anybody be able to afford it is a different question, but still a very good drug. Good drug. So median progression free survivals are improving in both the trials, and this has been FDA approved. So if you were in a US or a Europe, you would be getting sacituzumab with pembro or without pembro based on the PDL1 status. Lastly, here we have kind of access to these drugs, the HR positive metastatic. So for everybody who comes to us with metastatic HR positive disease, we are giving them AIs with CDK4 inhibitors. We have the Innovalicib trial where if the patient is endocrine resistant to begin with, there the combination of palbo fulvestrant with Inavo is what we have to do. In the ESR mutation is something now that we are using routinely, molecularly testing our patients and then looking at whether they have an ESR mutation or not. If they have an ESR mutation, the oral SERDs are here to stay. And this is the latest trial, the one of the later ones, which is the imlunestrant trial. There is also another interesting group of interesting class, the PROTACs, and vepdegestrant. Difficult to pronounce these words, but this has also been shown to improve progression-free survival in the metastatic setting. So HR positive patients, it's going to be crowded field, lot of drugs. But I think in my mind, if a patient comes, if the patient has an early endocrine resistance, I will go with the Inavolisib. If they don't have the early endocrine resistance, then we give the CDK4 AI, the combination only. And then if there is a molecular progression, we have the Serena 6 trial, not approved by FDA, approved by EMA. In India, of course, it's our choice whether we want to do it if we have access to the trial. If the patient has a radiological progression, then we have to look at the ESR mutation and the PIK3CA mutation and then decide which one of those four arms our patient will be in. And based on the trial that is there, we can decide which would be best suited for the patient sitting in front of us. So I think very exciting and has become very complicated and complex. So with this, I end my talk. I would also like to thank Claude and Notebook for doing the trials and making all my slides look like some Kanchivaram silk saree. Thank you very much.
Thank you, ma'am. Please.
Congratulations, Dr. Sudha, for such a elaborate and systematic algorithm-wise presentation. Is the means question answer? If anybody is or
Okay, I request our
any question,
I request our
maybe later. Yeah.
sir. I request our chairpersons please felicitate our speaker and please join Dr. Ravi Jaiswal for the memento presentation.
At the same time, I would request chairpersons to stay back for another session, after which they can collect their memento from the memento desk outside the hall. Next, I would like to involve Dr. S.P. Srivastav, medical oncologist from Indore. And the topic is transforming treatment paradigm for low and ultra low HER2 expressing breast cancer tumors with ENHER to you.
Yes, go ahead, sir.
So, a very good afternoon, everyone. And before starting my talk, I would like to thank Dr. Ravi, very good friend of mine, who has given me the opportunity to visit the Raipur and participate in this academic feast. So, as we know about the HER2, everybody is very much aware about the HER2, but now we are going to discuss about the HER2 low and HER2 ultra low, which is a paradigm shift in the management of HER2 directed therapies. We have drugs available, we are routinely using and having a wonderful response rates as compared to when we did not having this. So my topic of presentation would be transform the treatment paradigm for low, ultra low HER2 expressing metastatic breast cancer. with Enhertu, that is trastuzumab deruxtecan. This is the agenda, and my disclaimers or disclosure is this: these slides being provided by Estra for academic presentation only. So we are going to talk about the Enhertu, which is a specifically engineered HER2 directed antibody drug conjugate. And this is a depiction of this. This is having two components, topoisomerase 1 inhibitor and the trastuzumab, with a homogeneous and high drug to antibody ratio of 8:1 combination. That why it is very much effective drug. Now the bridge the unmet need in HR positive, HER2 low and HER2 ultra low metastatic breast cancer. So this is the timeline of ESCO CAP ISC guidelines update. We can see from 2007 till 2023, there is a lot of change in ISC reporting, and that has become possible because of one study, that is DB06. I'll discuss later on, where the HR HER2 low and ultra low came into the picture. So 2007, we only know about that ISC 3 plus 2 plus 0 or 1 plus. Then 2013, ISC 3 plus redefined and 1 plus and 0 redefined. In 2018, ISC 2 was redefined, and now in 2023, ISC 1 plus and 0, which has been redefined as a low and ultra low and negative. So we can see this pie chart where the evolution of HER2 classification from binary to a spectrum of expression is there. Earlier we were about only the HER2 positive and HER2 negative, but now we have HER2 positive, HER2 low, HER2 ultra low, and HER2 negative. This is a slide depiction of staining of HER2 part. So we can see this HER2 ultra low, where any or faint or barely perceptible membrane staining is there in less than 10% cells. Earlier it was considered as a negative. Now it is considered as a HER2 ultra low, and HER2 low, which is comprising of ISC 1 plus and ISC 2 plus with FISH negative. So what happened when we have the report of HER2 negative? So now our dictum or the ESCOCAP guidelines, which are recommending that just reevaluate the slides again with some another pathologist or discuss with your pathologist to go for higher power, that is 40x assessment, and then only just go with that, whether it is IC0 or IC1 plus. So detectable level of HER2 expression may be present in patient with HER2 ISC0 metastatic breast cancer. As we know, there is a critical unmet need for targeted treatment options after endocrine-based therapy for patient with HR positive, HER2 negative metastatic breast cancer. The standard of the treatment is CDK4/6 inhibitor and endocrine therapy, and it is having a maximum progression-free survival up to 25 to 28 months, was followed by, in second line or third line setting, both are options. When we are using, they are going for almost 8 to 12 months of the only PFS benefit. So there is a significant drop in the progression free survival after using the endocrine therapy plus CDK4/6 inhibitor in the first line setting. Now we need to have some more options to go for or increasing increment in the progression free survival. So the first of the thing is that when we know this HER2 null, where the HER2 zero is with the basis of ISC 0, 10 to 15%. Now there is out of 10 to 15%, 85 to 95% come as a HER2 low and HER2 ultra low over expressions. So where we have a actionable drug or actionable target available for those of the patients. So now this scenario came because of the Destiny's Breast 06 trial. This was a phase 3 trial where they have investigating the patient with hormone receptor positive, HER2 low and HER2 ultra low metastatic breast cancer. It was an open label trial, and the eligible adults more than 850, where they have taken prior endocrine therapy as a one line or second line with HR low and HR low, ultra low, HER2 low and HER2 ultra low with chemotherapy naive patient, divided in 1:1 fashion, where the NH2 was used as a 5.4 milligram per kg 3 weekly, or a physician choice of chemotherapy, whether capecitabine, nab-paclitaxel, or paclitaxel. Primary endpoint was progression-free survival in HER2 low population, and secondary endpoints were of in overall population PFS and OS in HER2 low and overall study population. So this is the demographics which were well balanced in both the arms of NH2 versus chemotherapy in terms of HER2 ISC score, number of prior lines of endocrine therapy in metastatic setting, site of metastasis, time to progression on prior endocrine therapy plus CDK4/6 inhibitor, and prior chemo in non-metastatic settings. We see the PFS benefit here, the ENHER2, that is trastuzumab deruxtecan, which provided the PFS of 13.2 months as compared to 8.1 months of chemotherapy. Delta of 5 is there, which is in favor of ENHER2. And if we see the HR, so it is 0.62, where the 38% reduction in the risk of disease progression or death with the help of ENHER2, there is a significant benefit. If we see the over 60% overall response rate with ENHER2 as compared to 35, so we see the depiction almost double the benefit in favor of ENHER2 as compared to the chemotherapy of various physician choice. Median duration of response again 14.1 versus 8.6 months, and ORR and DOR were not tested in this study. Over 90% of patients achieve disease control rate in terms of CR plus PR plus standard stable disease with ENHER2. We see the PFS results observed with ENHER2 in pre-specified exploratory patient subgroups, where it is in the HER2 low and HER2 ultra low settings. So on the basis of various subsets like age, HER2 expression, prior CDK4/6 inhibitor use, prior endocrine therapy investigation choice, and liver metastasis. So mostly all in favor of the ENHER2 as compared to the chemotherapy. If we see the PFS outcome across all levels of low HER2 expression, so in overall study population, there is 13 point versus 8.1 months difference in the PFS in favor of ENHER2, and HER2 low and HER2 ultra low also. In both the scenarios, it is favoring the PFS benefit in ENHER2. ORR results across all level of low HER2 expression. Here again, it is almost double the benefit in favor of ENHER2 in overall population, as well as in the HER2 low and HER2 ultra low population. So additional exploratory post-hoc data analysis was done with the of DB06 study, where the ORR and DOR by independent committee review by physician and compared with the physician choice of chemotherapy versus ENHER2. So ENHER2 again, there is a ORR and DOR almost double when we compare with the capecitabine and taxanes. PFS by measure of disease burden in various subsets like number of local or metastatic sites at baseline, liver metastasis, baseline tumor size, visceral disease. So in all subsets, ENHER2 was having a benefit as compared to the chemotherapy, whether it was capecitabine or taxanes. Overview on safety of ENHER2 in patients in DB06. So we can see that because it's a combination with the chemotherapy, so there are some side effects like nausea, diarrhea, vomiting, constipation, abdominal pain, which are slightly higher as compared to the chemotherapy, but mostly in the grade 1 to grade 3, 4 side effects were very less. Then common adverse reaction, which were more than 10% in all grades of population as compared to the ENHER2 versus chemotherapy. So like decreased appetite, COVID-19 infection, upper respiratory tract infection, musculoskeletal pain. These are common side effects we usually routinely face and slightly higher as compared to the chemotherapy. So if we see the ENHER2 benefit risk profile in HER2 low metastatic breast cancer, it was further confirmed by DB06 and was established in HER2 ultra low as well. So the median duration of treatment was double in ENHER2 as compared to the chemotherapy. If we see the serious adverse event, there were 20% in ENHER2 as compared to 16% in chemotherapy patients. So chemotherapy patients has lesser side effects or serious adverse event. Now, what are the important serious adverse event which were happened because of ENHER2? That is ILD or pneumonitis, febrile neutropenia, hypokalemia, and COVID-19 infections. So most of them were in grade 1 to But in some patients, that was grade 5, particularly ILD, sepsis, bacterial meningoencephalitis, CVA, neutropenic sepsis, peritonitis, and physical health deterioration. So if it when it was compared with the THP regimen, so adverse reaction which may require dose modifications, so particularly serious adverse reactions, dose interruptions and discontinuation, it was higher in HER2 as compared to the THP regimen as compared to the dose reduction and dose interruption, which were and particularly dose reduction, which was higher in the chemotherapy arm as compared to the NHER2. So NHER2 pooled safety profile uh, across pooled studies in patients with metastatic breast cancer and other solid tumors. So in all, because we have now tissue agnostic approach approval for this drug, particularly neutropenia and left ventricular dysfunction, these were the main side effects which were considered specifically, and we have to look into this. And most common other side effects like neutropenia, fatigue, and abdominal pain. So ILD or pneumonitis, which is a very important side effects, we have to take care of this side effects and we have to be aware about the side effects. So in pooled clinical study analysis, mostly ILD was in grade 1, 2. Very few patients had grade 3 and 4 interstitial lung disease. So, early identification of ILD is a key to appropriate management. So, there are the 5 S strategies like screening, scanning, synergy, suspend treatment, and steroid. So, this has to be start from the beginning, like screening in the initial when the patients are coming for us to start with the NHER2. At the outset, we can start with the CT scan or HRCT or PFT, educate the patient, scan the patient later on, and synergies. So we have to explain the patient as well as our supporting staff to identify the symptoms and go for the screening or go for the CT scan assessment. Then when to suspend the treatment, whenever we find there is any sign of the interstitial lung disease, we have to immediately stop the treatment and wait. If it is grade 1, then wait for the 28 days. If it resolved to 0, then we can start the treatment with the similar dose. Otherwise, if it is going beyond 28 days, then we have to reduce the dose in a fashion of like 5.4 milligram to 4.4 milligram, then 3.2 milligram. And if it is the patient is not tolerating, discontinue this. And finally, the use of steroids whenever we have a we just find that it may be the ILD, then start the steroids without thinking more. Later on, go for investigation and use the pulmonologist along with you. Importance of health related quality of life. So we can see this NHER2, which was associated with reduced risk of clinically meaningful deterioration in functioning and fatigue, but increased risk of some GI symptoms. GI symptoms like nausea and vomiting, which did not appear to negatively impact quality of life. Clinical meaningful deterioration of skin and mucosal symptoms were observed with chemotherapy, but not with the NHER2. So this is the quality of life questionnaire 30 and time to deterioration data graphical presentation where we can see this patient who received NHER2 demonstrate improved clinical outcome while maintaining overall health related quality of life, which was a meaningful benefit for patient with metastatic breast cancer. So to summarize this study, in DB06 for HER2 low and HER2 ultra low patient of metastatic breast cancer with the use of NHER2, where the PFS was superior as compared to the chemotherapy. Now, NCCN has recommended as a category 1 recommendation. In safety, NHER2 continue to establish its benefit risk profile. So, this was all from my side. Thank you so much.
Thank you, Dr. Shrivastava, for such enlightening and informative sessions. And we really appreciate for your valuable insights and knowledge on this topic. Any questions from the audience? Okay, thank you so much.
Thank you.
Thank you, speaker. I request our chairperson, please give mementos to our speaker. I request Dr. Ravi Jaiswal, please join the stage. Our now, I request our chairpersons, please collect their mementos from the memento podium, which is outside of the hall. And I request Dr. Chetna Ramani, please give mementos to our chairpersons. Now we move to the next session. The next session is a panel discussion on management of complex breast cancer scenario. To moderate the session, I invite Dr. A. Santa from Hyderabad and the chairpersons is Dr. R. Ramchandani from Raipur, Dr. Neeraj Pehlajani from Raipur, Dr. Santosh Sonkar from Raipur, Dr. Divya and Dr. Mrs. Subhi Nakwi, madam. Please join the stage. And I request Dr. Jayesh Sharma, please join the stage to chair the session.
Good afternoon, everyone. As the panelists are moving on to the stage, I would like to thank Ravi and one and all in his team who have organized this OncoSphere 2.0. So we have been enlightened by a lot of updates after the recent ASCO, but I also want to discuss the real world scenarios of two breast cancer patients. Two cases we'll be discussing in this next 20 minutes.
Let me invite all the panelists. So we have chairperson. So Dr. Arpan Chatur Mohta, Dr. Ayush, Dr. Nupur, Dr. Jayesh, they have already joined. Dr. Sunil Chopde, medical oncologist. Dr. Rohit Pai. Sunil, yes, raise your hand and come. Right. Dr. Rajiv Ratan Jain. Sir is here. Yes, sir, please. Dr. Manjula ma'am. Manjula ma'am, she's reached. Dr. Rahul Swarup Singh. Dr. Kishan Soni, Dr. Sonali Thakur. So Rahul sir is here and Sonali is here. So you can take their introduction so that you get familiar.
Okay, each one of you please introduce. Sonali is.
I can tell your specialty so that. And for everyone, ma'am was my teacher in Basavta Arkam, Indo-American Hyderabad. So I've learned a lot from her.
Hello, ma'am. Hello, everyone. I'm Dr. Sonali Thakur, consultant nuclear medicine, Sanjeevani Cancer Hospital.
Hello, ma'am. I'm Dr. Sunil Chopde, medical oncologist at Jaslok Hospital, Mumbai.
Ma'am, I'm Dr. Rajiv Jain. I'm radiation oncologist from RCC Raipur.
I'm Dr. Arpan Chaturmata, surgical oncologist, Sanjeevani Cancer Hospital.
I'm Dr. Ayush Dubey, medical oncologist at Sanjeevani Cancer Hospital.
Hello, ma'am. I'm Dr. Nupur Priya. I'm surgical oncology from Balco Medical Center, Raipur.
I'm Jayesh Sharma. I'm a surgical oncologist.
Hello, ma'am. I'm Dr. Rahul Singh. I'm radiation oncologist.
We need to introduce ourselves because there are so many experts and we are here just
please
to
introduce.
listen you and to raise our concern being the people who see a lot of young breast cancer patients. And in fact, being a gynecologist and reproductive medicine specialist, it is, I think, our onus to pick the cases early so that you people can do the justice. I'm Dr. Neeraj Pehlajani and I'm a reproductive medicine specialist. Nothing else I think I can contribute into the panel.
I'm Dr. Subhi Nakvi, gynecologist, Ramakrishna Care Hospital.
Good, we have a reproductive medicine person because this case is pertaining to that. So we have enlightened ourselves with the update of what is happening. But At the same time, we'll be discussing about some case scenarios in the real world. Are we able to maintain what are the standards of care? What are the dynamics involved in the treatment? So without wasting much of time, the first case I'll be discussing is a young breast cancer patient. She's a 27-year-old student, just finished her IIT, highly professional. So she just picked up a lump in her left breast just 4-5 days before she wrote her CAT entrance. Her mother, who was a breast cancer survivor, took her immediately to the sonologist, and after examining, the sonologist straight away said, "This is cancer." She said, "My exam is more important than my disease. Let me finish, then we'll go." She basically hails from my hometown, and they came all the way to Hyderabad. Her mother was also treated by me. She's a doctor. She's my junior. So with the 2 weeks by the time they came to me, it was 2 weeks. So they had a strong family history. Mother had breast cancer, and 8 years later, she was luminal A. 8 years later, she had contralateral breast cancer, and she was operated. Her maternal grandfather had CA pancreas. Grandfather's sister had ovarian cancer. Close family friends of ours. She doesn't have any comorbidities, very obese. Clinically, when I examined her PS was 1. Clinically, it was a T2 tumor. Just a 2 into 2 centimeter when I palpated, with no negative on clinical examination. And ultrasound anyway outside they had done. So she had gone to a sonologist, radiologist for a biopsy. So they did a mammogram and a biopsy. And such a patient who comes, so I would like to know what is the first investigation anybody would ask besides the ultrasound in a young breast cancer patient. What is the investigation? Though it is suspicious, what is the first investigation you would ask to confirm your diagnosis?
Ma'am, ultrasound is already done. I'll prefer a MRI breast because she's young. She will have dense breast. So have better clarity. It will be better to order a MRI breast for her.
But it is BRCA positive. So BRCA1 positive. Mother is
Mother is
BRCA1
positive.
positive.
Mhm.
So there
We
are
have
more
not yet-
chances. Yeah.
We have not yet done
Yeah.
for her. Yes. So MRI breast was done, and there was a 3.4 into 2.9 millimeter upper inner quadrant breast lesion, which was BIRAT 6. She had some satellite lesions and also some axillary node 1.3 to 1.2, suggestive of metastasis. Right side, there was a BIRAT 3 lesion. Okay, so a biopsy was done. The biopsy came as IDC, reproductive carcinoma, with a ER of 15%, PR negative, HER2 negative, KI 67 of 90%. She was a bit apprehensive. She wanted a second opinion on the biopsy. So a second opinion was also taken in another place. So the repeat biopsy in a second place, the same specimen showed an ER of 5%, PR was negative and HER2 was negative, KI 61 was 90%. Satellite lesions in the breast and the axilla were negative. Metastatic workup was negative. We sent for a BRCA. So what is the next plan? Surgeons, you can take the call.
We can have a staging workup, ma'am. And
you-
BRCA, because we have sent BRCA1 testing. We are waiting, but staging purpose, we can have a PET scan.
PET scan is done. Metastatic workup was negative.
Okay. We'll wait for the BRCA results because that will change line of surgery.
Will it, do you consider surgery upfront?
No.
Or
Upfront, we go for a neoadjuvant.
whether you want to do surgery upfront or go
Neoadjuvant,
for a treatment?
neoadjuvant treatment first. We will consider it like a triple negative only. It's ER very low positive, so triple negative.
Madam, you're not a panelist, but I just wanted to ask you, what is the advice you would give? Because she's young, 27 years. See,
In fact, the questions were coming to me that her mother was diagnosed with CA breast and was BRCA positive. Why not the daughter was tested before the lump or the BRCA? And is there any relevance of young means girls whose mother have BRCA positive cancers? So to detect the BRCA in advance, to counsel them and prepare them to detect the lump or palpate the breast well in advance.
So when her mother finished her treatment, this girl was 24 years in the peak of her engineering. Though we were supposed to line her up, we didn't do anything for her yet.
Not particular this case, but
24
it's
years,
only a
they
simple.
didn't still reveal to the children because they were studying. They were in the hostel. So she was 24 years when our mother finished her second treatment. First treatment, BRCA testing was not available and we didn't do. In second relapse, bilateral, when she had the second breast cancer of contralateral breast, we did the BRCA testing.
Ma'am, I will advise her fertility preservation also at this stage because she's married. She will be going for neoadjuvant chemotherapy. So we will advise her for oocyte preservation or something, and before she starts with her NACT.
What if she turns out to be BRCA positive?
Ultimately, ma'am, family she has to plan. And even if you're planning for oophorectomy at a later stage post NACT, I will do it at a later stage. Not she's just 27. She will have lot of symptoms post oophorectomy. So maybe once she crosses 40, we can plan for yes, or completed family. Yes.
So, madam, I would like to ask, when you do the oocyte preservation, do you do any genetic test and selectively take the ovum which is BRCA negative? Any genetic tests you do?
Technically, it is not possible.
It's not possible.
It's not possible that we have to we can select the eggs which are BRCA positive. So in such scenarios, if the surgeon has decided to go for the surgery for the breast, they can do it. But before that, only one more test before giving an option of egg preservation will be the ovarian reserves test. That is the AMH. Because speaking too much at a point when a young woman is struggling with the survival and the future, it is not an easy thing to talk about the egg preservation. So, first we have to decide the basic plan of management, which will be essential for her life. And in between, we have to seep in that where we can fit the oocyte preservation because it is a 15 to 20 days job. So, the treatment need to be adjusted for that much period of time. So, AMH will give us an idea that when to plan egg preservation. Is it the right time or it can be delayed before the chemo and radiation if required? Surgery will not interfere.
So we discussed the case in the tumor board. So options we discussed whether upfront surgery. What is the plan? The plan in the tumor board was to go for upfront chemotherapy. So medical oncologists can take this question. What chemotherapy you would plan?
I will plan it like a standard triple negative regimen, like pembrolizumab with chemotherapy, 8 cycle standard, Pex and carbo followed by AC.
So that's what was the tumor board opinion also to plan the treatment according to triple negative breast cancer. We did discuss about the ovarian function, what would have happened, and fertility issues. They went and met the reproductive specialist, but they didn't want any oocyte preservation. So we went ahead with the chemotherapy. What would be your chemotherapy choice? Dose dense with weekly IO out of this?
In my practice, ma'am, because what I have seen in my practice is patients were not tolerating dose dense regimen. So I go with the standard 3 weekly protocol only.
I perfectly agree with you. More than that, the other dynamics involved is she has to go back to Orissa. So overnight, almost 18 hours journey, she has to go. So we planned for a 3 weekly, not a dose dense, and also not a weekly regimen of taxanes. We gave like triple negative, paclitaxel, carboplatin. And she had a very good response. Yes.
Did you add any IU?
Add any? Yes. We didn't add. So finances were a little bit restrictive, so we didn't add IO.
Like suppose patient is financially okay.
Yes, definitely.
We have offered this ovum preservation to many patients, but we have seen 95 to 99% females
Not go because Gen Zs they are.
Yeah.
Gen Zs they are bothered about the profession, earning money. They're not bothered about family and
Yeah, that's because I think so. It took long time because in male, it's very easy to get sperm preservation, or for female, I think so. It takes ma'am about a month or no, not like that.
So it's a myth that it takes a month or more than that. You just need to give us 15 days.
Yeah.
Nowadays, in fact, the newer stimulation protocols are there that irrespective of the day of the menstrual cycle, we can start stimulating the lady, and usually the stimulation is over in 10 to 12 days, and thereafter in next 34-36 hour retrieval can be done. Only thing is that we need to have that time before the stress period is there, either the chemo or the radiation, because once that effect is there, the inside quality goes down or the number also get affected.
So means maximum it's around 14-15 days and less
14,
1
15
week to
days.
2 weeks.
Yes.
so she had a very good clinical response and we referred her to the surgeon. What surgeon's opinion is? She said, whatever you decide, it is okay with me. So what would surgeons offer her?
Ma'am,
They'll go
we will prefer for skin sparing mastectomy with reconstruction on the same sitting, ma'am. Because it's BRCA1 positive. We prefer this. Yeah, we can go for it and next time we can plan, but best to with a skin sparing mastectomy with the reconstruction like LD flap reconstruction, silicone implant, and many more. Yeah.
So she didn't
Three,
take
four.
opt for the Angela Jolie and all these other celebrities. She is cool like Kylie Minogue. How she wants to get back immediately after surgery to her stage. So she also opted for wide local excision and sentinel node was done. Fortunately, it was a white P T0N0. So I would like to ask the radiation oncologist what is will be a plan of radiation, any escalation, because clinically node negative,
Okay, ma'am.
27-year-old,
Ma'am, in this
SLNB
case,
negative, of course, post neoadjuvant.
this case, ma'am, but like radiation will depend only solely on the earlier stage, whether it uh, whether there was any indication before starting chemotherapy or not. Like in this case, it was probably T2N0. So there, and mastectomy was planned, what I think. So there was no.
Wide local excision was done.
Okay.
Oh, by the way,
So
BRCA, in meanwhile report came, BRCA was positive.
Ma'am, but BRCA,
BRCA1 was positive.
ma'am, risk of recurrence and local recurrence is like in carrier and non-carriers are almost the same. If you say in BRCA positivity, so radiation, if it is indicated, then it should be given.
Ma'am, I
That is
think
good.
radiation should be offered to the patient
Should be offered.
because it is a high risk patient, grade 3, young patient, and BCS has been done. So I think we should offer adjuvant patty to this
So
patient.
whole with
This
radiation with local boost.
Yes, definitely. Ma'am.
Yes,
Medical oncologist, what would be the further plan? She underwent radiation. So what would be the further adjuvant plan?
So though
15% ER in one center, 5% ER in one center.
though she is low hormone positive, I would offer tamoxifen as adjunct tamoxifen for at least 5 years, and maybe PARP inhibitors. We know it's early brace, though it is not clearly TNBC, but we would consider PARP inhibitors for at least 1 year of time.
So we put her on AEs and we gave her GnRH analogs. Yes.
PARP inhibitor I would have been added if it's a non-PCR. As it is a PCR, I would continue pembrolizumab with the hormones.
So we didn't give PARP inhibitors for her. So she was on hormones and GnRH analogs.
So again, I don't think PARP inhibitors probably we would go for if paths here. Tamoxifen, yes, probably it might impart some chemoprotective effect also because the BRCA is positive. So basically that might have some protective benefit also. So basically tamoxifen 15%, I would go for 5 years.
So tamoxifen was given along with this. So to your surprise, she has a monozygotic twin sister. So we sent the BRCA for her also. She was BRCA1 positive. She also underwent an MRI of the breast. They were normal. What would you advise for her sister? The follow-up prevention, from prevention part. What does the guidelines say? BRCA positive carriers with a strong family history. This is a high risk BRCA carrier.
So she is 27, you said now. What is
27.
27. Twin sister is also 27. So probably the same annual MRI of the breast along with a gynec checkup. And after the family is complete, probably bilateral salpingo-oophorectomy. Whether there is a role for TVS and CA125 monitoring till then, probably it is something controversial, but probably I would go for an MRI and a gynec checkup annually. That is what I would be doing.
According to the latest ASCO, do you? Okay, that's what was advised for her. These are the NCCN guidelines. A rapid RAP for this TNBC. Any biomarker based risk stratification you do for treatment decisions? This was discussed in the ASCO this year. Do you agree? Because it's still, what do you say? Depending on the TILs, would you offer immunotherapy because you were for immunotherapy? What TILs? Will you examine the TILs and decide on your IO? Any genomic signatures, if we come, you think they will impact your decision on neoadjuvant? So what they say is the high TILs, the better the IO. So less than 50%, they don't respond much. So that was the latest ASCO update. Dynamic response assessments are also done. Cytotoxic chemotherapy was escalated based on this, right? And of course, PARP inhibitors are coming into neoadjuvant settings also.
I have a question. Like this patient, earlier it was considered as TNBC. So IO plus paclicarbo, like was
We
a
did not
plan.
give because of financial.
Like that is okay, but ma'am, if it had been an option, you would have considered it.
We wouldn't.
But like post RT, you are considering her as ER positive. Like it was low.
It
So
was low, 15%. So we, because one
but
center was 15% and the other center it was 5%, we thought we will give her hormones for whatever. Her mother was also hormone positive. So 15%, we didn't want to take a chance for her.
Okay.
For fertility, because we are giving
Mm.
tamoxifen or kind of thing. So it might hamper because she will require fertility in next year. Continuing these tablets only.
No, that anyway, we are going to give a break for the hormones and all, no, once she decides on her family.
Ma'am, suppose she would have received IO, then would you consider continuous IO
Adjuvant IO.
or you would have given a, ER positive? What you have considered in this patient? Because this is a bit
Daisy situation. That's why it's complex scenario,
that
you see.
situation.
So these are always, we discuss any of out of this one, we discuss in
These are
board, and
treated, these are
that's what
treated
I
as
say. Standard
TNBC,
guidelines are
but at
separate,
the
and
actual
what in the real world are different.
Like you will give them only
Please speak in the
you will give only hormone or pembro plus hormone. What are you going to do?
continue IO and also
You'll add
of course we can continue IO and endocrines also.
and yeah. Together.
So anyway, we cannot discuss. I think the time is up. This case actually I wanted to discuss because Ravi is also involved in this. This is the 2018 case. Destiny is telling a lot of things, but this patient is destined to something else. And she survived even today, till today. I'll just run through, if you don't mind, 5 minutes. Just run through the slides. Okay, you just. So she was also a ERPR triple positive breast cancer, T2N0M0. Okay, we planned for her, the routine chemotherapy. She was on the Ayushman Bharat scheme, that is the government scheme. So she got her routine AC with 2 cycles. We could not put a clip. 2 cycles, there was no tumor. Surgeon said, I will operate. They operated. We finished the routine chemotherapy. And adjuvant treatment at that time, it just came and we gave adjuvant trastuzumab for her, 12 cycles, and reducing salpingo-oophorectomy was done. 2019, she finished. 21, she had this lung mets, right? So I will just not ask because of lack of time. So trastuzumab paclitaxel, because there was more than 18 months of gap. So that was the response. She completed. Then we continued on trastuzumab and hormones. Then after that, there was mild progression. So we just stopped the hormones and added capecitabine. There was some response. After that, there was again progression. So we got it more of a this one. We couldn't do the biopsy because the biopsies and all they had to pay. Exemestane and everolimus we tried. That was going on for a couple till October. October is a bad month for her. Every time she recurs in October. Then lab cape that progressed. Only one lesion progressed. Lab cape was given, partial response and stable throughout till April 25 last year. That's what happened. We did a biopsy, ER 10%, PR 0, HER2 new 3 plus. Of course, I gave TDM 1. Progression on TDM 1 3 cycles. Can't afford TDX. Then again, trans 2, there was a response. Trans 2 tamoxifen, brain mets in January. What would be your treatment? Last question. Yeah.
Like if she is local,
Patient to the brain, no other site of disease, lung, stable disease,
but
no other site of disease.
ma'am, like if finance support, you're asking for radiation,
What anyway will be given.
radiation will give it, like SBRT can be given.
What
because
next treatment?
And then further that you can add some tucatinib.
Exactly. Radionuclide. One question I'll ask. What is the role of FAPI PET? Will it pick up more lesions? Brain mets was there. Nowhere else the disease is there on the routine PET. Lung is stable disease. Well, FAPI PET will help. Any FAPI directed radionuclide therapy will help.
Ma'am, in breast cancer, FAPI, the recent studies have found that FAPI is more sensitive and pick up more lesions compared to FDG PET-CT. And it also depends upon FAPI picking up lesions also depends upon the resolution of the PET-CT scanner. So if the lesions are big in size, it will definitely pick up. And brain lesions, when it comes to brain lesions, it will do better than FDG because FDG will have physiological uptake in brain, while FAPI would not have physiological uptake.
What about FAPI-based radionuclide treatment?
Yeah, lutetium FAPI is available nowadays, and based upon FAPI uptake on PET scan, we decide whether we can give it or not.
This is homework for you people. This is the order of treatment for a metastatic HER2 positive breast cancer. But what are the disadvantages of adding TDX2 upfront? If there is resistance, please go and look up. If we are bringing up to the first line and neoadjuvant setting, what are we left with? When through the rest of the treatment, patient has lived so many years, maybe it's an anecdotal case, we don't know, but most of them 3-4 years, we can push through a lot of anti-HER2 treatment. Pharma driven, once the patent is gone, new drugs will come. Next, what happens? Cost of treatment. Please look up it all. Thank you so much. Thank you.
Left-sided breast tumor. I just want to know the role of deep inspiration breath holding technique of the radiotherapy. Is it indicated only on the left-sided cancer or it is also being practiced in the right side? And what is do you have any disadvantage of this technique using for the radiotherapy?
Ma'am, DIBH is mostly for the left side because we are able to decrease the dose of heart and because heart is the main dose constraint area for that. And for right side, we generally don't do it because
I
it's
just want to know the recommendation because it also protects the lungs.
ma'am,
Ma'am,
it
So
protects,
even
but
in
lung are like
Rajiv,
lung have a more tolerance.
if we are going for ultra hypofractionated, I mean 26 grain 5 fraction sort of thing, then we have to go for DIVH in right side breast also, I guess.
So we'll take expert opinion on this. So we have Dr. Charu from Delhi. So I think I'm sure you all know.
Thank you so much for the question. I think like DIVH, we start left-sided breast cancer. Broad, they are doing it for both sides because lung is, I mean, it spares lung to a large extent. So we also do it in right-sided breast cancer if the patient has got some, if the patient has got any kind of COPD or anything where we have to save the lung because it saves both the structures. That is very true. So, huh? That's huh? So then we can. No, no, not at all, not at all, not at all. I mean, we know that, I mean, we cannot compromise on the treatment modalities, right? The dose and everything remains the same. It is just that the choice of patient. Yes, yes, yes. A very, yes. A very well-bred patient, they will come and ask for it.
I think you both can have a coffee and take it further. We will end this session here. Thank you so much, Shanta ma'am.
I'm
And
extremely sorry for pinching your time.
no, it's okay. So we are running short of schedule. So may I request our chairperson to please and panelists to join us in felicitating our speaker. Ma'am, if you can please come in center. Uh, ma'am, Nakvi ma'am, Bella Jani ma'am, please. And all the panelists are here. So we all can have a photo.
And that was the lovely panel brainstorming. And after this, I would request the panelists and chairpersons to collect their mementos from the memento desk outside the hall. And I invite Dr. Neha Chandrakar to please present them the mementos.
Thank you. Thank you so much. मैम को ले जाना मोमेंटो सब लोग एट द मोमेंटो डेस्क ग्रेट नाइस टू सी नाइस टू कॉल यू
For next session, I would invite Dr. Rakesh Mishra, medical oncologist from Raipur, and he's going to tell us about unlocking the role of immunotherapy in early triple negative breast cancer. And for this, I would invite Dr. Rishi Agrawal to be the chairperson.
Rishi sir, please chair this session. You can please. Charu ma'am, if you can join in chairing this session along with Manju ma'am, please.
I request all the chairperson, please collect their mementos from the memento podium, which is just outside of the hall. Over to chairpersons.
So very good evening to all of you. Now it's 5 p.m. So I'm going to discuss the role of immunotherapy in early TN triple negative breast cancer. When I was a student, triple negative breast cancer was the worst prognosis was HER2 positive. But since the advancement of targeted therapy in HER2 positive cancers, now the worst prognostic cancer is become the triple negative. It's the most challenging cancer, and we are going to discuss the role of immunotherapy in early triple negative breast cancer. So we know the breast cancer show lower estimated neoantigen burden. We know that the highest neoantigen burden is with the melanoma and the lowest with the brain tumor, that is the astrocytoma. Breast also is known to have less immunogenic tumor compared to the other tumors. We can see the prognosis of triple negative breast cancer stage wise as compared to the other variety. It is have the poorer prognosis, and we can see the stage wise, stage 1, 2, 3, 4, and higher the stage, the worse the prognosis compared to the other breast subtypes. Regarding the immunogenicity, TNBC has higher immunogenicity, and it is a potential subtype for effective immunotherapy. We know the data like the tumor infiltrating lymphocytes, which ma'am has been discussing. High TIL is known to for the immunogenicity. We can see the more than 30% TIL possibility is higher in case of triple negative, that is the tune of 31%. Then comes to the ERPR negative and HER2 positive tumors. They are also have higher TIL value, and this higher TIL value are more responsive to the chemotherapy and the immunotherapy. Coming to the PDL1 gene sequencing, that is the expression of PDL1 related mRNA gene, which is also higher with the triple negative breast cancer compared to the other variety. Coming to the biomarker that has the potential predictor for the immunotherapy in triple negative breast cancer. So there are the few biomarkers. One is the Japan Novo trial, where they have seen the tumor mutation burden high tumor mutation burden, and another is immune gene expression profiling. So what they have found very interesting data that immune gene expression profiling, if it is there, they have higher pathological complete response, and that is in the tune of 80%. When it is combined with the tumor mutation burden, there also the PCR rate is high, that is in the tune of 80%. TMB high alone have shown the pathological complete response to the 40%. So it means immune related gene expression profiling is a very good candidate for good pathological complete response. Another biomarker which was studied in the NeoPact study, that is the DNA damage immune response, and another signature, that is the Gutermalo signature, where we can see that if these immune related signature were positive, these patients have got the higher pathological response compared to the negative population. Coming to the easiest biomarker for the immunotherapy is the tumor infiltrating lymphocytes, which can be assessed by your own pathologist if she is trained with the assessing the stomal TIL. We can see that if it is more than 30% stomal TIL, these patients have improved disease-free survival and overall survival compared to the less than 30%. Coming to the PD-L1 status, it is very known biomarker for the immunotherapy in the various cancer, but in the breast cancer, it is not much effective, especially in the triple negative. Whether it is a positive, it is a negative, it does not influence the your choice of immunotherapy. Only important point in this slide is that if it is a PD-L1 positive, these patients do well even to the chemotherapy. We can see PD-L1 positive patients have better pathological response compared to the PD-L1 negative, even without use of immunotherapy. So PD-L1 does not take any relevance in the triple negative breast cancer except for the prognostic significance. Coming to the CPS, whether it is more than one, whether it is the less than one, addition of immunotherapy to the chemotherapy, there is no much difference in the survival. Regarding another very interesting trial, that is the I-SPY2. This is a very interesting trial. It was a very complicated design, but you want to understand that in this trial, early TNBC improves the pathological complete response by identifying the precise population by the immune signature. So what they did the MAMA print, 70 gene signature study to identify the genetic classification which they defined either immune positive or DRD, that is a deficient repair gene positive. So what we can see the conclusion that if the signature is immune type, giving pembro have the better pathological complete response. If signature is deficient DRD positive, these patients do well with the addition of velaparib and carboplatin, that is the pathological response in the tune of 75%. Coming to the triple negative subset, so in the triple negative subset, you can see if both immune and DRD is positive, these patients do well to pembrolizumab. If you add immunotherapy to the chemotherapy, they will have higher pathological response compared to the DRD positive only, where the addition of olaparib and the addition of velaparib and the carboplatin ultimately lead to the higher pathological response. So immune signature is there. You can go ahead with the combination of chemotherapy and immunotherapy in neoadjuvant setting. This data comes from the a very landmark study, that is the Keynote 522, where they have evaluated the role of addition of pembrolizumab to the chemotherapy in early breast cancer. So the inclusion criteria were newly diagnosed early stage TNBC, more than 1 centimeter tumor size with the nodal involvement, or if the size of more than 2 centimeter irrespective of nodal status, they were included in this study. Inclusion criteria were the autoimmune disease that requires systemic treatment within 2 years of, and the medical condition that required the immunosuppression. The stratification factors were the node positive versus node negative, T1, T2 versus T3, T4, and the choice of carboplatin, whether it was 3 weekly versus weekly. Coming to the regimen, where we can see this was not the conventional what we used to in our practice. In our practice, we use the doxocycline first, followed by the taxane. In this trial, they have used the taxane based regimen at the front. They combine the Keytruda, that is a 200 mg 3 weekly. They have given along with the Keytruda paclitaxel carboplatin. Pacli was the weekly, that is 80 milligram per meter square. And the carboplatin, two choices were there, whether is the 3 weekly AUC 5 or weekly AUC 1.5, not 2, which we do conventionally in our practice. After this, they have given the 4 cycle of plus cycle or equivalencing cycle along with the Keytruda 200 mg 3 weekly. It means almost you can see I think 4 to 5 doses of the pembro was given before the surgery. Then patient go for the surgery and followed by the adjuvant Jumab, that is the 9 cycle with a total duration of 1 year. The primary endpoint of this study was the pathological complete response and the event-free survival. Secondary endpoint were the overall survival and the PCR, EFS, and OS according to the PDL1 positive population. Exploratory analysis in this trial were the EFS, event-free survival according to the different patient subgroup, event-free survival according to the PCR. Regarding to the baseline characteristic, median age was 49. They included the patient from age 22 to 80. So they have the old population where in this trial also 99% were the female. Asian population were over 20%. PS was mostly good. And when we see the advanced disease, that is the 25% in stage 3. Coming to the dosing, we can see regarding the PCR, but as an endpoint, we know the data from the different meta-analysis and the trials that if PCR is there, these patients have the better EFS in the OS compared to the non-PCR patients. Regarding the interim analysis of this trial, what they have found that the primary endpoint, that is the pathological complete response, were better with addition of immunotherapy to the chemotherapy, that is the 64 versus 51%. Coming to the PCR by nodal status, so whether it is a node negative or the node positive, the benefit of the PCR is there, and the benefit of PCR is higher in the node positive group, that is the advanced group. You can see the EFS, that is the event-free survival, were also significantly higher with the addition of immunotherapy to the chemotherapy. In the larger follow-up, what we can see, EFS benefit was still maintained with absolute benefit in 9% at the 3-year follow-up. Coming to the Asian population, in Asian population, the benefit was much higher, that is in the tune of 10%. Regarding the various subgroup, in the subgroup analysis, whether it is PD-L1 positive, node positive, or the advanced disease, all subgroup were get benefit by addition of immunotherapy to the chemotherapy. Then comes the larger follow-up data. Now this trial have the 5-year survival data where it has shown that the EFS benefit is still maintained. We can see the absolute benefit in the EFS at the end of 5 years is still 9% when it was at the 3 years. Coming to the exploratory subgroup, all both stage 2 and the stage 3 got benefited by addition of immunotherapy, and the magnitude of benefit was higher in advanced disease, that is the stage 3. Here the absolute benefit was around 9 to 10% by addition of immunotherapy to chemotherapy. Then comes the early disease. They also got the benefit of addition of immunotherapy, and at the end of 60 months, all subgroups have shown consistently by this, they have shown the benefit of adding immunotherapy to the chemotherapy. Regarding the overall survival is also higher by addition of immunotherapy, and that is the tune of 5%. If 5% benefit in the in the breast cancer non-metastatic disease is a really significant, and what actually we want as an oncologist to our patients. Regarding the subgroup, every subgroup got benefit. Another very important slide, this is that patient whether got the PCR, whether did not get the PCR, both group got the benefit, but you can see patient who did not get complete pathological response after adding immunotherapy, these patients they get more benefit after addition of immunotherapy, especially neoadjuvant adjuvant. Regarding the residual tumor burden, higher the residual tumor burden, these patients got the better benefit, especially in the distance recurrence also. So, if the residual disease is there, these patients will get the benefit in the distance recurrence by adding immunotherapy. Regarding the toxicity, diarrhea, rash, fever, and the appetite, these are the some additional toxicity which are present with the immunotherapy, and no grade 3, grade 4 toxicity were comparable. Now we know that in the triple negative breast cancer, the guidelines also recommend that you should go with the addition of immunotherapy to the chemotherapy in triple negative breast cancer. If there is a residual disease, you can go with the capecitabine. But if you have used pembro as a neoadjuvant setting, it's better to go for the adjuvant immunotherapy in the subsequent treatment. Thank you.
If there is no question, I request our chairpersons, please give memento to our speaker, Dr. Rishi, Dr. Charu. I'd request Dr. Ravi Jaiswal, please join the desk for the memento session. And I request our chairperson, please collect their mementos from memento podium. And I request Dr. Ravi Jaiswal, please felicitate with mementos to our speaker, our chairpersons. Dr. Ravi Jaiswal, please felicitate Dr. Rishi and Dr. Charu with mementos at memento podium. Now we move to the next session, which is reduce the risk of recurrence in HRN HER2 EBC. To deliver this topic, I invite Dr. Rajiv Ratan Jain from Raipur, and to chair the session, I request Dr. Ram Chandani, Dr. Chetna Ramani, and Dr. Neha Jain from Ram Krishna Care Hospital, Raipur. Over to you.
So shall I start? Uh, like,
Please start, sir.
okay. So without wasting time, at the offset, I will thank Dr. Ravi to invite us for this wonderful conference. And then I'll be starting on my topic, that is reduce the risk of recurrence in HR positive, HER2 negative, EBC early breast cancer. Like this, slides have been provided to me by Novartis. And I'll be covering unmet needs in this area, risk of recurrence. I'll be discussing NATALY study, efficacy and safety, and then patient profile for other questions. So as we see the evaluation of HR positive cases, then as we can see from 1996 onwards, there is first it came to be anastrozole and letrozole, then exemestane was approved by US FDA, and then further then this CDK4/6 inhibitors came. Then 10 years data for tamoxifen and endocrine therapy came. So HR positive has a long history. So recently, what new has come? What in EBCs we are there is an indication for two CDK4/6. First is ribociclib and second is abemaciclib. So then how to optimize treatment in EBCs? So in contrast to ER negative, ER positive patient, EBCs have a risk of metastatic recurrence, which is usually after 5 years, and more than 50% of all these recurrences happens after 5 years. Uh, there are unmet needs. There are a lot of data for that. That is Pan et al. At 2017, Javeri and Flashing et al. At 2024. What we can see, this graph is very important for us. Like what we can see in all EBCs, if you see that those patients who had 4 to 9 lymph node positivity, that is an N2 disease, had a very high rate of recurrence, say that 22% and 36%. And when you see the in N1 disease, if we say N1 disease less than 4 lymph node, N1 to N3, then at 5 years and at 10 years, 10 and 19% recurrence. And then we see all those patients were N0, it was 6 and 11. So there was good recurrence. The recurrence rate was very high after 5 years. So patient with high risk N0 may be at similar risk of recurrence as patient with N1 EBCs. Analysis of 7,564 patients with HR positive and HER2 negative EBC patient from Flatrion database found that N0 patient with or without high risk feature at 7 years had 2.9x around 3x greater overall recurrence risk and 4x greater distant recurrence risk. And if N0 non-high risk had significantly lower overall risk of recurrence and distant risk of recurrence. So node positive has a high rate of recurrence and node negative had a lower risk of recurrence, but not all node negative had a lower risk of recurrence. So across the whole Natalie's population remain at risk of cancer recurrence. Within 3 years, 1 in 8 patient will experience a recurrence. 90% of this recurrence at 3 years are distant recurrence, incurable recurrence, and death or second primary non-breast invasive cancer. And by 5 years, it rises to 1 in every 5 patients. So a very high, you know, now, she's a young girl of 54-year-old dentist. She's having stage 3A ER positive, PR positive, HER2 negative EBC with ER strongly positive with N2 disease, 6 node with no genomic testing. So tumor was intraductal carcinoma. It was a T2 disease, 4.9 max diameter. So Ki67 score was 11. Total treatment was given total mastectomy with axillary lymph node dissection without intermediate reconstruction, completed radiotherapy and chemotherapy, started on endocrine therapy 1 month. So this patient, after 5 years, so as per the data, what we saw earlier in the graph, she has around 30% recurrence rate after 5 years in NSA after non-steroidal aromatase inhibitor monotherapy. So this is a quite high number. So, second patient of similar type, but she is having an N1 disease, but with a high genomic risk. That like we do a oncotype DX or mama print, and if you see that there is a high genomic risk, so these are the other group of patient. And she as per the data, she also has a 15 to 20% recurrence risk after 5 years. And then the another patient, she is node negative T2 disease, but with high. I'll be discussing these 3 patients and how disease goes. And she also has a N0, but N0 node. She's an N0, but T2 N0, but she's having high genomic risk by after oncotype DX. So she also have around 15 to 20% recurrence risk. So then these are 3 scenarios where we see that if you see it looks like an EBC, and in per se it can be said that like it's a good disease and she'll do good, but all this patient has a very high risk of recurrence. So ribociclib, what ribociclib actually do? ribociclib is recognized by it's a recognized by major international guidelines as with highest level of evidence among all CDK4/6 inhibitors and HR positive, HER2 negative. Ribociclib is the only CDK4/6 to have CAT1 recommendation with AI in first line, and ESMO as well as have highly rated CDK4/6, and ABC 6-7 guidelines also rates it. So Ribo is now approved in a broader indication for EBCs, that is high risk N0, T2N0 with high genomic risk disease with Ki67 score more than 20%. All T3, T4 disease N0, and node positive N1 disease and N2 and N3 disease. So a broad group of ER/PR positive, HER2 negative disease patient is having a good, you know, ribociclib in HR positive and HER2 negative EPC has received the highest ratings for NCCN and ESMO. NCBS is now recommended as a category 1 rated option. So there are two data which I earlier told as well. One is ribociclib, that is Natalie's data, and another is amibaciclib, that is Monarchy cohort 1 study. So in this data, what we can see that ribociclib is indicated in lot of indications, but abemaciclib trial was done only in grade 3 and more than 5 centimeter tumor, that is T3 disease, and all N2 and N3 as well. So they haven't done it for N0 patient. They haven't done it for, they haven't done a genomic scoring for this patient. So Natalie's study is a phase 3 clinical trial assessing efficacy and safety of ribociclib plus NSAI versus NSAI alone, and adult with anatomical stage 2 and stage 3 population, NEN, no N0 with T2 disease with high genomic risk, and NSAI alone for 5 years, and ribociclib 400 mg per day for every 21 days, 28 days cycle for 3 years. Ribociclib 400 mg was selected for better tolerability and lesser side effect. So the 3-year treatment duration narrative, longer the duration to extend the time of target exposure and prevent early and late relapses. So ribociclib schedule fits with ESMO guidelines, follow up for 3 months for first 3 years. And Natalie's has demonstrated a significant DFS benefit of IDFS benefit of 4.9% versus AI alone in broader EBC population. So at 5 years, Ribo plus NSAI prevented more than 1 in 4 recurrences. Ribociclib prevented 1 in 28% decrease in relative risk of reduction over for 5 years. At the cumulative risk of recurrence continued to be increased. So does the benefit of ribo. So if you see forest analysis, if you can see that across all age groups, like patient who has received chemotherapy, who has not received chemotherapy priority or not, everyone was benefited with this study. So, and the risk of recurrence was also decreased. Distant recurrence was only 8.1% versus 11.4. Local recurrence also decreased across all parameters. Now, the data suggested that it is benefiting. At 5 years, say, Ribo plus NSAI showed an increasing magnitude of IDFS benefit over time for patient with N0 and N1 to N3 disease versus NSAI alone. At 5 years, disease-free survival was also better as compared to NSAI alone. 29.1% risk in decrease in risk reduction in distant disease, and around 30% risk reduction in distant recurrence. So this patient, she was, now we can see about this particular case. She was a 54-year-old dentist. What adjuvant therapy she should have been prescribed? Like we can easily see she had a N2 disease, and then no genomic testing was done, but N2 disease was there. So Ribo plus NSAI can be easily prescribed to this patient. And in stage 3, ribo plus NSAI prevented 1 in 4 recurrences, 18.8%, like 5.6% absolute risk reduction as compared to NSAI alone. This second group of patients who had N1 disease but high genomic risk. So this patient was a premenopausal, like 29-year-old female. So she was given NSAI plus OFS plus ribociclib. And third patient, the absolute risk of reduction is around 4.4% as well. And the third patient, 67-year-old female, she also had she was treated with NSAI plus ribo. So 5.7% absolute risk of reduction. Ribo safety profile. Ribo is quite safe as we have used in all recurrent cases. And majority of grade 3 toxicities were laboratory findings that were easily identifiable and manageable and mostly reversible. Rate of dose adjustment due to adverse event was around 22.8%. Rate of discontinuation was around 19.7%. Dose reduction did not impacted outcome, and liver-related adverse event were most frequent cause of permanent discontinuation. So based on experience, the list below, which are the top 3 attitudes most relevant to your high-risk EBC's patient. Treatment efficacy is very important, and it has a lower risk of diarrhea, lower risk of thromboembolic events, lower risk of fatigue, and so patient with EBC risk EBC preferred treatment that maximizes efficacy while minimizing symptomatic adverse event. Treatment efficacy was quite high and toxicity was low. Patient in the quality of life and other engagements, physical functioning was maintained with the addition of ribociclib plus SOC, and global health status was not impacted over time in both the arms, and no difference in social and functioning from baseline was observed in both the arms. So across everything, this drug actually benefited patient and 3-year survival, and it had a lot better indications as compared to the other CDK4/6, and then I think. And if you summarize, reduce the risk of recurrence including risk of distant recurrence. At 4 years, relative risk of distant recurrence was 28.5%, suitable for broad range of eligibility, demonstrate a manageable and mostly reversible safety profile, and maintain HRQOL. Thank you.
It is already in the phase 3 trial.
Sir, done. Phase 3 trial.
Don't they already it is in the guidelines?
Yeah.
So how it is given?
Like
with IV for is it injectable, na?
No, oral.
Oral.
Oral drug.
And cost?
So cost is bit high. Around 60,000, I think. 35,000 हो गए.
Until bad day newer drugs are coming new.
सेकेंडली धीरे धीरे सर वो तो उस पे भी आ जाएगा, पेटेंट ऑफ होगा तो फिर और अवेलेबिलिटी हो जाएगा वो वैसा तो.
Any push?
हाँ.
हाँ. Risk reduction बहुत माने there is a good outcome ना.
Definitely.
And the sample size in this is very large ना.
Very large. एंड सर हम लोगों ने इसको एमबीसी में मेटास्टेटिक ब्रेस्ट कैंसर में काफी यूज किया है. इट्स क्वाइट सेफ ड्रग्स एंड वेरी इफेक्टिव. मैं तो खुश, कई सारे पेशेंट 4 years 5 years दे आर सर्वाइविंग. So it's not, it's a good one overall.
Thank you, sir.
Thank you.
So I request our chairpersons, please felicitate our speaker with memento. I request Dr. Maura, madam, please join the stage for felicitation. And I request our chairperson, please collect their mementos from the memento desk, which is outside of the hall. I request Dr. Gaurav Gupta, please give mementos to our chairpersons. Now we move to our next panel discussion, which is redefining first line HCC therapy with Checkmate 9DW. To moderate the session, I invite Dr. Deepak Kapakka from Hyderabad, and the panelist for this session is Dr. Suman Mittal ma'am, Dr. Darshna Rane, Dr. Yashwant Kashyap, and Dr. Rakesh Mishra. Please join the desk. Over to chairpersons, panelist, and moderator.
Good afternoon, or probably good evening, everyone. So thank you, Ravi, for this opportunity. And I was told that I have to wind it up early because the health minister will be arriving soon. Uh, I have Dr. Suman Mittal. Dr. Suman Mittal. Yeah. Dr. Darshana Rane. And Dr. Yashwant Kashyap. And Dr. Rakesh Mishra. Okay, so we'll quickly complete this. And regarding the management of HCC, I think HCC, we are now eventually seeing more number of HCCs in our practice, and we see there's almost 11% increase year on year with the incidence of HCCs. And unfortunately, most of our patients, like any other disease, present in an advanced stage, and the 5 year survival in India is way below 15%. And worldwide, it's the sixth most common cancer and the third leading cause of cancer-related deaths. And we all are aware regarding the etiology. Around 80% of HCCs are because of cirrhosis, and the cirrhosis secondary to either hepatitis B, hepatitis C infections or co-infections, alcohol consumption, and NASH-related HCCs. So, when you see a patient with advanced HCCs in your practice, Dr. Simon Mittal, what are the concerns while approaching and managing these patients in practice?
So, if you look at the goal of the therapy of the patient, so first and foremost is to improve the survival, then to give good quality of life to the patient, maybe the rapid response in terms of tumor reduction. And these are the main things we look at when we start the treatment.
Unlike any other cancer, Dr. Krishna, what are your issues when you manage a patient with advanced HCCs, unlike a lung stage 4 or a breast stage 4?
So, in my practice, I'm telling you, advanced HCC more than it requires convincing the referring doctor as well
Yeah.
to actually understand that now the HCC is actually treatable, curable with good outcomes.
Yes.
And goal, though, still remains one is symptom palliation, and now we can, have some kind of survival benefits seen compared to the past with dual immunotherapies and all. And yeah, so unlike the other outcomes, now we are not having, I mean, since HCC, we don't give any chemotherapy.
Yeah.
We are more focused on giving targeted and immunotherapy options. So we keep on playing with the combination therapy.
Yeah.
Is what we do.
Yeah. So one other interesting or practical issue that we all face is most of these patients are cirrhotic, and overall outcomes, not only in relation to the malignancy, the cirrhotic component also is a major deterrent in the outcomes of our patients. And what we discuss here are the child-puke A's, but unfortunately in our patients, most often we see them, they come in child-puke B's and child-puke C's. So moving ahead, I'll just start with a case scenario: 58-year-old female with chronic hepatitis B on tenofovir with undetectable HBV DNA, child-puke class A, ECOG 0, and 2-month history of right upper quadrant pain and discomfort, well-controlled hypertension, and no comorbidities. Vitals are stable. Hepatitis HbSAg is positive. AFP is 230. The liver enzymes are normal except with mild thrombocytopenia secondary to splenomegaly. MRI revealed multifocal HCC with tumor thrombus into the right branch of the portal vein. No extrahepatic disease is present. PD-L1 status was not done. Moving from here, Dr. Yashwant Kashyap, how often do you do biopsies in your patient with HCC?
If my imaging is very much conclusive and AFP also correlates, then I am not doing biopsy.
Biopsies. Yep. Dr. Rakesh, your take, biopsies in all patients, no patients, selective patients? So, mostly, if uh, in the metastatic disease, my tendency is to go for the biopsy. Okay. Especially because nowadays we do see the both mixed variety cholangio and SCC. Exactly. Since nowadays I have seen lot, not it is not very rare to me. Yeah. So I do prefer, especially some discondenses there regarding the imaging finding in the biomarker level. Yeah, yeah. So one other thing is the place where we should be avoiding a biopsy is in a patient with cirrhotic liver where you're worried about the risk of decompensation. There we have to go back to the LIRADS classification, LIRADS 4 and LIRADS 5. You can get away by not doing a biopsy. In LIRADS 3, where there is no capsular enhancement, arterial phase hyper enhancement, you eventually have to do a biopsy like sir was rightly pointing out. You can end up getting a intrahepatic cholangiocarcinoma or a intrahepatic cholangiocarcinoma with a HCC. And it is important that management in these diseases are effectively dependent on the biopsy report. So that is the take home to the audience. And what is the now this patient is having a VP2 lesion, right branch portal vein is involved with multifocal HCCs. So Dr. Kashyap, your take on this? How would you manage this patient in practice?
I will go ahead with he's young, fit guy, hepatitis B in control. So I will go ahead with immunotherapy and dual blockade because I know that this patient, all hepatitis and everything is controlled. So he's fit. So I will go ahead with dual blockade of new AP.
So Rakesh, anything else that would help you make a decision before you initiate the treatment in your practice? So, in the multifocal SCC, still it is a non-metastatic disease elsewhere. I also take it young patient, not CLD changes. I will also take it. Changes are there on MRI. Okay. Yeah, CLD changes are there. Mild splenomegaly is also there. Mild splenomegaly. Yeah. And endoscopy, there is no varices. Yeah. So definitely, that was the point I wanted to bring forth. Upper GI endoscopy. Yeah, please proceed, sir. Yeah. So definitely, I need to see the upper GI endoscopy whether it is there is any varices is not there or not. So in this patient, if there is no variceal, both options are valid. Atezolizumab or bevacizumab as a front agent, and either Durva and Tremeli if HbSAg is well controlled with the antiviral coverage. Yeah. She's on tenofovir. I've shown it in an initial slide. Yeah. So, Dr. Suman, would you consider these patients for any loco-regional therapies like TACE or TARE? Because just a VP2 lesion, SBRT to the thrombus, what is the management in your practice? Would you directly treat them like
Multifocal, maybe patient might not get that benefit, but if there are 2, 3 lesions, definitely I'll like to refer and take a opinion
Yeah.
from my radiology colleague that if can benefit. But if it is more than 2 or 3, probably I will not go for it. Otherwise, definitely yes, taking a opinion. Local therapy might help the patient.
Okay. So, Dr. Darshana, your take on the use of pembrolizumab, lenvatinib, bevacizumab, atezolizumab in the later line of, sorry, durvalumab, bevacizumab in the later line. I mean, post-TACE. Do you do that in your practice? Because the ESMO recommends based on the lead study. So, do you do that post-TACE, or usually it is with the gastroenterologist? They only refer the case after TACE failure happens.
So usually in my practice, I get a case referred from the GI person.
Yes.
So yes, in my practice, I definitely prefer atezolizumab with bevacizumab. Pembrolizumab will be my second choice with lenvatinib, and yeah, so and then the others actually, because I have limited experience in the others, but atezolizumab, especially in the hepatitis setting, has shown significant results.
I think post is durvalumab data is coming. So I think we are very much hopeful.
Yeah.
Slowly we will try to incorporate on
Yeah.
that sector.
So the Emerald 3 was recently discussed in the ASCO 2026, where post stage they've taken patients up to VP1 and VP2, and they were initiated on lenvatinib, durvalumab, tremelimumab after TACE, and that has shown an event-free survival benefit. And I think immunotherapy and targeted therapies are moving ahead into the management. Even in BCLC-Bs, probably we should be incorporating. We should encourage our gastroenterologists to consider using this even in earlier lines. Now, considering this patient who is not eligible for TACE or any local regional therapy, so what and there are no viruses on endoscopy. What effectively helps you make a decision of IO versus IO VEGF inhibition, Dr. Kashyap?
I think it all depends fit because Nevo EP is good. It has shown good CR rate. We have many category one options. So for young fit, where I will be more towards Nevo EP, but Atizobave is also good option for such patients.
Yeah. Dr. Rakesh, So practice nowadays you have two options. That is immunotherapy with the bevacizumab, and that is another is a dual immunotherapy. So the choice depends upon the how fast I want response. So chances of getting fast response is higher with the atezolizumab and the bevacizumab. The response rate is fast. Yeah. Dhruva and Tremeli or Nivo plus EPD, that is a dual IO, they got the deeper response and more complete response. So depending upon my intention, if I want fast response, I'll go with the atezolizumab, bevacizumab. If I want deeper and sustained response, I'll go with the dual immunotherapy. So, Dr. Suman, your take on which combination probably would have more response rates?
See, if we need to see one thing is whether is any varices or an active bleeding or patient is any anticoagulants or anything which leads to more tendency for bleeding. If there is no such contraindication, then definitely, as we have more experience with atezolizumab, so that will be my first choice in a patient who is not bleeding, as we have more experience with this drug. But suppose if there is some contraindication, somebody is bleeding uncontrolled varices or anticoagulants which I cannot stop, or any other thing which leads to more predisposition for bleeding, in that case, my choice will be tremelimab or durvalumab. And
Darshana, your take, what helps you make a decision on initiating the right treatment in our patients?
Yes, I agree with my colleagues. The first would be how quick I would want a response, and if the patient is bleeding versus not bleeding. If the bleeding is there, I would like to settle the bleeding first with banding and all, and then give the therapy. Also, of the financial will matter. How like easy for the patient it is to manage that, and yeah, and the rest is the same.
So effectively, we have three different treatment options with Etezobeb being the first. Way back in 2018, the approval has come, followed by Durvatremi, followed by Nivo-Epi, which is a new kid on the block. So we this is the database. So the reason for using Opdata plus ipilimumab is that ipilimumab stimulates the tumor antigens in the periphery with CTLA inhibition, and at the center, at the tumor microenvironment, there is activation of the PD-1 pathway. So, certain interesting factors about the Checkmate 90W before I move ahead is about the control arm here was lenvatinib plus sorafenib, but most of the patients, 85% of the patients had lenvatinib in the control arm. The other interesting factor is they have not taken patients with VP4. So, VP4 is patients having major vascular involvement, that is into the common portal vein and distal to the common portal vein. And there was a statistically significant improvement in overall survival, and in terms of patients who've responded, they have the highest duration of response. So coming back to the panel. So Dr. Darshana, from your point of view, so if you do a cross trial comparison, which we are not supposed to do, but we effectively end up doing in all our situations, Nivo-IP has the best data in terms of long-term outcomes. The patients who've responded have the highest DOR of 30 months, whereas in all other studies, it's varying somewhere between 19 to 22 months. So what is your take? I mean, Nivo-IP per se has the longest response. Most response rates are with Nivo-IP, almost 7 to 8% of the patients have a complete response. And so wouldn't this be a optimal choice of treatment in your practice? So what are the challenges with using this regimen in your practice?
So, Nivo-AP has shown definitely great responses in metastatic RCC.
Yeah.
And definitely in hepatocellular carcinoma also, they have shown a significant response, especially because in this trial they have used a comparator arm, which is lenvatinib in majority of the patients.
Yeah.
And in the previous trials, it was always the sorafenib, which was not even the standard of care at that time. So, in terms of how they have studied the trial, also, I mean, this is more
head to not a head to head, but yeah, more of the standard of care, and definitely the overall survival has been significantly improved in the combination therapy.
So, Dr. Suman Mittal, your take on the data and any other insights?
Data looks impressive at the moment, but I think no, it's about we don't have much of
First mover
experience.
advantage, I think.
Yes, so we need maybe some more time, more data, more experience before we are more comfortable and more convinced about using this drug more, as compared to the drugs we have been doing. So maybe need some more data, some more time. But I think it's I mean, another good option
Yeah.
for SCC.
Dr. Rakesh, your take on this combination? Because we talk stride, we do Exopev most often. Not most of us in our practice have not moved to Nivo EP despite showing the best data. Now the median OS is 23.7, which is the largest in the other compared to the other two studies. So your take on why have we not used this more often in our practice? So I think there is slight slight resistance to use of non-immunotherapy. That's why the Nevo-EPILI has not become too much more often prescribed drug and the dose of ipilimumab. So most of us, actually as a medical oncologist, we are concerned that the 3 milligram per kg would have more toxicity. But the important part of this regimen is that the ipili is the actually main, it's a front runner drug in this trials. That's why we got the best response and the duration of response is better also because here the EPIL is also 4 times compared to the Durva and Trevil that is only one dose. That's why we will see the deeper response with the new EPIL and this is a very good drug. I think toxicity are manageable. Yes, toxicity would be there, but the disease is so aggressive that if you are getting a 2 year survival, 3 year survival, 38% in a advanced SCC, you will never get this kind of result. Dr. Kashyap, your take on.
Ipilimumab per se, we all are worried about toxicity. So for young fit patient, controlled patient, this is a good way.
Yeah. So one interesting fact that I would like to present here is the lenvatinib arm here had a median survival of 20.6 months. To the delta, if you compare it with the IMBRAVE study or the STRIDE data, there the control arm had a survival of around 14 or 15 months. And here we can see even our control arms are performing better. Because this is the last study that came in that group, other than the Toribev and the tislelizumab. This is the last study, and probably our use of immunotherapy in the later lines have also improved, and probably that was the reason why the overall survival even in the control arm is around 20.6 months. So delta here is less, but if you see the control arm in the other two studies, the control arm here fares much better than the other studies. So again, in patients who respond, you can see that there's almost a flattening of curve beyond 2 years, and the response durations are deeper. And in patients who respond well, we can see that it's almost around 2.5 years that they continue to respond. And the overall response rate again is the highest in this study. It's around 36% versus 13%. So do you really go back and try to see the etiology of HCCs in your practice? So I'll start with Dr. Kashyap.
Yes, it matters because we are giving for hepatitis B, C positive patient. I am very worried about starting immunotherapy directly because first we have to control the viral load and other thing due to immune phenomena. So etiology matters a lot. Alcoholic, NASH, or all thing this matters.
Dr. Rakesh, your take, etiology. So etiology actually matters because in the viral etiology, there is a prognosis is different. NASH, they have the prognosis is different. With the use of immunotherapy nowadays, it does not matter much because in the NASH variety also the immunotherapy works very good, where we have not seen the result with a single immunotherapy. So nowadays they have almost good survival, irrespective of etiology. So, Dr. Suman Mittal, your take on etiology. Would etiology help you choose a regimen, or most often you just based on?
So, if there is doesn't matter much, but it's more of compensated or decompensated. So if it's already hepatitis B or C, the more likely to have decompensated varied disease. So there things becomes difficult. So there choosing immuno will be difficult. So in those cases, maybe we'll have to go for TKIs if decompensated or
Manage the lenvatinib data comes from there. Yeah. Dr. Darshana, your take on this?
Knowing hepatitis, if it's viral or not matters because treating the hepatitis with the antiviral agent itself controls the hepatitis, HCC, and also we have seen atazobactam as a better combination option in the viral hepatitis patients. So that would be my choice in that case.
So, as per the data goes, I mean, all three regimens fared very well in the viral etiology population. And like Sir rightly told, in the NASH population, the IO-IO combination fared better. It is a web, the hazard ratios were around 1.05, 1.02. So, it versus sorafenib. So, I think if you have a NASH patient, IO-IO combination fared better than the it is a web combination. So regarding the toxicities, I think it was pretty well manageable. More hypertension with lenvatinib and more autoimmune side effects with Nivo EP. And like rightly pointed out, the problem with Nivo EP is in terms of the dosing schedule. So here it is Nivo 1 mg per kg, whereas with EP it is about 3 mg per kg. Following which, if the patient at the end of 3 months has a response, either a partial response or a complete response, from there things get easy for us. And yeah, so in summary, Nivo EP demonstrated a statistically significant and clinically meaningful OS benefit versus lenvatinib or sorafenib. And Nivo EV actually has higher overall response rate, even the duration of response is higher, and better quality of life is seen with this combination. Thank you.
Thank you.
Thank you, sir. I request our panelists, please felicitate our speaker, moderator with a memento. And I request our panelists, please collect their mementos from memento desk. I request Dr. Naveen Jain. Dr. Naveen Jain, please give mementos to our panelists outside just outside of the hall. Huh? Now,
Madam Hannah. Next, I would like to invite Dr. Mao Roy, and she's going to speak about current standards in oncoplastic breast surgery. For this, I would like to invite Dr. Nishchal Tiwari, who is surgical oncologist, Raipur, Dr. Vaibhav Jain, Raipur, Dr. Prashant Kasir, and Dr. Amit Jotwani as chairperson. Dr. Jayesh Sharma also.
over to chairperson.
Over to chairpersons now.
ये सामने जाने का जस्ट इधर से तेज करेंगे स्टार्ट नहीं किया ना डिस्प्ले स्टार्ट नहीं किया डिस्प्ले After day-long sessions on chemotherapy, targeted therapy, immunotherapy, now we have short break and we are going to a surgical topic. The topic of discussion now would be oncoplastic breast surgery, the current standards. This is a 35-year-old female who came to me from nearby state of Odisha, who underwent mastectomy for a 2-centimeter breast lump. This is the patient. This is an operative image of a patient who had undergone breast conservation surgery, which has given very beautiful cosmesis and symmetry of both the breasts post surgery. Now, this is also a picture of breast conservation surgery, but a 5 centimeter big lump was removed from the central quadrant and a bit of the lateral area, and the patient was not offered option of reconstruction. The patient came to me from outside, and this is the result that the patient had post breast conservation surgery. Certain areas of the breast where breast conservation surgery is going to give more deformity are the upper inner quadrants and the lower quadrants. Lower quadrant, especially where it gives a Snoopy nose deformity as shown. So, this poor aesthetic results of breast conservation surgery brought about the concept of oncoplastic breast surgery, where we added reconstruction to the operative defect to give better cosmetic results and better body image to the woman. So, who benefits from the oncoplastic approach? One is the patient, as she is able to preserve her breast and body image. Oncosurgeon, as the surgeon now is not worried about giving good margins, as the patient is, as the surgeon is going to offer plastic surgery principles for good reconstruction, and the plastic surgeon also, who is involved in the management of cancer patient. So, patient assessment for oncoplastic breast surgery, what are the factors we take into consideration? One is tumor to breast ratio, tumor size, and tumor location matters a lot, whether it's a centrally located tumor or it's a peripherally located tumor. About the levels of oncoplasty, if the defect is less than 20% of the breast volume, then we can offer level 1 oncoplasty, where we can just do a dual plane mobilization or some advancement or rotation techniques, volume displacement techniques to reconstruct the breast. Level 2 is when the defect created after surgery is 20 to 50%, wherein we add chest wall perforator flaps or other oncoplastic breast techniques that I will show in my pics. And level 3 is reduction mammoplasty procedures with contralateral balancing. Indications of oncoplastic breast surgery are high tumor to breast ratio, tumor location, as I said, that central, inferior, and medial, macromastia, large tumor, patient desires smaller breast where we can do reduction mammoplasty, significant ptosis or breast asymmetry, and where an unfavorable result is anticipated. Oncologic indications are concern about clear margins, wide excision is required, patient is a poor candidate for mastectomy and reconstruction, and patient desires breast conservation. This is a standard chart that shows oncoplastic breast surgeries that are being selected for different quadrants of the breast. Now, what factors do we take into consideration when we are planning oncoplastic breast surgery for a patient? The first is the degree of ptosis. Degree of ptosis increases with age. Other is symmetry. Symmetry we have to see at both the levels, the nipple areolar complex level and the inframammary crease. And third is the nipple areolar complex symmetry, for which we have to plan the various diagrams when we do reduction mammoplasty, especially from suprasternal notch to nipple distance, inframammary crease to nipple distance, to give proper symmetry. The three plastic surgery principles that are very important and that form the basis of oncoplasty are transposition flaps, rotation flap, and advancement flap. This is a pic that is demonstrating Paget's disease of the nipple without any invasive component. Patient had undergone biopsy and there was no lump underlying. This patient underwent a wide local excision, removing the nipple areolar complex and the underlying breast tissue, and a Grissotti flap, that is a rotation flap, that is an advancement flap was planned in for this defect. It gives good symmetry in appropriately selected patients. Another example of Grissotti flap, how we plan the flap, how the deepithelialization, the third picture is showing how the deepithelialization is carried out and how a lateral to medial advancement is done to give symmetry to the breast. This is a picture that shows Burroughs triangle advancement flap or matrix rotation. This is mainly used for defects in the upper inner quadrant. If you see, apart from the scar, the symmetry of the breast, both the sides, the right side operated and the left side operated breast, have near normal symmetry. For periareolar lesions, we prefer donut mastopexy, wherein we remove this skin in the circle that has been, the dotted circle that has been shown, and from the upper circle, we create flaps in the mastectomy planes, remove the tumor with 1 centimeter wide margins, and do a dual plane mobilization along the pectoralis major muscle and underlying the skin, and do a good parenchymal closure, and it gives a very beautiful cosmesis to the operated breast. This is another example, that is bat wing mastopexy, that we do for periareolar lesions. Now, when the defect is more than 20% of the breast volume, and we need certain flaps to switch in for giving symmetry to the breast, then there are a lot of local flap options and even the regional or distant flap options that are available. The local flap options are the intercostal artery perforator flaps, and the regional or the free flaps are the latissimus dorsi flap or the DIEP, that is deep inferior epigastric perforator based flaps, and the transverse upper gracilis or superficial inferior epigastric flap. This is an example of transposition flap. If you see from here, the tissue has been taken and it has been switched in the lateral quadrant. If we see the front view, there is almost equally looking breasts giving beautiful cosmesis, and this patient has undergone a wide local excision in the outer quadrant. From the front, you cannot just make out that the patient has undergone surgery. This is the basis of doing intercostal artery perforator flaps. When the defect is in the lateral aspect, whether it is the upper or the lower quadrant, then lateral intercostal artery perforator flaps are planned for this defect in this area. If the defect is in the lower parenchyma of the breast, then a medial intercostal artery or an anterior intercostal artery perforator flap is planned. This is a beautiful diagram that shows the perforator anatomy. The medial intercostal artery perforator, the anterior and the lateral intercostal artery perforator. Mainly the perforators that are selected are from the 4th to 8th intercostal spaces, but the reliable ones are in the 6th to 8th intercostal space. This is my latest patient. I just operated last month. This patient came to me with an invasive duct carcinoma of bilateral breast. It was a luminal tumor in both the breasts, and on PET scan she had a thyroid nodule, which on FNSE showed papillary thyroid carcinoma. So we offered a bilateral oncoplastic breast surgery. For the central quadrant also, this was a defect in the periareolar region and slightly going into the retroareolar region. So I did a removal of the nipple areolar complex with wide margins. So this is how it was reconstructed with LICAP flap. This is how we raise the LICAP flap. The patient need not change the position. We did not change the position like we do it in the latissimus dorsi flap. We raise the flap in this place from the anterior and the posterior axillary line. Drawing is made according to the volume that has to be switched in. And this is how we de-epithelize and we put it into the defect. This is example of an anterior intercostal artery perforator flap that was done for a lower central defect. Reduction mammoplasty also, when the breasts are voluminous and more ptotic, patients can be offered reduction mammoplasty also. Latissimus dorsi flap is a workhorse for reconstruction in breast tumors. If you see, it can be switched into any defect. If we see the first photograph, that is in the upper outer quadrant, central quadrant, and the medial quadrant, the flap has such versatility that it can be switched into any defect and we can give good symmetry to the breast. This was latissimus dorsi flap with implant. This was a case that was operated in Katni. and the patient came with this type of scar. Actually, outside when they undergo surgeries, we get patients with this type of scar. The entire scar was removed. It was an invasive duct carcinoma, luminal A. We removed this entire scars, and from here in the mastectomy planes, we dissected the entire breast and did a modified radical mastectomy, and we did reconstruction with latissimus dorsi flap. The basis of the perforated anatomy when we do nipple sparing mastectomy. In many patients, we are offering nipple sparing mastectomy also. This is one such example. A physiotherapist with lipodystrophy or of her upper torso had come to me. She had cup A breasts, and she had a tumor that was 3 centimeter beyond the nipple areolar complex, and from the inframammary crease, we had removed the entire breast and we have reconstructed it with latissimus dorsi flap. Example of skin sparing mastectomy with boomerang LD flap reconstruction. The whole breast has been removed and has been reconstructed with latissimus dorsi flap. Nipple areolar reconstruction can also be done, and if we do tattooing of the nipple, we can give beautiful symmetry similar to the opposite breast. This is a photograph of a 23-year-old female who had come to my OPD with a 7 centimeter DCIS, whom we did a simple mastectomy with sentinel lymph node mapping and did a boomerang LD flap reconstruction with reconstruction of nipple areolar complex. She underwent her marriage 2 years after this surgery. Autologous fat grafting can be offered to the patient if the volume of the breast that we have created is not good enough and doesn't match the opposite breast. This is how it can be done. And we should always audit our patients whenever we are doing oncoplastic breast surgery of how physically attractive they feel about themselves, how sexually attractive they feel about themselves, what is their body image perception. So this was a scoring system in which patients felt as good as the opposite, before surgery in at least 49% of the patients. Upgradation in surgery and in any scientific branch is very, very important. As we can see in this photograph in 2009, through an helicopter, a professional photographer is taking a pic from the aerial view, and now drones are doing the similar things. It doesn't even require a human resource to do that. So oncoplastic breast surgery is one such upgradation in breast cancer management. Thank you very much. And then I'm open to questions if there are any.
Thank you, ma'am, for wonderful presentation. And I think you have done highest number of oncoplasty in Chhattisgarh as far as Surgical Congress is concerned. And thank you for.
Thank you very much for that introduction.
Any question from audience, please? Please.
Hello, ma'am. What is your take on robotic surgeries in this breast oncoplasty?
Yeah. So generally, robotic surgeries are being done, or for that matter, minimally invasive surgeries are done for BRCA1, BRCA2 negative. If we see the standard of care, if we see the standard of care, it is for BRCA1, BRCA2 mutation positive patients where we are offering mastectomy and then whole breast reconstruction. It gives the advantage that you would make just a 3 or 4 centimeter lateral crease incision which will be hidden under the arm. Through the 3 to 4 centimeter lateral skin incision, we raise the flap in the mastectomy plane and an implant can be placed in that. So it's really a good technique. It is really good to go ahead robotically in those BRCA1, BRCA2 positive patients.
Ma'am, I have a question. Because being a radiation oncologist, every patient of oncoplasty has to be go for adjuvant radiation. And I have a doubt that after completion of the treatment, how will you screen that patient for follow-up? And for recurrence, what is your modality of choice for investigation of choice in case of recurrence in oncoplastic patient?
So these oncoplastic breast surgery patients, they generally undergo radiation also. The area of the tumor, as we know, is marked with clip. So they receive that tumor boost. In case of recurrence, because this is generally, these are the flaps that are based with fat. So
That's why I
if there is a solid recurrence, we can identify it by mammography. But if we want advanced investigation, we can do an MRI also.
Because I think most of the radiation oncology will feel after radiation, usually the surface get usually hardened or
Yes.
very, then it is by palpable method, it is not easily
Yes.
will get that.
So we can do MRI also. And as we know that if we are doubting recurrence, we can even advise them PET scan, which by its metabolic activity will also pick up.
Thank you. Thank you.
Okay. Thank you, ma'am. I request our chairperson, please felicitate our speaker with a memento. And I welcome Dr. Nishal Tiwari as a chairperson. He joined late.
For the next talk.
नहीं नहीं यही चीज आपको सुना
I request the chairpersons to stay back for the next session, which is AI in oncology, that is artificial intelligence in oncology, practical implementation of AI in clinics. And the speaker is Dr. Purvish Parikh, who is a medical oncologist and hematologist.
So, sir is the president of Asian Geriatric Oncology Society, and he is ex-head of TMH Mumbai. So, we are honored to have him here, and he is the champion of oncology.
So yesterday, Ravi said that I have to make my talk a little more entertaining instead of talking strictly on the uh, technical aspects of AI. So I have revamped some of my slides, and I will take you through introduction, good, bad, and what now. Okay. So yesterday, when I landed at the airport, I was very impressed to see this Scottish horses out there. And then I said, "Okay, let me use artificial intelligence to change this a bit." So then we had a very nice view of the horses in front of a nice sunset. And this took 15 seconds, okay? So please remember that is the power of artificial intelligence. To understand what is the difference between machine learning and artificial intelligence, look at this cartoon. On the left side is a car, and now we have to extract the features so that it is identified as a car. On the top, you see machine learning where a human being is involved, okay? Whatever happens is happening under the supervision of a human being. And in deep learning, what happens is that there is no human being involved and we don't know what the software program is doing to identify car or no car. And therefore, we write when in 2023, when ChatGPT was launched, we wrote this publication that you can access to. But my question to all of you is, what is your favorite artificial intelligence today that you are using in your day-to-day practice? How many are using ChatGPT? Raise your hands. Okay. How many are using Gemini? Raise your hands. So more or less the same. And how many are using Indian large language models? Raise your hands. So this is the thing. There are at least 3 Indian large language models that are available to us, and we are not even aware of it. So one of them is Sarwan, the other one is Gyani, and the third one is Bharat Jen. And you can see that on my smartphone, on the front screen, on the home screen, I use Sarwan, which is also known as Indus, on a regular basis. Now, there are 3 features about these large language models that you should know about. One is that they are young and innocent. Okay, they are young and innocent. So they will follow exactly what you ask them to do. So when we are teaching youngsters to play cricket or to play baseball, we tell them keep your eye on the ball. right? If you tell keep your eye on the ball to these large language models, this is what they will do. They will put their eye on the ball. So that is why you have to be very, very clear and specific about what you are asking them to do. Second is like young Sheldon, they are very data heavy. And everything is talked about in the terms of tokens. So token is either an alphabet, a number, a punctuation, or an empty space. And the third feature that they are very cocky. So in this particular instance, when a coder asks the software to do something, it says, this is not my job, you do it yourself. So please understand the value of prompt engineering. A few years ago, we did not know what this term was. Now there's a 2-year course on what is prompt engineering. And sometimes I have to use a prompt which is 2 pages long to get exactly what I want as an output from them. So for you, if you want to use any chat GPT or Gemini, these are the 3 things that you should keep in mind while writing the prompt. One is that be very polite and patient while you're doing the job. Second is to give them respect and say, please imagine that you are a expert in the field. You have 30 years of experience as a tenure track professor at Boston or Harvard Medical School, and then give me the answer. Then you will see that the answer they give out is much different from if you're treating it like an encyclopedia. So with this introduction, let us move on to the good part of it. Please understand that Stanford University has said that India is number 3 in the global AI vibrancy. So we are quite advanced as far as AI is concerned. And I did a PubMed search, Artificial Intelligence Healthcare India. You can see that in this year, there are already 350 articles. The majority of these articles are in pathology and radiology. And what does it do for imaging? On the left side, you see a hematoxylin eosin stain. In the middle, you see how the computer has artificially painted to all the things. And one of the key factors here is stroma. So when our pathologists report, they are focusing on the malignant cells, but the computer, the artificial intelligence has already also focused on the stroma, and it has devised a cutoff value for stroma low versus stroma high tumors. And believe it or not, it has overall survival significance, which is statistically important. This is how artificial intelligence can pick up things which we may not be aware of. Another example is colonoscopy, screening colonoscopy. 20% of polyps are missed during conventional colonoscopy. And if you use an artificial intelligence propagated genius scan, there is an increase in detection by 14%. And this translates into a 47% increase in detection of cancer. And all the data that is published, you see the forest plot, everything is to one side of the unity. This is the power of artificial intelligence. Another landmark was on 29 January 2024 when a computer chip was surgically introduced into a human being, and that human being was then able to communicate with the outside world using a computer. Now, we had a very nice talk from a surgeon, and she also mentioned about robotic surgery in BRCA positive breast cancer. So, I put before you that now the surgeons are moving away from the patients. Okay, ma'am, when you did open surgery, you are few millimeters away from the patient. Then came laparoscopic surgery, which was centimeters away. Robotic surgery is meters away, and now we have telemedicine robotic surgery. Now, telesurgery, if you look at the publication, there are more than 500 publications, and there are several experts from India who are also using artificial intelligence and telesurgery. But we already have an artificial intelligence program that can do the telesurgery without a human surgeon. A 34-year-old Italian patient suffering from atrial fibrillation was on the operating theater in Milan, Italy, and a robot performed this 50-minute surgery without any hitch or without human intervention. It was supervised by a surgeon in Boston, USA, but he did not have to do anything else. And are we in India far behind? The answer is no. AIMS New Delhi did a tele ultrasound of a person who was in the Antarctica, 13,000 kilometers away. And this is the power of what our colleagues are doing. In 2014, I was using Google Glass. In 2025, I am using Meta AI glasses. So now let's look at what is the bad of artificial intelligence. Before the SpaceX IPO, this fellow was the richest person on the world. Now, of course, it is Elon Musk because now he's become a trillionaire. But NVIDIA CEO said AI will cause harm, but it is worth it. If he has 164 billion US dollars, of course it is worth for him. But what about the rest of us? To understand that, we should know the difference between surface web, deep web, and dark web. Surface web is where you do Google search or you go to ChatGPT. The deep web is where we do net banking. So unless I have a password or unless I have a username, I cannot access that. And what is there in the deep web is what we should be really afraid of. So I use some special tools to go to the dark web to see whether my information was available or not. And this is what I found out. And I have put a box around Yatra. Yatra is a travel app that all of us are using. Yatra had my name, my email address, my phone number, my password, and my postal address as well. So we have to be extremely careful about what we put on the web, as well as make sure that we change our passwords as frequently as possible. Now, let me give you one more example, and this was on 4th January 2025. A Tesla truck was used for a terror attack outside a casino in Las Vegas. And then the police wanted some help from Tesla. So they found Elon Musk. And what were they able to provide? They were able to remotely unlock the truck. Okay, remotely unlock the truck. And then they provided CCTV footages of where the truck was 24 hours continuously for the previous 6 to 8 weeks. So please understand, our privacy is gone forever. If you are using any camera, any phone, you are already part of this. There is AI bias against India. I was looking at something and I said, please give me Indian references that says that these scores are different in the Indian context as opposed to the Western world. And it said no published peer review articles. Okay. Then I had to remind that I think you are wrong. There are at least 3 references on this, and I gave the references. And that is when it said, yes, you are absolutely right. I made a mistake. So please understand, AI can make significant mistakes, and this is particularly true for Indian publications. This is the difference. What international articles say that the tug score, time to get up and go, is 13.5 seconds. But Tata Hospital has proven that 10 seconds is very important for response and toxicity of chemotherapy, and 12 seconds is important for a risk of fall. So we must ensure that we follow Indian guidelines and Indian references rather than international references. So did this experience of artificial intelligence change what that AI tool will do in the future? The answer is no. Once we log out or start a new chat, the previous memory is deleted. So now if I ask the same question again, the response will be the same, that these references do not exist. And therefore, big companies like Apple are now trying to modify their AI to make sure that it is right. But our patients are very smart. Now they are using AI with malified intentions to find out what is wrong in the discharge summary so that they can go to the court for against us. So there is something called the idiot syndrome. Idiot syndrome means internet derived information obstructing treatment. For the last 2 minutes, I will talk about what now. Earlier this year, we published Is Rapid Incorporation of Technology a Blessing or a Curse? And none other than Dr. Atul Gawande has said on NDTV that doctors not using AI will get replaced. So let us see this replacement part. TCS has said that they will have as many AI agents as employees. How many of you know what is an AI agent? Please raise your hand. At least 3 or 4 people have raised. So we know only these agents, right? Raw agents. I use Claude to make a flight calendar agent. What it does, it looks at all my emails, looks at what flights I am taking, takes down all the information and puts it in my Google Calendar. So I don't have to do it manually. So this is something that I could do when I had no coding experience. And the agent, to explain to you what is an agent, I have taken the example of the Akbar Bilbar story of the caravan, right? So Birbal sent somebody, Akbar sent somebody, and he said, go and find out where the caravan is from. So the guy went and came back and said the caravan is from XYZ. Then he said, okay, now you go and find out where the caravan is going, and so forth and so forth. So that guy went 5-6 times and each time brought some information. Then Birbal was sent, and Birbal came back with the caravan and he said, this caravan is going from this to this. It is carrying these goods. They are wanting to sell it at this price, but we need it and they are giving us a discount. So I bought it and they are coming here. So an AI agent does everything that you expect it to do. If it finds an obstacle, it will also find the solution for the obstacle and give it to you. That is an AI agent. And we are actually doing a hands-on AI workshop that we can do for other people also. Last month we did it at Bengaluru during the 54th ICON conference. And you can see that all the people were actually working on their laptops to develop programs. But there is another aspect of this AI agent that I would like to tell you. And I'm taking the example of Amazon. The names on your left hand side, do they ring a bell as far as you are concerned? What is it? So these are the names of the AI powered robots that are being used in the warehouse of Amazon. Recently, they commissioned the millionth robot in their warehouse. And how many people, human beings, are employed by Amazon in their warehouse? 500,000. So twice as much as human beings are the robots that are providing that information. And therefore, Amazon is able to make 283,000 US dollars every minute. So in the 20 minutes that I am spending with you, already they have earned 53 crore rupees. Now this is the difference between what humans can do and what AI can do. Before AlphaFold, from 1969 to 2015, humans were able to identify the 3D structure of 100,000 proteins. Between 2016 and 2022, the AlphaFold program was able to identify the structure of 200 million proteins. So there is no comparison what humans can do as opposed to what AI can do, and therefore 14 million jobs are going to disappear in the next 5 years. So if somebody says that career survival in the AI age has nothing to do with the AI agent, then please remember that he is a bad joker. And if you want to know more information, you please join us, Association of Artificial Intelligence and Oncology, which is being developed by Dr. Pawan Raghav Reddy. With that, I thank you very much for a patient hearing. And I always end my talks with a salute to the Indian Armed Forces, because we are at liberty to come and speak and talk freely here because of the sacrifice that they make at the borders. Thank you very much.
Thank you, Purveshwar. Really interesting talk, and as always, you have been leading on even on the technology side. The technology side, if you say AI has tremendous potential, as you mentioned, it largely solves problem of scale, as you showed us that the number and the grunt work that we tend to do, so those grunt jobs will be gone. More deep work will be required. So next
Absolutely.
generation has to go deeper in knowledge generation. Deep work has to be done, and it gives you a very smart, hyper smart intern or an assistant that makes it easy. But you are the real holder of the wagon. It will as doctors, it will never change. We are liable. We are answerable to the actions we take based on whatever AI tells us. So,
Sure.
with that, any questions we will be to.
Thank you.
Thank you for a wonderful session. I request our chairperson, please felicitate our speaker with mementos.
May I invite Sandeep Gavri sir, please, who can help us on the stage. Sir, please, sir, please. Vincent, sir.
So we'll continue with one more session, and I request the chairpersons again to stay back. For next session, I would invite Dr. Mehboob Basade, who is a past president, ISMPO, and director of medical oncology at Jaslok Hospital, Mumbai. And he is going to talk on from innovation to impact role of nivolumab in non-small cell lung cancer.
Thank you again, Ravi, for inviting, and thank you, Zydus, for providing me the slides for this session. Not these slides. मैंने जो भेजा
ये उधर कॉर्नर में रख दूंगा. I request Dr. R.K. Panda, chest physician from Raipur, please join the dais as a chairperson.
full screen, full screen. Full screen. Sorry for the mix-up of the slides. I changed few slides, so that's why. So thank you, Zydus, for providing me the slides. And as you will be aware that nivolumab is the first Indian IO which is into the market, and we oftenly don't discuss nivolumab in the non-small cell lung cancer. And when they said me to discuss, then I said, okay, we will have to look more into the data. So what I will be discussing is that the role of nivolumab in the neoadjuvant setting in resectable early non-small cell lung cancer and in metastatic non-small cell lung cancer. So in both these settings, I will show you the what is the evidence. So first is in the first two trials will be in the early non-metastatic non-small cell lung cancer. This is the Checkmate 816 neoadjuvant neo plus chemotherapy in the stage 1 B to stage 3A. So tumor had to be more than 4 centimeter, and up to 3A were resectable. Those who were resectable, non-small cell lung cancer, and obviously any targetable mutation like EGFR, ALK, etc., were excluded. So here nivolumab was given along with chemotherapy for 3 cycles. The dose, remember, it's 360 milligram. And so 3 cycles of chemo plus nivo, then surgery was done within 6 weeks. And there was an optional adjuvant chemotherapy if it is required, plus minus radiation. But remember, this is only neoadjuvant nivolumab. There is no adjuvant. This is not a perioperative. This is only neoadjuvant. And the eligibility criteria, it was given in both squamous as well as adenocarcinoma, both these things. And the results got was almost 25% HCR. It is very important. 1 in 4 is going to achieve the pathological CR. And pathological CR by stage wise, if you see, the highest was in 1B. Obviously, the tumors were small, 4 centimeter, early grade. So that's where the pathological response went high. And as you move down towards around 23 to 24% of the patients had the pathological CR. But 1 in 4 had good pathological CR, and you can see the depth of the regression by the tumor size wise is showing a wonderful regression in all. So when the patients were given, almost 358 patients were there. Majority of the patients completed the planned the trial. The 4-year update is shown over here, and what you can see, the median event-free survival is almost 43.8 months versus 18.3 months when only the chemotherapy was given. That means that this addition of a neoadjuvant 3 doses of nivolumab has improved the event-free survival. There is a 5-year OS data now, and it has shown that the 5-year OS, 65% of the patient are alive at the end of the 5 years, as compared to 55% were only with the chemotherapy. And obviously, the survival is better in the early stage, despite the PDL1 status. So some safety summary is we all know that the nivolumab, any immunotherapy has its immune related side effects, but we have learned all that how to manage the side effects. So that's not a big challenge right now to manage with that. The another study is this Checkmate 77T, and this is again a phase 3 trial where this is a perioperative where chemotherapy and nivolumab was given. Here they were given the 4 cycles. Then the surgery was performed, and then nivolumab was continued for a total period of 1 year. So this is like perioperative. The first was only the neoadjuvant trial. And if we see here, the median event-free survival for the patients who received the nevo has not yet reached. For the stage 2, it was 78, 12 months EFS, and at stage 3B, it was 71%. And this hazard ratio has been really very good, showing around 0.58%. The patients who had a PDL1 expression more than 1 uh, had a better event-free survival. That is, it has not reached median yet. But while the patient who had less than 1%, it was 29%. Or the patient. So pathological response rate almost same, 1 in 4, that is 25% PAT-CR was achieved in this setting also. So the neoadjuvant part remained the same. So if you give nivolumab, you will have 25% PAT-CR. So these are the conclusions that neoadjuvant nivolumab plus chemotherapy followed by surgery followed by nivolumab has a meaningful event-free survival. In the first trial, which I showed PAT-CR also same. Here also it is almost practically the same. But the overall survival, the chart response has not yet come in that. So what should we take home? Which should be using it? Whether we should use only neoadjuvant therapy or we should use perioperative approach. So this is my opinion. I mean, that is what I put it there. So if the patient who achieves PAT-CR, probably there is no need to continue further and you can prevent financial toxicity, other toxicity, especially the patients are in the lower early stage disease, stage 1B, stage 2. In stage 3 patient, probably you may go ahead with the adjuvant part. So if you have a multi-station N2 disease or the patients who have not achieved the pathological CR or PDL1 is less than 1%, this group probably you go ahead with the not only neoadjuvant but the adjuvant nivolumab part as well. So these are the two conclusions. Now we will go into the metastatic non-small cell lung cancer, and this is the Checkmate 9LA. This is a chemotherapy plus dual IO, that is neo EP, which is given along with the chemotherapy. But chemotherapy cycles have been just 2 cycles, and the therapy has been continued maximum for 2 years or until the toxicity. And the versus that was only the chemotherapy 4 cycles. And maintenance pemetrexed was allowed over there. So if you see the median OS for all patients was 15.8 versus chemotherapy of 11. This is at the end of the 4 years, and we have a 6-year data also. This is the subgroup analysis. This is the 6-year OS. What you can get over here, the median OS is 15.8 when the 2 cycles of chemo plus Nivo EP is given as compared to 11 months with the chemotherapy arm. So this is the trial which has shown that 2 cycles of chemotherapy alone, along with the dual IO, you can have a good chance of survival over a 6 years follow-up period also. So these were their conclusions in that. So going forward, they did another trial where they removed the chemotherapy also. So that's the Checkmate 227, where there is no chemotherapy. It's a chemo-free, only IO-based therapy, whether the PDL1 is there or PDL1 is more than 1 or less than 1%. So we look more into the part 1 group, that is PDL1 more than 1%. And in this subgroup, Neo EP, that is chemo-free regimen, has shown median OS of almost 17 months and 4-year OS is almost 30%. So 1 in 3 will survive 4 years without chemotherapy only if the IO is given, as compared to only 18% when the chemotherapy has been given. Response rates have been also good. So overall response rate is almost 36% versus 30 months. The patients who are PDL1 less than 1%, again the median OS is almost 17 months versus 12.2 months. So irrespective of the PDL1 status, the response rates are better, in fact, in more than 1%. But even in PDL1 less than 1%, you do get responses, and you can have the chemotherapy regimen free treatment for such patients. So we have a Checkmate 227 5-year update, which is showing that those patients who received Neo EP 5-year, it's at the end of the 5 years is almost 24% of the patients are alive through that. So among these two, what we should choose, whether you should go ahead with the chemotherapy or chemotherapy free, if there is a tumor burden high, and if the patient requires an urgent tumor reduction, probably addition of chemotherapy with the Neo EP will be better. But if the patient is frail, not fit for any chemotherapy, if there is no urgency, you will have same chemotherapy free in chemotherapy free regimen of Neo EP can also be given to such patients. So overall response rates, as you can see here, Neo EP is 35%, and Neo EP with the chemo is around 55%, and median duration of response with just chemo-free regimen is 23 months, and that is what is there. So this data is from the Zydus, the nivolumab. So Ravi, I finished 5 minutes before. Thank you. Thank you very much.
Thank you, sir.
Thank you, sir.
Any question from the audience? If no, we conclude the session. I request our chairpersons, please felicitate speaker with the memento. And I request our chairpersons for their great job. Continue 3 sessions there. I request our chairperson, please collect their mementos from the memento podium, which is outside the auditorium. Yeah. I request Dr. Naveen Jain, please give mementos to our chairperson, please. जो postpone हुआ था। हाँ, इसमें करना है।
तो इसके लिए चेयरपर्सन
For the next talk, I will invite Dr. Bharat Bhosle. Please come on the dais. Dr. Bharat Bhosle is a senior medical oncologist from Mumbai, ex Tata, and he is going to talk about redefining the treatment paradigm in IDH mutant glioma, precision targeting with vorasidenib. And to chair this session, let me invite
ठीक है, तब तक हो जाएगा। उनको तब तक बैठा लेंगे जरा, ये चलता रहेगा।
चेयरपर्सन है।
To chair the session,
I would invite Dr. S.N. Madaria, sir, neurosurgeon Raipur, Dr. Anil Sharma from Raipur, Dr. Sanjay Sharma, sir, neurologist Raipur, Dr. H.P. Sinha, sir, again neurologist from Raipur, and Dr. Rajesh Jain, sir, who is a neurologist.
Along with that, let me invite Dr. Puneet Seth to come on the dais to chair this session. And Dr. Pradeep Chandrakar, sir. Please come on the dais to chair this session. Thank you.
न्यूरोसर्जन हाँ गुड गुड मिनिस्टर आएंगे अरे
over to chairperson, please. Go ahead.
would like to say that.
So you are speaking on a recent topic, and it is good for radiation oncologists also. Please start, sir.
So I'm a medical oncologist. So we are new to gliomas because we used to manage with only temozolomide because PCV used to be very difficult to but I think medical oncologists used to look after that part only. Largely, it has been a disease of neurosurgeons and radiation oncologists. Obviously, in difficult time, both surgeons and radiation oncologists call medical oncologists. We talked about precision. Tomorrow there is again I have to talk on precision oncology, but AI is changing away. I assume in the surgical part is shown the radiation, the AI is helping a lot for precision in terms of planning. When we talk about glioma, it's not about survival; it's the comorbidity which comes with both the modalities. Surgery because it's a delicate organ, and to get a clear margin is something which is sometimes next to impossible. So safe resection, gross total resection, which we talk about. Then comes the radiation. Yes, it is important for survival, but the problem comes with the when the patient survives, the late side effects. So there comes now this drug, and we have been doing IDH. We know that low grade glioma, high grade glioma. I will not go into the details. We'll stick to the this trial. Thanks, Dr. Ravi. Second time I'm in Raipur, away from Mumbai hit. I thought Raipur would be better than Mumbai, but it's better and severe. So we'll be discussing this phase 3 trial Indigo. It's a randomized double-blind trial. The drug vorasidenib has been evaluated. The other IDH1, which has been predominantly used in the pancreatic biliary, is an oral brain penetrant. It's a dual IDH1 and IDH2 inhibitor. So the population was IDH mutant, both 1 and 2, WHO grade 2 glioma. So it was for low grade gliomas, not for high grade gliomas, following surgery. So surgery has been the backbone of low grade gliomas. And what was the unmet need? As I mentioned, the delay, the intention of here, sometimes or most of the time, I respect the surgeons who do the great job always. I am from Bombay Hospital, where a large number of surgeries are done, and so large volume of one of the highest volume center in the country. So then the surgeon thinks of delay the disease progression. So whether we can avoid the radiation. As I mentioned, sometimes radiation comes with the side effect. Chemotherapy, obviously, for low grade gliomas, we don't introduce chemotherapy unless they relapse many times. So the primary objective here was PFS, progression-free survival, and the secondary objectives were delay the next intervention in terms of the radiation or chemotherapy, safety, quality of life. Quality of life is very, very important for glioma patient.
So if you look at the biology of evolution of a glioma, when it develops from a normal cell to low grade and high grade, the first hit happens at the epigenetic level. It is not the mutation which is happening. And over a period of time, if you allow the metabolites to accumulate, the genetic hit happens, mutations happens, and that genetic driver leads to a high grade transformation from a low grade. So methylation is the early event. If we target that, we may prevent the high grade transformation. That is the hypothesis while developing this drug. The discovery of this particular mutation happened in 2009 as a key driver of glioma. So as I mentioned, epigenetic dysregulation happens, then there is a block at cellular differentiation level and pathological cell renewation of the stem cells, upregulation of the PIK3 AKT signaling, and that contributes to the immunosuppressive landscape. And immunotherapy is also has been evolving. We are still not in a brain with the immunotherapy. So there is a disturbed DNA repair mechanism. There is a BRCA. So if you see in the healthy cells, what happens? So this is a progenitor cells. There is a hit. There is a mutations. Then it goes to glioma precursor. Problem of this mutation. So this is a pathway of citrate to isocitrate, which is converted to alpha ketoglutarate. When there is a problem in this particular mutation, IDH, the conversion of alpha ketoglutarate happens to 2-HG, and this 2-HG metabolite is an oncometabolite. The more the concentration of this, the progenitor cells are converted into glioma precursor cells, and if the hit continues, the low grade transformation to high grade transformation happens. So this is the trial design. It's a phase 3 trial. There are key eligibility criteria: fit patients with these two mutations, grade 2, one or more than one surgery allowed, measurable lesions, more than one target lesions, 1 centimeter or above 1 centimeter, and not in need of immediate chemotherapy and radiotherapy as for the investigator assessment. Dose was 40 milligram versus placebo. The other standard of care is like low grade for observe. And endpoints, as I mentioned, is the progression-free survival. And there was secondary endpoints, delay the time to next intervention. And they looked at the quality of life, overall responses. Seizure control was one of the important, because we know when there is a surgery happens, all the patients we put on anti-epileptics, because seizure reduces your quality of life. And sometimes these are young patients who are into skillful jobs, and they have to change their total occupation because of this disease. So that becomes one of the important endpoint. So patient demographics well balanced between two. So this is the primary endpoint. So if you give this drug within to 2.5 years, so if you do surgery up to 2.5 years, is allowed to put the patient on these tablets. It's an oral drug. So if you see the graph, primary endpoint PFS, the median is 27.7, and placebo, which is observation, is 11 months. So 61% reduction in risk of progression and death. So there is a 16.6 months benefit in terms of PFS if the patient takes the oral tablet. We'll not talk now about the cost, because cost effectiveness is something which is very critical in India. But yes, the primary endpoint, the trial succeeded in showing that there is a benefit of 16.6 months in terms of the progression-free survival. So patients receiving vorasidenib remained on the treatment. The side effects are not too much. You just have to monitor the liver functions. So median follow-up, there were this follow-up was continued till recent ASCO, and you have more number of patients. 73% of the patients on vorasidenib and 44% of the patients on placebo. That shows that the quality of life is also maintained and the progression was delayed. The discontinued treatment 26% versus 55%. And there is a disease progression of 18% versus 47%. So when we look at the longer follow-up, the long-term PFS at 12 months, 24 months, if you see 47% on the control arm and 77.3% with vorasidenib. And when we look at 2 years, it is just 26% on observation, that is placebo, and vorasidenib, nearly 60% of the patients remain without progression. So longer follow-up confirmed the statistically significant improved PFS observed at interim analysis 2. So this is the interim analysis 2. Now coming to the key secondary endpoints, this is very, very critical. So we want our patients to live more, so we introduce radiation, but radiation comes with a long-term side effect, especially if it is a whole brain delivery. And these are young patients. The cognitive decline, the quality of life, the performance, as I mentioned, occupations, they have to change their occupations. So every patient needs to be discussed. What patient needs to be included in the decision making. So if you look at the delay in the time to next intervention, the vorasidenib is still not reached the median. And if you look at the observation, which is placebo, it is 17.8 months. So there is 74% reduction in time to next intervention. And most of the time it is surgery or radiation. Mostly it is radiation. So this ASCO 2026, they looked at the updated results. So vorasidenib demonstrated a statistically significant and clinically meaningful improvement versus placebo in patients with grade 2 IDH1 and 2 mutant gliomas. Total number of patients were 331. So if you look at the unblinded follow-up, which is January 17, 2025, median follow-up when it was 41.6 months. So first presented this, the PFS was again statistically significant over here. This is the extended follow-up, showed the median PFS as per the blinded independent review with vorasidenib was 44 months. And if you look at the 1 year, 2 year, 3 year, and 4 year, 48% of the patient, nearly 50% of the patients remain disease free, means the disease did not progress. If the patients on tablets, most of these patients showed some responses, reduction in the size of the no seizures. That is very, very important. So primary endpoint extended, nearly 50% of the patients remain disease progression free. Again, this is very important for me. Rather than the PFS, the time to next intervention was delayed and median time to next intervention was not reached with this drug. Now coming to subgroup analysis, whether the patient was less than 40, more than 40, based on some mutations we do, that is 1p19q deletion, whether they are co-deleted or not deleted, number of surgeries, whether it is less than one or more than one or two more surgeries, all the subsets. And I mentioned about the resection, gross total resection. So whatever amount of disease you keep, the drug was benefiting in those patients. And this is again about, as I mentioned, about the amount of residual left, the quality of life. The seizure analysis, if you can see a rate of on treatment seizure is nearly 20% versus 50%. So those patients who are not receiving vorasidenib, 50% of the patients showed seizures. And we know what happens to a seizure patients if they are on the job, especially the skillful job. Side effects, yes, this drug comes with the side effect, but not very significant grade 3 side effect. This drug causes increase in the transaminitis. You have to monitor the LFTs more frequently, initially per every month. Fatigue comes and other side effects can be easily managed. So this comes into the guideline and comes with a great cost. One has to involve all the specialties treating the tumor, including the surgeon who is the center point in glioma treatment, then the radiation oncologist, medical oncologist, because now we have a precision treatment. I feel apart from this, the occupational therapists, the physiotherapists, the social workers, they also need to be part of this because in glioma, I believe patient is not the only person whom you treat, is the caregiver, is the family member. Entire family becomes stressful because these patients sometimes lose power, lose jobs. Most of the time, these are the people who are bringing bread to the family. So all these things needs to be considered when the cost of the drugs is exorbitant. Luckily or fortunately in India, the cost is significantly low, but still it is out of reach of common Indians. So I will take the Ravi's permission to request the surveyor to bring down the cost so that most of these patients from the Indian continent will get help. And I would like to thanks for the opportunity again, the organizers, Dr. Ravi and surveyor. Thank you. I think we have finished in time.
On time. Thank you. We welcome Dr. S.N. Madaria, sir, from Ramakrishna Care Hospital as a chair. And Dr. Anil Sharma.
So your take on last 2 decades or your of journey of low grade gliomas, especially we are not talking about high grade gliomas. And now these drugs, first time there is some drug in precision. I'm not saying it's for all, absolutely not for all. but selective patients who wish to know there is a drug exists which can prolong the progression or gets a longer progression-free survival.
With IDH varieties, concept has changed. There is nothing like low grade glioma. All the gliomas are the high grade. It is starting from two wild type, mutant type, and simple types. So most of the gliomas we initially consider when I was doing neurosurgery in 90s, some low grade and the high grade. But here I feel all the gliomas are the high grade, which is it is the only time. And now the role of the oncologists are much more in the glioma treatment post-op.
Not much, but we are slowly entering. But you are right. I think we need to have awareness because this last week, one young fellow who was in the merchant navy presented to a gastroenterologist with a repeated vomiting, and when we looked at the history, he had a history of headache. So people, obviously, we don't pay that much attention. You are on WhatsApp, you are on EI, no, you have neck pain. So I think there has to be a spread of awareness among people that headache needs to be addressed early. And in that process, as I mentioned, first hit happens in the epigenetic space and then the mutation happens. So the transformation happens sometimes. So if you pick up early, maybe your surgery can damage less part of the brain and the quality of life and the morbidity or the mobility can be preserved. That is very important, what I feel so.
Quality of life is very important because post radiotherapy we are seeing patients. So in this study, this Indigo trial has changed the scenario as you're showing. 16.6 month over the placebo. It's really great. I mean, imaging wise also, and this.
Right.
So for young patients, it's a good emerging.
At least the option needs to be discussed.
Yeah.
It's difficult, when it comes to the cost and when we have to put a patient on tablet for a longer period.
Yeah, very, very nice talk. And actually, this has been the most significant recent development. If we see the history of glioma surgeries and management, and this subgroup particularly constitute the most common group. IDS mutant grade 2. This is the most common subgroup. But there are few questions that remain unanswered, like how long we need to give.
Absolutely.
Well, like
I
we
also
do not know. We do not know. And when to subject, particularly when to subject patient for this. Like low risk, high risk, there is stratification. But there are still many questions that remain unanswered. So only time can tell that.
No, this question started in my mind and still it lingers in my mind. But if you remember when the CML started, the standard of care was allogenic transplant, right? And the cost of Gleevec was exorbitant, and you didn't have any idea how long it will go. Then the Gleevec program came. That's how people started accessing the drug, and now the drug is for free or 1,000, 2,000. So obviously, initially it looks difficult. When the immunotherapy came, the cost was exorbitant. Hardly any patients used to have access. Look at every other patient is now having access. So with time, it will definitely come. But when it comes to glioma, not like other disease, the modality which we wish to delay is radiation. If you can delay, and obviously it is delaying, it is not completely curing the disease. At least during that younger age, like there was a patient, as I mentioned, he was 23-year-old, high grade glioma. But there was a musician who was 40-year-old and low grade glioma. He wants to preserve his skills. At least this option needs to be discussed. Obviously, it is not for all. It needs to be personalized. This is an expensive drug, but at least now there is an option which needs to be discussed in the MDT, and we have to include the patient also into the MDT.
Yeah, that I agree completely. That most recent development. But still, we need to see like.
Absolutely, I agree. Completely agree with you.
We need to see like suppose some young
Duration.
patient tumor has been resected completely, and shall we offer? Or shall we just wait and watch?
No, we have
An answer.
So we have brave surgeons who operate on gliomas twice, thrice, and they do fantastic job. So if you delay that, get a good quality of life, then comes the radiation. The radiation is also evolving now. We have proton, but we have to agree that once all these modalities are used, the cognitive decline goes down, the performance status goes down.
Yeah, radiotherapy is also its own hazard.
I'm a radiation oncologist.
No, I totally agree with you. I'm not against radiation oncology.
Say that we generally don't require whole brain radiation in gliomas, and now we do hippocampal sparing for
Yes.
preserving the cognition, and then we have drugs like memantine and all to support that.
Yeah, so I'm not against radiation. I'm a radiation friendly medical oncologist. But there is some hope we can discuss. Yes.
We can say nothing like it.
Sir, which subset of patients which are selected, complete resection or subtotal resection? Which subset and what is the difference in the results?
I personally feel if the surgeon has, again, low-grade glioma, if you have picked up early, you have preserved functions and you have done an excellent job, there is less residual, there is no residual disease as per the surgeon's discussion. I think those patients should not be put on the trial. But in the trial, if you see, irrespective of the excision, both the subsets have benefited. But I would not personally push that patient for this. If you feel that there is a significant amount, again, the significant volume and this discussion has to happen on the post-operative scan. You have to have the post-op scan at 48 hours or 21 days. These things are very critical. You do it in a high volume centers. And then these things should be discussed because surgeon knows because he has operated inside the OD. You and me are not sitting over there in the OD. And like that, we can choose those patients. Again, the question comes when to start because in the trial, that's some patients have started in 2 months, some patients have started at 5 years. So when to start is the big question, and when to stop is the another.
Yeah, I think only time can tell that. It remain still at that this stage. It's very early to say whether to start for 5 year or 10 year or lifelong.
No, he said the. That's why. Okay, no, I mean, I will share my experience because the questions what has been raised on the stages are valid. One of my classmates' daughters just finished her gynecology exam, and the day she started practicing, she is 30 years old. She got convulsions, and the married 2 months back, and she was alone at got convulsion, and obviously when the MRI everything done showed that she had a left frontal lobe close to Broca's area, low grade glioma, though the Ki67 is around 5%. So whatever the surgeon has possible did the surgery and it was being close to Broca's area. So obviously some part is remaining. Now the same question is being asked whether because she is gynecologist would like to operate and whatever goes through. So whether to start radiation now to have a neurocognitive problems as the radiation oncologist has said now the hippocampus probably will be there. So this option is there for her that at least she can do and we can delay the radiation as much as possible. How long? Nobody knows. When to start? Nobody knows.
Yeah, that's true. That molecular the genetics and treatment targeted towards molecular genetics that's evolving, and I think it will evolve over a period of time. Thank you.
Thank you. Thank you.
Thank you,
Thank you
sir.
all chairperson and panelists.
Thank you, sir. I request our chairpersons, please felicitate our speaker with a memento. Dr. Ravi, please. And I request our chairpersons, please collect their mementos from the memento podium, which is just outside of the hall. Our health minister is supposed to come shortly. Anytime. I request all the delegates who are standing behind just
Everyone, please remain seated, occupied. We will continue with our session. And as soon as he comes, then we will stop for a time. Please occupy your seats. For the next presentation, which is going to be interesting discussion on heart talks, I hand over to Dr. Gaurav Gupta.
Before that, I request our chairpersons, please collect their mementos from the memento podium. I request Dr. Ravi Jaiswal, please give mementos to our chairpersons. I request Dr. Santosh Singh, please.
For the next talk, let me invite our chairpersons, Dr. Ashutosh Gupta sir, Dr. Devin Naik sir, Dr. Manjula Bek ma'am, Dr. Firoz Memon sir, Dr. Babuji Meher, Dr. Ajay Govardhan sir, Dr. Visham Shadani sir. Please quickly come on the dais.
Dr. Jay Rai.
Yeah. Maybe you can come on the sofa for chairing the session so that yeah, please.
Respected seniors, dear colleagues. So I welcome you all in this session of SBRT. So it was started as a niche tool for lung and spine, but it slowly waved into abdomen and pelvis. So we will have 3 talks on prostate, pancreas, and liver. So first talk, I would like to, I will request Dr. Charu Garg ma'am. She is a renowned radiation oncologist of India from Delhi to deliver her talk on prostate, ma'am.
Rest of the chairpersons, Dr. Jay Rai sir, Dr. Bisham Shadani sir, Ashutosh Gupta sir, please come. And I request all of you to please remain seated. Thank you.
Thank you, Dr. Gaurav, for the kind introduction. And I think Dr. Purvish just said that, we can operate the patients from, kilometers and kilometers away. So we are not really surgeons, but even we can sort of, treat the patients with stereotaxy, which we call stereotactic radiosurgery or stereotactic body radiotherapy. So it is like, you would have heard different names like cyber knife, X knife, gamma knife. So these are all knives, but we really don't go in and operate. It's done at least from, 100 centimeters away from the patient. So I'm going to talk about the role of SBRT in prostate cancer. So I know it's a very mixed crowd, but normally for the radiation oncologist, it's the alpha beta ratio on which we operate. So for a very long time, we were treating prostate cancers with something like, for at least, 6 to 7 to 8 weeks of radiation. But then we found out that the alpha beta of the prostate cancer was very low, and then we could hypofractionate. So in this graph, you can see as we keep on decreasing the number of fractions, increasing the dose per fraction, the red one is the normal tissue, it keeps on getting spared, and the blue one is the dose delivered to the prostate cancer. So now we can deliver radiation in just 5 sittings. Instead of, 39 sittings, we can do it in 5 sittings. So it is more convenient for the patient, it is cost effective, and also more patients can be treated in the high volume centers. Here I have just tried to show you the BED. You can see here with the prostate BED, with the SBRT, it is around 154, which is comparable to the conventional fractionation where we were giving 37 fractions. And the rectum here, you can see the conventional fractionation. It is around 123 vis-a-vis SBRT 106, which is lower than that. So we have best of both the worlds. We can give more dose to the prostate and less dose to the normal tissues around. And if you see the indications of SBRT, this is the NCCN 2026 publication. And here you can see that we can use SBRT in almost all the indications. So let's look at what are the evidences we have. So we have the evidence with these 4 randomized trials. The first one is a hypo-RT prostate cancer trial, which was done in 2005 to 2015. It is basically a randomized non-inferiority phase 3 trial. And they had recruited intermediate risk patients mostly. Very few were high risk. And you can see here 39 fractions versus 7 fractions. This was the schema. And 5 years, the biochemical freedom from survival was similar. Recently in Lancet, they have published their 10-year results. And here also you can see that the failure-free survival is similar in both the arms, that is the conventional and the SBRT. So it confirms the non-inferiority of SBRT over conventional. So imagine 37 fractions versus 5 fractions. And if you see the toxicities, just apart from a grade 2 urinary toxicity, that to just acute, none of the other GU or the GI toxicity. That is what we are worried about when we are treating prostate, GI or GU. So you can see at 5 years, at 10 years, there is no difference. This was the PACE B trial, which happened from 2012 to 2018. It had only lower intermediate risk patients. Again, you can see 39 fractions versus 5 fractions. Acute toxicity, no difference. Their 5-year results came out in 2024. And here you can see the 5-year biochemical failure-free survival was again similar in both the arms. Overall survival was again same in both the arms. If you look at the toxicity, in the second year around, there was slightly more toxicity, but eventually, if you see at 5 years, the toxicity was normal. And the patients who had baseline higher urinary frequencies or higher urinary complaints, they had more acute grade 2 reactions. GI wise, they were same. This was another randomized phase 3 trials. They said that they wanted to establish that SBRT is superior to moderately hypofractionated IMRT. So the results are still pending. The early results says that SBRT has better overall quality of life as compared to the moderated hypofractionated IMRT. Urinary complaints were similar. No. So this is a review literature in the high risk. So till now, we have, non-inferiority trials for low and intermediate. Let's look what happened to the high risk group. So this was a systematic review of the literature, which was recently published in Feb 2026. 30 studies, 1,400 patients, and the biochemical control rates, even in this high risk patients, was pretty good with low toxicity profiles. And they were done on different platforms like CyberKnife, MR-Linac, tomotherapy, or Linac. So no difference in toxicity rates or efficacy outcomes. So these are the three trials which are being done in high-risk prostate cancer, the PACE-C, the ASCENT SBRT, and the PRIME trial. The PRIME trial has been, the principal investigator is Dr. Vedant Murthy from Tata. And this year, they have presented at ESTRO 2026 their early results. Here you can see that this, remember that this was done in the high grade prostate cancers. So here you can see that the acute grade 3 AEs were very low. The acute grade 2 were also similar. Only the patients who had prior TERP, they had slightly higher incidence of grade 2 urinary complaints. So I think this is very important. How do you select the patients? So we know that low, intermediate risk can be selected. High risk is with caution. Not suitable are the patients who have got severe urinary obstruction, large prostate volume, or who have an extensive TERP cavity or acute inflammatory bowel disease. IPSS score for this thing should be less than 15. No TERP. If the patient has underwent a TERP, please wait for 4 to 8 weeks. And prostate volume should be ideally less than 100 cc. Photon versus proton, I think no talk is complete if we don't talk about proton. But this was a meta-analysis. And here it has shown that there was no difference in the ultra hypofractionated arms. So these are few of the guidelines. I think the people who are trying to incorporate SBRT in their treatment armamentarium, they should read these papers about target delineation, guide to the treatment. The dose constraints have to be very diligently followed. Upcoming trials in prostate cancer are Saber Dual, PACE, Mirage, where they're comparing MR-Linac versus Linac-based RT, CT-based RT. Then they are comparing stereotactic body proton therapy versus stereotactic body photon therapy. So in the end, I would just like to say that the verdict is unambiguous. SBRT delivers superior BED with level 1 non-inferiority data across low and intermediate risk groups. It is emerging in high risk groups. The non-negotiable triad for SBRT is patient selection, robust image guidance, and a disciplined dosimetry. And the future is exciting because you have MR-Linac studies which are going on. Then you have ultra hypofractionation. Now, instead of 5 fractions, they are trying to do it in 2 or 3 fractions. And then, of course, the artificial intelligence contouring. So, with this, I would like to conclude. Thank you. Any questions?
Ma'am, excellent talk, ma'am. What measures you take for motion management, ma'am? Motion management.
So you have different, modalities for that. Like in tomotherapy, you can put markers, or like we do it on VMAT and tomotherapy, we are doing it without the markers. So there is a stringent, bowel and bladder protocols which we follow, the diet which we follow. The patients are given, a detailed pre-SBRT protocols. So and then onboard imaging has to be there. So, I mean, different people are using different modalities.
And role of internal physician. Do you place internal
No, we
physician?
don't do it, but I mean, a lot of people are doing it.
Thank you, ma'am. Excellent.
Thank you, ma'am. I request our chairpersons, including Dr. Chandramani Siddhar, please join for the felicitation. I request our chairperson, please give momentum to our speaker. As we know, our health minister is here. And I request our chairpersons, please collect their mementos from the memento desk. Thank you all. I request again Dr. Santosh, please give mementos to our chairpersons at memento desk. And for the further proceeding, I request Dr. Shamik Dave for the inaugural session.
गुड इवनिंग एवरीवन। हमारे राज्य के स्वास्थ्य मंत्री श्री श्याम बिहारी जायसवाल जी पधार चुके हैं। आपका सर तहे दिल से स्वागत है। मैं चाहूंगा कि सभी लोग जोरदार तालियों से उनका स्वागत करें। मैं अनुरोध करता हूं सर से, डॉक्टर दवे सर से, डॉक्टर रवि जायसवाल सर से, डॉक्टर माऊराव मैम से, डॉक्टर गौरव गुप्ता सर से, डॉक्टर नवीन जैन सर से और डॉक्टर ज्योत्सना मैम से आए और कृपया स्टेज पे अपना स्थान ग्रहण करें। सर। हरीश त्रिवेदी सर प्लीज। मैं डॉक्टर संदीप दवे सर और हरीश त्रिवेदी सर से अनुरोध करूंगा कि रामकृष्ण केयर और उनकी टीम की तरफ से श्री श्याम बिहारी जायसवाल जी का स्वागत करें। I would like to welcome Dr. Harish Trivedi sir to felicitate our oncologists, which will include Dr. Ravi Jaiswal sir, our medical oncologist. Dr. Maura madam, surgical oncologist. Dr. Gaurav Gupta sir, radiation oncologist. Dr. Naveen Jain sir, surgical oncologist. And last but not the least, Dr. Jyotsna ma'am, nuclear medicine. मैं हेल्थ मिनिस्टर साहब से अनुरोध करूंगा कि सारे डिग्नेटरीज के साथ कृपया लैंप लाइटिंग के लिए आगे बढ़े। ऑन्कोसर्जन है लैंप लाइटिंग के बाद ये बोलूंगा, फिर यहाँ पर आएगा ना दवे सर के बाद ना। गुड इवनिंग लेडीज एंड जेंटलमैन, आई एम डॉक्टर शमीक दवे। मैं रामकृष्ण केयर परिवार का सबसे छोटा और नया सदस्य हूं और इतनी बड़ी रिस्पॉन्सिबिलिटी मेरे कंधों पे है आज के इवेंट की। At the outset of this splendid event, I feel it my proud privilege to extend a warm welcome to our Honorable Health Minister, Shri Shyam Bihari Jaiswal, and all the dignitaries who are going to grace this occasion with their auspicious presence. Today, year marks not just an inaugural moment of an oncological entity in Ramakrishna Care, but the birth of a renewed commitment to our patients and society, a renaissance where every cancer patient will have access to finer health delivery at worrisome times when hopes and fear float, when enigmatic and puzzling decisions have to be made. Cancer is no longer a distant or a rare disease in India. It is increasingly becoming a part of everyday health conversations. Yet, paradoxically, it continues to be diagnosed far too late. With rising life expectancy, rapid urbanization, lifestyle changes, and environmental exposure, India is witnessing a steady and a worrying increase in cancer cases. Eminently, Ramakrishna Care is not just a hospital, it is a movement to democratize high end cancer treatment for the people of Chhattisgarh and to bridge gap between high tech and high touch care. The independent installation of an unconventional, self reliant, and self contained oncological entirely in this hospital is going to create a less visible but increasingly important challenge. It is about challenging limits, redefining standards, and setting new benchmarks. The chief convener and designer of this Purple Team project are the rare bloom and renowned oncologist Dr. Ravi Jaiswal, the foundation stone of Ram Krishna Care, Dr. Sandeep Dave, and the untold insider Mrs. Samedha Dave. Very recently, this Dreamliner has been co-powered by the Golden Catalyst and Surgical Oncology Storybook, Dr. Mau Roy, along with Dr. Gaurav Gupta, Dr. Naveen Jain, and Dr. Neeru Karkatta. With this milestone, we are poised to operate with enhanced agility, singular, absolute, and strategic focus on key oncological issues. Thus, we take pride in celebrating an evolving legacy on tricky with a new color and growth that drives a meaningful change when the undiscovered becomes the familiar. On this auspicious occasion, we look forward to our Honorable Health Minister, Shri Shyam Bihari Jaiswal, for his unwavering and continued support to strengthen the healthcare infrastructure of this hospital and pave the future from design to development, inclusivity to innovation, and safety to sustainability. With these words, I feel it my proud privilege to invite Dr. Ravi Jaiswal sir, the dexterous craftsman and the opening batsman of oncology in this hospital, who has this unique perspective, insight, and expertise in the field to enlighten the learned audience with his distinguished guidelines and key considerations regarding oncological issues. Sir, please.
Honorable Health Minister, distinguished guests, respected faculty from across India. So we are proud to have more than 50 national and 500 regional faculties who have come for this OncoSphere. So huge round of applause for everyone who's attending OncoSphere 2.0. So as the tradition, we are getting bigger and bigger. So this year we are getting even bigger. And as you know that cancer cases are increasing day by day, दिन ब दिन कैंसर के केसेस बढ़ रहे हैं, पेशेंट्स बढ़ रहे हैं, ट्रीटमेंट ऑप्शंस ज्यादा आ रहे हैं. अब केवल सर्जरी, कीमोथेरेपी और रेडिएशन तक हम सीमित नहीं है. अब हम टारगेटेड थेरेपी, इम्यूनोथेरेपी, नोवेल टेक्नोलॉजी, इन सब की बातें करते हैं. तो जैसे कैंसर एक कॉम्प्लेक्स डिसीज है, इसे ठीक करने में एक एक्सपीरियंस टीम की भी आवश्यकता है. और एक्सपीरियंस चाहे कितना भी हो, लर्निंग इज कंटिन्यूअस प्रोसेस. हमको अपडेट होना है, नया क्या हो रहा है. अभी रिसेंटली एस्को की कॉन्फ्रेंस हुई, एस्मो की कॉन्फ्रेंस हुई, तो यूरोप और अमेरिका में क्या नया हो रहा है, हम छत्तीसगढ़ के मरीजों तक ये सेवाएं कैसे पहुंचा है, ये चर्चा से ये सारी चीजें निकल के सामने आती है. और दिन ब दिन कॉस्ट ऑफ ट्रीटमेंट कम होते जा रहा है. गवर्नमेंट इज ऑल्सो हेल्पिंग विद देयर फ्लैगशिप स्कीम्स का अब हम आयुष्मान भारत स्कीम में भी पूरा इलाज कर पा रहे हैं. दिन ब दिन आई एम हैप्पी टू से इवन इन रामकृष्ण केयर हॉस्पिटल 70 to 80% ऑफ पेशेंट्स का आयुष्मान भारत योजना से हम कैंसर में इलाज करते हैं. थैंकफुल टू आवर ऑनरेबल हेल्थ मिनिस्टर. सो अबाउट ऑन्कोस्फियर 2.0, आई थिंक आप सुबह से देख रहे हो कि वी हैव ऑर्गन स्पेसिफिक सेशंस और अभी भी हमारा रेडिएशन के एक्सपर्ट्स चल रहे हैं. सो आई थिंक विल कोलैबोरेट मोर, विल इनोवेट मोर एंड टुगेदर वी विल डिफीट दिस डिसीज. तो हमारा रामकृष्ण अस्पताल का एक स्लोगन है, जीतेगी जिंदगी हारेगा कैंसर. सो विल स्टिक बाय दैट स्लोगन एंड आई वेलकम ऑल ऑफ यू टू ऑन्कोस्फियर 2.0. थैंक यू.
Thank you, sir. Now give a big applause to the managing director of this hospital, Dr. Sandeep Dave, who is the cornerstone of Ram Krishna Care and first and only recipient of the prestigious Shushruth Award in the state for surgical brilliance and recognition of exceptional contribution to the field of surgery. With 37 years of humanitarian devotion in the healthcare sector of the state, he dreams, dares, and delivers to the society with purpose, principle, and philanthropy. Sir, please.
माननीय स्वास्थ्य मंत्री श्री श्याम बिहारी जायसवाल जी, मंच पर आसीन मेरे कलीग्स, डेलीगेट्स, शायद मैं उतना जोर से ना बोल पाऊं. आप सब देख रहे हैं कि एक वेल प्लान भी लगा हुआ है. मेरा शुरू से ध्येय रहा है और मैं ये मानता हूं कि सही इलाज ही सस्ता इलाज है. अगर सही इलाज किया जाए तो ही आप उसको सस्ता कर सकते हैं. हम इस ध्येय के साथ बहुत सालों से काम कर रहे हैं और हमारा प्रयास रामकृष्ण केयर अस्पताल में हमेशा से ये रहा कि हम ज्यादा से ज्यादा मरीजों तक पहुंच सके. कैंसर एक ऐसा रोग है जो कि बहुत तेजी से हिंदुस्तान में बढ़ रहा है. आने वाले समय में कैंसर का लोड कितना होगा ये हम भी नहीं जानते हैं. हमने आज सुबह से वक्ताओं को सुना और हर वक्ता का यही कहना है कि कैंसर के बढ़ते हुए लोड को देखते हुए और कैंसर के अस्पतालों की आवश्यकता पड़ेगी. साल डेढ़ साल पहले अपने घर में ही जब मैंने अपने बड़े भाई को कैंसर प्रोस्टेट के तहत खोया तो उसी दिन ये निर्णय बन गया था कि ये कैंसर का अस्पताल अपना खुद का भी बनाना पड़ेगा। और उस वक्त सिर्फ रवि जायसवाल मेरे यहाँ काम करते थे। आज एक बड़ी टीम हमने खड़ी कर ली है और उनके जन्मदिन 16 अगस्त को ये कैंसर का अस्पताल हम छत्तीसगढ़ को डेडिकेट करने जा रहे हैं। मेरा ये मानना है कि मैं अपनी टीम को भी यही बोलता हूँ कि आप जब भी कैंसर का इलाज करें तो ह्यूमैनिटेरियन ग्राउंड पे उनका इलाज करें। एक आपके मन में, आपके दिल में ये बात हमेशा रहनी चाहिए कि ये जो मरीज है, अगर इसकी जगह आपके परिवार का सदस्य होता तो आप किस प्रकार से उसका इलाज करते। आप इस भावना को ध्यान में रखें। आप जितना ज़्यादा पेशेंट उस पेशेंट के साथ हो सकते हैं, जितना ज़्यादा आप उसके साथ घुल मिल सकते हैं, क्योंकि कैंसर का इलाज सिर्फ दवाई, रेडिएशन या सर्जरी नहीं है। कैंसर का इलाज उसकी संवेदनाओं के साथ में काम करता है। उसकी भावनाओं को भी हमको समझना पड़ता है। उस फैमिली के टॉर्चर को भी समझना पड़ता है, जो इस टॉर्चर से वो गुजर रही होती है, क्योंकि कैंसर अभी भी एक बहुत बड़ा स्टिग्मा है, एक बहुत बड़ी बीमारी मानी जाती है। मरीज बोलता है कि कैंसर मतलब मर गया मरीज, जबकि आज की तारीख में ऐसा नहीं है। आज की तारीख में कैंसर मतलब मरीज का इलाज हो सकता है और मरीज पूरी तरह से क्योर भी हो सकता है। इस भावना के साथ में अगर हम इलाज करेंगे तो हम एक बेहतर समाज की कल्पना कर सकते हैं। हमने पूरा प्रयास किया है कि इन भावनाओं को हम समाहित कर सकें और इनके साथ में हम अपना नया कदम उठाने जा रहे हैं, जिसमें आप सबका आशीर्वाद हम सबको लगेगा, मेरी पूरी टीम को लगेगा। और जैसी रामकृष्ण केयर की अभी तक के सेवा भावना रही है, उसी सेवा भावना के साथ हम इस इलाज को कंटिन्यू करेंगे। धन्यवाद। मैं फिर से एक बार माननीय स्वास्थ्य मंत्री जी का स्वागत करता हूँ।
Thank you, sir. So you are hearing the man, the myth, the legend. उन्होंने मुझसे एक बात कही थी बहुत साल पहले, जब मैं पूछा कि पिताजी आप इतना ऊपर कैसे पहुंचे, तो उन्होंने सिंपल कहा था कि बेटा कलाकार नहीं बनते हाथों की लकीरों से, तू कला पे हाथ रख तो खुद ही बनता जाएगा. So that is the man himself. I would like to invite Mr. Harish Trivedi, sir, our regional CEO, Prayer Group, to facilitate the audience with his words.
Thank you, Shamik. Good evening, everyone. Honorable Health Minister, distinguished guests, honorable oncologists, dear friends, and healthcare leaders. It's my privilege and honor to stand here and giving me this opportunity to address you. When we look back, I'm the regional CEO. My name is Harish Trivedi. I'm the regional CEO for Care Hospitals. I take care of all the hospitals outside Hyderabad, and I also head the oncology vertical for Care Group. And as a leader in healthcare and in oncology, most of the time what we do is review a lot of blueprints, different operational metrics. We look at the growth strategy. But eventually, what I've realized is this doesn't matter. What matters in healthcare is the profound clinician and clinical outcome. Without that, it's nothing. So I respect all of you for what you are doing every single day. And if I have to talk about our plan in oncology, and you all know, I don't have to say how the disease is growing very fast. And when we decided to check and move the landscape of oncology and care hospital, we realized then working in silos is not going to help our patients. We need to work in synchronized manner, and there's a reason. And we need to work synchronized manner and create an entire ecosystem which will help our patients. And that's where we have realized. And our plan is to invest very heavily in oncology. And ma'am, you'll realize I was in Max Healthcare. And that's where we started initially under Harsh Chaturvedi, we started focusing on the oncology. And thereafter, I also spent 3 years heading the oncology vertical in Apollo. I was also heading the proton center. And here are we have realized this. And like always, Dr. Dave says, 36 saal in Chhattisgarh. And then we have realized, and he talked about this story. Most of the patients still go outside from Raipur. When you look at the investment which is happening in healthcare, you realize all the national player working in the metro cities, class A1 cities, and now they have started entering in the tier 2 and tier 3. But if you look at the story and journey of care hospital, we have already mastered being in tier 2 and tier 3. So that's our strength. That's where we have realized and started investing very heavily in oncology. So our first dedicated oncology center is coming up in Raipur, and Dr. Dave has just announced that we'll be inaugurating formally in August. We are right now, I'm sure most of you are aware that we are merging with the Esther DM, subject to all the approvals which we'll receive. Right now, we are 20 hospitals, 5,200 beds, and we also, Esther is again 19 hospitals and 5,250 beds. Subject to all the approvals on 1st of July, we will be the second largest healthcare player in India with 39 hospitals, 10,400 plus beds, and another 5,000 beds in pipeline in next 2 years. So hopefully, we'll be the single largest player very soon. But while talking about all this, what is very important is the disease burden right now on oncology and the patients are facing. So we want to enter in the entire tier 2 and tier 3 cities. So first center is coming up right now in Raipur. Simultaneously, we are working in Bhubaneswar. By this year end or early first quarter, we'll coming up with the another dedicated centers. Another 2 years down the line, we are coming up in Nagpur. We are setting up the dedicated hospital with oncology. We are setting up oncology in Aurangabad. We are setting oncology centers in Vizag. And this all I'm talking about, including the investment which we are making in Hyderabad. At the same time, Aster DMS is far ahead in its journey in oncology. So this platform will provide us the strength and our ability to treat the more patients. And what we are creating in Raipur here at this point of time is site-specific multidisciplinary team. And there's a reason we have hired already distinguished oncologists who are sitting with us. Without great oncologists, we cannot do anything. But what we can do is provide the fantastic technology which will help them to treat the patient. So that's where we are making very heavy investment. At the same time, you all realize in today's world, without the digital transformation, we can't work. So we are also working and will be taking help of the agentic, how we can automate the entire EHR process so where doctor don't have to spend their time in writing and doing the administrative work. We want to take out that burden from the doctor so they can spend more time in treating the patient. So that's the ecosystem we are creating and we are just looking forward. So this is a fantastic team we have. Formally or soft launch we'll make in the month of July and formal inauguration of the center which we'll making in the August. And looking forward to your cooperation. We'll work together. Thank you so very much for giving me this opportunity. And thank you, Health Minister Saab, for coming here. खूब खूब आपका आभार सर. Thank you. Thank you everyone.
Thank you, sir. Thank you so much. Now we have an EV film of 2 minutes or something. Can you just all of you look at the screen, please? Thank you.
No single percentage is enough. Some truths are too large to any of us. The toughest challenges lie more than it reflects to us. They demand many ones. Many histories look at theory because different persons carry many questions. And the responses are different. This is where these beliefs comes life. And always without distinction. Every case, every perspective considered. Every decision is translated by collectives. 36 years, Raipur hospitals has brought experts together for months. To give presentation confidence of the system, made not by one expert, but by an entire team. Comprehensive cancer care, backed by multidisciplinary expertise and clinician excellence, now closer to home.
Unveiling. Now I would request the Health Minister, sir, and all the dignitaries to unveil the Comprehensive Care Program Unit by Ramakrishna Care Hospital. Moving among the stars of healthcare sector in Chhattisgarh, our Honorable Health Minister, Shri Cham Bihari Jaiswal, who is the only one for whom I have retained a fabulous compliment. हुकूमत वही करते हैं जो दिलों पर राज करते हैं, यूं तो मुर्गों के सर पे भी ताज होते हैं. Sir, kindly put up your hand on the microphone to address us with your premium and inestimable oration, sir.
बोलिए भारत माता की, भारत माता की। से आप लोगों को नारा लगाने की हैबिट ज्यादा है नहीं, लेकिन दो चार तो साथ रहोगे तो हो जाएगा। आज हमारे रायपुर में देश भर से आए हुए जो कैंसर क्षेत्र में काम करने वाले और विभिन्न साइंटिस्ट, रिसर्चर्स, डॉक्टर्स और कैंसर के सेक्टर में काम करने वाले विविध क्षेत्रों से, विभिन्न राज्यों से जो हमारे विशेषज्ञ आए हैं, और ये दूसरा सेशन है ऑन्कोस्फेयर इनोवेशंस इन कैंसर केयर। ये हमारे रामकृष्ण केयर के जिनके माध्यम से पूरे राज्य में और आसपास के राज्यों में जिनका नाम चलता है, ऐसे डॉक्टर संदीप दवे जी ने कैंसर के क्षेत्र में भी काम करने का बीड़ा उठाया है। तो निश्चित रूप से आज मैं उनको अपनी ओर से बहुत शुभकामनाएं देता हूं। हमारे बीच में कैंसर के क्षेत्र में बहुत ही अच्छा जिनका नाम है एक युवा डॉक्टर रवि जायसवाल जी, इनका भी हम काफी हृदय से अभिनंदन करते हैं। और हमारे बीच में डॉक्टर माऊ राय जी जो सर्जिकल ऑन्कोलॉजिस्ट हैं, आपका भी अभिनंदन है। डॉक्टर गौरव गुप्ता जी रेडिएशन ऑन्कोलॉजिस्ट, डॉक्टर नीरू जी न्यूक्लियर मेडिसिन, डॉक्टर नवीन जैन जी ऑन्कोलॉजिस्ट, और हमारे बीच में श्री हरेश त्रिपाठी जी रीजनल सीईओ केयर ग्रुप यहाँ मंच पर उपस्थित हैं। और जो मंच पर उपस्थित नहीं हो पाए हैं वो भी बहुत वीआईपी है, मैं देख रहा हूँ, वो भी कोई कम नहीं है। तो एक बार सभी के लिए ताली बजा दीजिए। क्योंकि मैं देख पा रहा हूँ उसमें आधे लोगों का मैं बाई नेम बता सकता हूँ, ले भी सकता हूँ, लेकिन मुझे लगता है कि आप लोग काफी टाइम से एक दूसरे को सुन रहे हैं, तो कुछ इंटरेस्टिंग भी होगा, कुछ बोरिंग भी होगा। और उधर खुशबू भी आ रहा है, भोजन कैसा लग रहा है। तो हम ज्यादा समय नहीं लेंगे आप लोगों का, बस आप लोगों को शुभकामना देना था। और एज ए हेल्थ मिनिस्टर मैं आप लोगों की बहुत प्रशंसा करता हूं कि आप लोगों ने कैंसर के क्षेत्र में हमारे छत्तीसगढ़ में जो यहाँ के जो डेमोग्राफी है, बस्तर, सरगुजा और हमारा मैदानी क्षेत्र बिलासपुर, जांजगीर चांपा, रायपुर, दुर्ग, धमतरी, कांकेर, हम देखेंगे कि ये छोटा राज्य जरूर है, लेकिन इतना भी छोटा नहीं है। केरल से ज्यादा बड़ा हमारा केवल बस्तर संभाग है। और यहाँ की जो भौगोलिक परिस्थितियां हैं, यहाँ की जो आ, हम भौगोलिक ही नहीं, यहाँ की हम मौसम की बातचीत करें, यहाँ की जो क्लाइमेट की बातचीत करें, तो छत्तीसगढ़ में 3-4 प्रकार के विविधताएं अलग अलग क्षेत्रों में मिलता है। बस्तर की भौगोलिक स्थिति और जो वहाँ की बाकी चीजें हैं वो अलग हैं, तो सरगुजा का अलग है, तो मध्य क्षेत्र का अलग है। और ऐसे में मैं जो देख पा रहा हूँ, मुझे लगता है आप लोगों के पास ज्यादा आंकड़े होंगे, लेकिन हम रायपुर से ऐसे बढ़ते हैं दोनों तरफ, नॉर्थ और साउथ में। साउथ में बस्तर है, नॉर्थ में सरगुजा है। ये 2-3 बीमारियां बढ़ते जाती हैं। जो कैंसर है, जिसमें हमारा माउथ कैंसर है या गर्भाशय का है, तो ऐसे कैंसर बढ़ते जाते हैं दोनों तरफ। ऐसे ही सिकल सेल की जो है वो भी बढ़ते जाता है, जो मैं अभी तक अनुभव किया हूँ। ऐसे ही एमएमआर, आईएमआर सब वैसे ही बढ़ता जाता है, यहाँ से ऐसे बढ़ता है, तो और ज्यादा है चारों दिशा में से, मतलब उसकी नंबर्स बढ़ता है। और फैसिलिटीज की हम बात करें तो हर चीज यहाँ से ऐसी डिक्रीज होता है, समस्या इंक्रीज होती है, और दोनों में एक बड़ा संतुलन होता है। और अभी कुछ दिनों से हो सकता है पहले जांच कम होता रहा हो, बात अलग है, तो पता नहीं चलता रहा होगा। जैसे हम दवाइयों को भी बेतहाशा जांच करा रहे हैं 2 सालों से, तो हमको हमारे ऊपर ब्लेम लगता है कि पूरी ये मानक दवाइयां खरीद रहे हैं। अरे भाई, पहले जांच ही नहीं होता तो क्या पता चलेगा उसमें मानक है क्या मानक है। ऐसी पनीर उनीर में भी हम खूब कार्रवाई करा रहे हैं। जो सीएफडी डिपार्टमेंट भी मेरे पास है, तो उसको पूरी ताकत के साथ, तो कम से कम 50 लाख पनीर का पकड़ाया होगा। तो बोले पनीर बहुत यहाँ 2 नंबर का बिकता है। अरे भाई, पहले तो और बिकता था, अब तो इतनी कार्रवाई कर रहे हैं तो कम हो रहा है, खत्म हो रहा है। तो उसी प्रकार से मुझे लगता है कि जांच नहीं होता होगा, इसलिए ज्यादा जांच हो रहा है, तो लगता है कि कैंसर बढ़ रहा है। तो सारी बीमारी बढ़ रहे हैं, और बीमारियों का भी नेचर और इलाज का भी नेचर और पेशेंट का भी नेचर, सब कुछ चेंज हो रहा है। पहले देखिए, बीमारी ठीक करने के लिए डॉक्टरों के पास लोग आते थे, हॉस्पिटल में आते थे। अब डॉक्टरों के पास एडवांस में आते हैं कि हम बीमार ना हो, फिटनेस के लिए आते हैं। पहले दांत में काढ़ा हो जाए तो डेंटिस्ट के पास जाते थे। आजकल वो क्या मैक्सोफेशियल और वो सब चेहरे का भी वो सब हो जाते हैं। पहले स्किन वाले के पास जाते थे, तो दांत खाज खुजली हो जाए तो जाते थे। आजकल वो चेहरे को ठीक कराने जाते हैं, झुर्री कैसे खत्म होगा। क्या डॉक्टर साहब, सही बात है? तो ऐसे मतलब उसकी नेचर बता रहा हूं। और जो बीमारी है वो भी पहले सीधे सीधे होते थे, आजकल बीमारी भी आड़े तिरछे हो गए हैं, पता ही नहीं चलता एक आध बार के जांच में। पहले सामान्य रूप से गांव के किसी लैब में पता चल जाता था कि वो टाइफाइड है कि मलेरिया है कि क्या है। आजकल बड़ा बड़ा लैब पकड़ने में दिक्कत कर रहा है, क्योंकि बैक्टीरिया, वायरस सब अपना रूप बदल रहे हैं। तो बीमारी का स्वरूप बदल रहा है तो डॉक्टर का भी स्वरूप बदल रहा है। पहले डॉक्टर लोग अपने समान रूप से सर्जरी करते थे, आजकल उसका सहारा ले रहे हैं। किसका? रोबोट का, रोबोटिक सर्जरी कर रहे हैं। पहले डॉक्टर केवल अपने आईक्यू के इस्तेमाल करता था, आजकल अपने से 100 गुना ज्यादा आईक्यू वाला रोबोट उसका ये अपना एआई का भी इस्तेमाल करता है। एआई से भी इलाज कर मतलब वो उससे एडवाइस ले रहे हैं। जो चीज आप नहीं पकड़ पाएंगे एआई की मदद से पकड़ा जाएगा। तो सारा चीज अपनी दृष्टि से बदल रहा है। तो उसी प्रकार पेशेंट भी, पहले पेशेंट को गद्दे से ओह गद्दे से जमीन में लेटा देते थे तो उसको लगता था मैं हॉस्पिटल पहुंच गया, अब ठीक हो जाऊंगा। उसको ये ध्यान नहीं होता था कि मैं नीचे सो रहा हूँ, कि बिस्तर नहीं है, कि एसी नहीं है, कि कूलर नहीं है। मरीज भी आता है तो उसको एसी वाला सेपरेट चाहिए, आयुष्मान वाला भी आता है तो बोलता है कि थोड़ा सा डॉक्टर साहब को बोलिए आयुष्मान में हमको सेपरेट दे दे, वो भी रामकृष्ण केयर में। तो ये इतनी चेंजेस आया है। मैं एकदम जहां भी बात करता हूँ तो भी फ्रैंक बात करता हूँ, कहीं कोई लाग लपेट वाला नहीं, कोई डिप्लोमेटिक नहीं करता। ये सारा ओपन बात है, आप माने या मत माने। मैं जो अनुभव किया हूं इन 2.5 सालों में, और आने वाला समय और इससे और खतरनाक आ रहा है। जैसे हम 5 मेडिकल कॉलेज खोले मतलब उसके भवन का टेंडर किए, तो लोग बोले डॉक्टर जितने उतने में प्रोफेसर नहीं मिल रहे हैं, कहां से चलाओगे? हम बोले यार देखो, गांव में बोलते हैं अगर दूध है तो दूहना मिल जाता है, दूहने वाला। तो मटका से पहले दूहते थे, वो नहीं है तो स्टील वाला मिल जाएगा, नहीं होगा तो एल्युमिनियम वाला मिलेगा। कोई चीज तो मिलेगी, अगर दूध है तो उसको रखने की मिलेगी ही। तो हम बोले हॉस्पिटल खोलेंगे डॉक्टर मिलेंगे ही, ऐसा नहीं है। और 10 से 15 कर दिए, और ऐसा ही नहीं कि हमने भर्ती भी उसमें कर रहे हैं। उसमें हमने एनएमसी से वो भी मांगा था अनुमति, तो कुछ रिजेक्ट हो गया, तो मीडियम चल रहा है, खत्म हो गया। लेकिन आप लोग तो जानते हैं डॉक्टर लोग कि एक बार में एनएमसी भी नहीं देती, कुछ ना कुछ क्वारी निकालती है, तो क्वारी निकाल के वापस की है, तो लोगों को लग रहा है पूरा खत्म हो गया। सोशल मीडिया में पढ़ रहा था, एक जन बोले स्वास्थ्य मंत्री को इस्तीफा दे देना चाहिए। वाह, मैं बोला मैं बोला मेरे इस्तीफा देने से अगर काम बन जाएगा तो वो भी कर देते, पर वो भी नहीं होना है, क्योंकि इस्तीफा दे दी तो और 2 साल लेट होगा। तो उसमें फिर से हम 15 दिन की अपील में जा रहे हैं। तो मैं कोई ये उपलब्धि है वो नहीं बता रहा हूँ, एक तो जोड़ के बता रहा हूँ। तो भविष्य में इतने डॉक्टर हो जाएंगे, एक जने बोले इतने डॉक्टर हो जाएंगे तो क्या काम दोगे भाई इतने लोगों को? बोले अरे भैया, मैं बोला सब सिस्टम बदल रहा है। पहले एक ब्लॉक में एक स्कूल होता था और एक मास्टर होता था, वो पूरे आसपास को पढ़ा लेता था। बाद में स्कूलें बढ़ना चालू हुआ। जैसे मैं जब पढ़ता था तो मेरे ब्लॉक में एक हायर सेकेंडरी स्कूल तक था, और जब मेरे बेटे लोग हाई स्कूल में पहुंचने लायक हुए तो 43 हो गए। इतना फर्क आया 30 साल में, 28-30 साल में। और अब जो है अभी और आवेदन आते हैं कि हमारे गांव में हाई स्कूल दे दो, हायर सेकेंडरी दे दो। तो इसका कोई हिसाब किताब नहीं है। पहले एक मेडिकल कॉलेज था, बड़े मुश्किल से वो भी नहीं भरता रहोगे। जब डॉक्टर दवे आप तो यहीं पढ़े होंगे, रायपुर में पढ़े हैं, तो उस समय बड़े मुश्किल से छत्तीसगढ़ के आधे लोग पढ़ते रहे होंगे। शुरुआत में 50 सीट रहा होगा, 100 सीट रहा होगा, हाँ। और आजकल 100 सीट वाली तो बहुत हो गए, 10 है, 5 और बढ़ जाएंगे तो 15 तो हमारी हो जा रही है, 5 और प्राइवेट हो गए। तो ऐसे करके जितना डॉक्टर बढ़ेंगे उतने पेशेंट बढ़ रहे हैं। जब वो बात अलग है कि भविष्य में लोग अपना बीमारी की इलाज कराने कम आएंगे। एडवांस में जो है बीमार होने से पहले, जैसा होता है ना कि लोग बोलते हैं अगले जन्म के लिए फटाफट पुण्य इकट्ठा करो, अच्छे काम करो, गरीबों को खिलाओ, कथा सुनो, मंदिर में जाओ, लोगों की मदद करो। ये डिपॉजिट होता है पुण्य एडवांस में। तो लोग एडवांस में डॉक्टर के पास जाएंगे। और एडवांस टेक्नोलॉजी काफी लंबे समय से कुछ चीजों की चल रही है। जैसे हम जो टीका लगाते हैं तो बीमारी से बचने के एडवांस है टीका, उसी प्रकार सारे चीजों का भविष्य में एडवांस में भी चलेगा, कंटिन्यू में भी चलेगा और वेलनेस के लिए भी लोग जाएंगे। आजकल ऐसे ऐसे इंजेक्शन आ रहे हैं, मुझे तो नहीं मालूम, लेकिन वो मोटापा को बोलते हैं 4 इंजेक्शन लगाओ बराबर कर देता है फेट। हो सकता है फेट टूट रिमूव वाला आता होगा। कई लोग वजन डाउन कर लेते हैं दवाइयां खा के। तो कई प्रकार के इसका जो सिस्टम बदल रहा है, लेकिन आज आप लोग जो काम कर रहे हैं वो बहुत ही महत्वपूर्ण काम है और समाज के लिए एक ऐसा काम आप लोग कर रहे हैं विशेष रूप से छत्तीसगढ़ के लिए कि यहाँ के लोगों की अनजाने में कई ऐसे लोगों की मौत हो जाता होगा जिनकी गिनती नहीं है, हमको पता नहीं चलता कि उनको कैंसर हो गया है। और मुझे लगता है इस प्रकार के आप लोगों के जो सेमिनार्स हैं या सम्मेलन हैं, इससे छत्तीसगढ़ को लाभ मिलेगा और डॉक्टर साहब ने कहा है कि जल्दी हम एक और कैंसर का अपना हॉस्पिटल बढ़ा रहे हैं। तो निश्चित रूप से मैं आपको आश्वस्त करता हूँ हमारी ओर से, सरकार की ओर से जो भी आपको मदद चाहिए होगा, हर संभव प्रयास हम मदद देंगे। और आप सब लोग भी अगर हॉस्पिटल खोलना होगा, छत्तीसगढ़ में मैं देख रहा था लिस्ट में हैदराबाद से भी आए हैं, मुंबई से भी आए हैं, दिल्ली से भी आए हैं, ऑल ओवर इंडिया से आप सब लोग आए हैं। तो मैं आपसे निवेदन करूंगा कि छत्तीसगढ़ में आपको बड़ा हॉस्पिटल खोलना हो तो हम नया रायपुर में आप लोगों को जमीन भी दे देंगे और हम हॉस्पिटल को इंडस्ट्रियल पॉलिसी में जोड़ लिए हैं। और छत्तीसगढ़ का इंडस्ट्रियल पॉलिसी 40% से लेकर 55% तक की सब्सिडी इसमें है, इलेक्ट्रिसिटी ड्यूटी में है, इंटरेस्ट सब्सिडी है, कैपिटल सब्सिडी मैंने बता ही दिया कि 40 to 55% हम दे रहे हैं, जीएसटी में छूट दे रहे हैं। तो आप लोग आइए, इन्वेस्ट करिए और आप हॉस्पिटल खोल लेंगे तो प्रेम से आप लोगों को हम आयुष्मान से रजिस्ट्रेशन करेंगे, मरीज हमारा, इलाज आपका और पैसा भी हमारा। हम साल में लगभग 2000 करोड़ देते हैं हर साल और बड़े ईमानदारी के साथ हमारे डॉक्टर्स और हॉस्पिटल वाले भी काम करते हैं और सरकार भी वैसे ही करती है। और शुरुआत में जरूर कुछ समस्या हॉस्पिटल वालों को सरकार से था, सरकार को हॉस्पिटल वालों से था, मरीज को हॉस्पिटल से था, हॉस्पिटल को मरीज से था। धीरे धीरे लेकिन हम लोगों ने कितना परसेंट डॉक्टर साहब 75% बोल देते हैं, 75% तो ठीक ही कर लिए हैं। मैं अभी भी 100% ठीक हुआ है ऐसा नहीं कह सकता, कहीं कहीं शिकायत आता है कि पैकेज से अलग से पैसे मांग रहे हैं, कई बार बोलते हैं आयुष्मान नहीं चला रहे हैं, कई बार डॉक्टरों का आता है कि हमारा पेमेंट नहीं हो रहा है, लेट हो रहा है। तो ये तो सतत रूप से चलता है थोड़ा थोड़ा, लेकिन ओवरऑल ऐसा कोई ओवरड्यू ना तो इनका पेमेंट है ना कोई परेशान करता है। और आप लोगों को बताते हुए खुशी है कि आयुष्मान के संचालन में सभी पैरामीटर्स के हिसाब से छत्तीसगढ़ को देश में पहला स्थान मिला, इस बार पहला पुरस्कार भी मिला। और हम ऐसा नहीं है कि हम केवल हवा में तीर भांज रहे हैं, गवर्नमेंट सेक्टर में हमने 2.5 साल में बहुत हद तक हेल्थ की तस्वीर बदला है। आप एम्बुलेंसेस देखेंगे, हमने 375 नए एम्बुलेंसेस पूरे छत्तीसगढ़ में चलाए हैं, पूरे न्यू ब्रांड। और उनमें ऐसा रूल किए हैं कि वो 1 मिनट लेट नहीं कर सकता। अभी उसका शुरुआत है इसलिए हो सकता है। जो पीवीटीजीज हैं, बैगा हैं, पंडो हैं, कोरवा हैं, जो पहाड़ियों के पीछे कंदराओं के पास रहते हैं, जो हॉस्पिटल नहीं आना चाहते, छत्तीसगढ़ में ऐसे ट्राइब्स हैं जो मोर देन 2000 ईयर के भी पुराने हैं। तो उनके घरों तक पहुंचाने के लिए हम पूरी चलित हॉस्पिटल 57 यूनिट जो है मेडिकल मोबाइल यूनिट हम चला रहे हैं। मैं इसलिए बता रहा हूं कि देश भर के लोग आए हैं तो सरकार का भी थोड़ा सा इन तक जाना चाहिए। इसी प्रकार से जो आईएमआर और एमएमआर में आप सभी जानते हैं कि हम देश में बड़े प्रेम से नीचे से दूसरे स्थान में थे, अच्छे में, और खराब में ऊपर से दूसरे। इन 2 सालों में हमने काफी प्रयास किया है। जो एमएमआर 144 था वो अब 124 146 था, वो 124 हो गया, मतलब 22 पायदान हम 22 अंक नीचे सुधार किए हैं। और उड़ीसा के साथ हम ज्वाइंट रूप से थर्ड में है, मतलब उसको फोर्थ भी बोल सकते हैं। तो हमने 2 स्थान छलांग लगाया है। ऐसी डिलीवरी के लिए हम लोगों ने जो अध्ययन किया, मैं बोला अध्ययन करो, क्यों खत्म हो रहे हैं लोग, ऐसा क्यों बुरा हाल है हमारा। तो बात तो पहला सही है कि गायनकोलॉजिस्ट हैं, जो चाइल्ड स्पेशलिस्ट हैं, सर्जन है, एनेस्थेसिया वाले हैं, तो ऐसे दुर्गम क्षेत्रों में हमारे जरूर कम है। लेकिन सबसे ज्यादा मौतें जो है ट्रांसपोर्टेशन के दौरान हुई। 70% मौत जो है केवल एक हॉस्पिटल से दूसरे हॉस्पिटल में शिफ्ट करने में हुई। तो हम एक नया प्रयोग कर रहे हैं, हमने 116 जगह चिन्हित किया है। फर्स्ट फेज में हमारे पूरे डिस्ट्रिक्ट हॉस्पिटल और 2-3 और ऐसे लगभग 40 हॉस्पिटल को हमने फर्स्ट फेज में लिया है। ये पूरी सुविधा रहेगा और पूरे के पूरे जो डिलीवरी वाले हमारी माताएं बहनें हैं, उनको पहले प्राथमिकता हम वहां कोशिश करेंगे कि सीधे वहीं भेजो। जहां 10 मिनट लगता है पहुंचने में नीचे में, वहां 20 मिनट लग जाएगा। इसके बाद सेकेंड फेज में 6 महीने के अंदर 116 जगह सीएचसी तक हम करेंगे और पीएचसी और सब हेल्थ सेंटर में डिलीवरी बंद करने वाले हैं कि वहां जाए ही मत, सीधे उनको गाड़ी हमारा है ही है महतारी एक्सप्रेस 102, तो जो नीचे के हॉस्पिटल में जा रहे हैं तो और सही 10 मिनट तय करके करेंगे, क्योंकि मैडम ज्यादा समझेंगी, एचओडी है हमारे स्त्री रोग विशेषज्ञ का, जसवाल मैडम। तो हम ऐसा करने वाले हैं, आप लोग भी बताइएगा, ऐसा ना हो कि हम केवल हेड देखे हों सिक्का का, टेल नहीं देख पा रहे हों। तो अगर ऐसा डिसीजन हमारा गलत लगे तो टेल दिखा दीजिएगा, तो हम कोशिश करेंगे ठीक कर लें। तो ऐसे हम सुधार कर रहे हैं हेल्थ सेक्टर में। फिर हमारे प्राइवेट सेक्टर के भी हमारे डॉक्टर्स लोग बराबर हमारा कंधे से कंधा मिलाकर चल रहे हैं। सरकार प्राइवेट हॉस्पिटल को जितना महत्व दे रही है उतना सरकारी को देती है, सरकारी को जितना दे रही है उतना प्राइवेट को हम दे रहे हैं। हम नर्सिंग सेक्टर में भी जो हमारे 8 नर्सिंग कॉलेज थे उससे बढ़ाकर सीधे 22 कर दिए हैं। एक फिजियोथेरेपी कॉलेज से सीधे 8 कर दिए हैं इन 2 सालों में। योग और नेचुरोपैथी के लिए 100 बेड का, डॉक्टर साहब जो एनआईटी के सामने है, देखे आप लोग, वो गड्ढा खोद रहे हैं खूब, वो 100 करोड़ का है। 100 बेड का योग और नेचुरोपैथी का हॉस्पिटल जैसे जिंदल वगैरह में होता है, लगभग उसी तर्ज पर ये भी होगा। और रिसर्च सेंटर भी होगा और वोकेशनल कोर्स भी हम देंगे। तो ये कर रहे हैं। उसके अलावा 4 और हॉस्पिटल हम खोल रहे हैं। तो होम्योपैथिक का भी हम पहला जो मेडिकल कॉलेज है वो छत्तीसगढ़ में खुलेगा इस साल से। तो हेल्थ सेक्टर में मैं प्रयास किया हूँ और माननीय मुख्यमंत्री जी इसके लिए हमें रोकते नहीं है, उनका धन्यवाद है। पूरी तरह से हमको छूट मिली हुई है, वो करते हैं। एक और हमने नया चीज किया कि भाई जब तक जांच नहीं होगा तो डॉक्टर क्या दवाई करेगा, डॉक्टर तो जांच करते नहीं है। तो जांच सिस्टम को पूरे हमने एचएलएल को दे दिया। आप लोग ज्यादा जानते होंगे एचएलएल के बारे में, सभी लोग। एचएलएल जो हमारे एम्स में भी चला रही है और वर्ल्ड के अच्छे मशीनरीज हमारे सभी डिस्ट्रिक्ट हॉस्पिटल में लगभग हमारी तैयार हो गए हैं और कई जगह चालू हो गए हैं। और फ्री के लोगों की जांच होगा, वो बात अलग है। कई अखबारों मित्रों ने लिखा कि ज्यादा पैसे दे रहे हैं, तो हम बोले उससे क्या करना है, हम लोगों को इनोवा में घुमा रहे हैं, तुम मार्शल में सोच रहे हो घुमाएं, क्यों घुमाएं, जैसा हमारा लग रहा है। जनता को अच्छी सुविधा मिलना चाहिए, लोगों का अच्छी डायग्नोस्टिक सिस्टम होना चाहिए, और उसके लिए हम काम कर रहे हैं। और लगातार छत्तीसगढ़ सरकार काम कर रही है। कैंसर के भी क्षेत्र में हम लोग एक अभियान चलाएंगे और उसमें आप सब लोगों का सहयोग होगा। रायपुर का हमारा जो मध्य भारत का सबसे बड़ा इंस्टीट्यूट जो कैंसर इंस्टीट्यूट है, उसको और डेवलप कर रहे हैं। उसकी पेट स्किन मशीन को हम जल्दी चालू करने वाले हैं डॉक्टर साहब। और हमारे मध्य भारत का हार्ट का भी हम उसको एक बड़ा सेंटर बनाना चाह रहे हैं, उसके लिए प्रयासरत भी हैं। पहली बार मुझे लगता है कि इस छत्तीसगढ़ और आसपास के राज्यों में डीएम कार्डियक की 2 सीटें हमको इस बार मिल गई हैं। और मेरा प्रयास, मैं तो गांव का एक किसान आदमी हूं और मैं ज्यादा जानता नहीं हूं मेडिकल, लेकिन जितना मेरे से बन पड़ा है इन 2.5 सालों में मैंने पूरा ईमानदारी से प्रयास किया है कि छत्तीसगढ़ को हर दिशा में स्वास्थ्य की बुलंदियों तक पहुंचाया जाए, और मैं उसी दिशा में लगा हूं। आप लोगों के भी सहयोग मिलते रहते हैं ना। सभी देश भर से आए हुए सभी डॉक्टर, सभी वैज्ञानिक, सभी रिसर्चर्स और सभी सहयोगियों को, आयोजक मंडल के हमारे मुख्य रूप से डॉक्टर दवी जी और मंच पर उपस्थित सभी लोगों का मैं धन्यवाद करता हूँ। बहुत बहुत धन्यवाद। जय हिंद, जय भारत, जय छत्तीसगढ़।
Thank you, sir. Now we'll move ahead with the felicitation ceremony. We'll be felicitating few of the champions of this oncological department. I would request Shyam Bihari Jaiswal sir to felicitate Dr. Purvesh M. Parakh, medical oncologist and hematologist, Mumbai. Dr. Mehboob Basari, past president, director of medical oncology, Jaslok Hospital, Mumbai. Dr. K. Santa, consultant medical oncologist, Indo-American Cancer Hospital and Research Institute, Hyderabad. Dr. Sudha Sinha, clinical director and HOD, senior consulting medical oncology and hematology, Yashoda Hospital, Hyderabad. Ma'am. Moving on, Dr. Bharat Bhosle, founder director, Baby Precision Oncocare Center, Mumbai, senior consultant, Bombay Hospital. Dr. Ghanshyam Biswas, consultant medical oncology, executive director, Sparsh Hospital, Bhubaneswar. Charu Garg, Max Hospital, New Delhi. Dr. Amit Jotwani, group head for clinical oncology, Care Group. And last but not the least, Dr. Sarthak Tandon, senior consultant, radiation oncologist. Vote of thanks. 5 minutes. Lastly, I would like to express my gratitude to all who have made this event a memorable grand success by their auspicious presence. Thank you, Ramkrishna Care team. Lastly, I would like to invite Dr. Madhura ma'am, the first senior cancer oncologist in this state. The lady in scrubs, welcome ma'am for the vote of thanks.
I feel a deep sense of privilege and gratitude to extend my official vote of thanks to all who have contributed to this conference. The first and foremost to the Minister of Health and Family Member, Family Planning, Shyam Bihari Jaiswal ji, for gracing the occasion. Dr. Sandeep Dave sir, Medical Director, Ramakrishna Care Hospital, Raipur, our visionary and leader. Our regional CEO, Harish Trivedi sir, and our Raipur CEO, Hardik sir. This conference would not have been success without our esteemed faculty members who have taken the pain to come to this conference and share their knowledge on the practice changing guidelines, management of complex case scenarios, and wonderful talks on precision oncology and immunotherapies and targeted therapies. Special vote of thanks to the organizing team of this conference, our industry sponsors, the audiovisual team, and the staff of Babylon Capital who have supported us flawlessly in flawlessly executing this conference. Thank you all for actively participating in the conference and being a vital part of our journey. I request everyone, the session will continue for just 2 talks and then we will open up for gala dinner. Thank you all.
Yes, I request all the delegates, please be seated here for a few minutes more. We have our few sessions which will be continued. I hand over mic to Dr. Gaurav Gupta. Please.
Hello, everyone. So our SBRT session will continue after this inaugural session. I request our chairpersons to take their respective seats. Dr. Pradeep, Dr. Jay, Dr. Asutosh sir. So after a well-structured talk of Dr. Charu Garg ma'am, I invite Dr. Amit Jotwani for the toughest battleground in oncology, CA pancreas. It has humbled every modality thrown at it. Dr. Pradeep, podium is yours.
May I request Dr. Ashutosh Gupta sir, Dr. HP Sinha sir to chair the session. Ashutosh Gupta sir. प्रदीप चंद्राकर सर, जाओ जाओ. जय राय सर, 5 मिनट. आशुतोष गुप्ता सर, प्लीज. जय राय सर, ओवर टू यू. जोटवानी सर.
Very good evening, everyone. I know I'm standing in between the dinner and I'm in conflict with your brain and the hunger part, but we'll quickly start. So, pancreatic adenocarcinoma is one of the most difficult cancers to treat. We have been getting difficult breakthroughs, and as we all know, most patients will present with locally advanced disease. Most of them would be 80% of them would be inoperable, and most of them are locally advanced or borderline resectable. Dismal survival outcomes in India, it would be in single digit maybe. Main factor is the complex, crowded anatomy that we deal with in pancreatic adenocarcinoma. So, primary goal of treatment, as we all know, surgery is the cornerstone of any potentially curative intent of treatment for pancreatic adenocarcinoma. But when we treat, as we are managing locally advanced and borderline resective pancreatic cancers,
two factors need to be balanced: the systemic control and local control. And radiation oncology, we have been trying to incorporate into the treatment armamentarium since 40 years, but somehow the outcomes have not been very great. And that's where the overall studies have evolved over time. But before that, I'll just refurb on the part. Localized pancreatic cancers is three types based on its relationship with the major vessels like superior mesenteric artery, resectable, borderline resectable, and unresectable, as we all know. Under 180-degree correlation with superior mesenteric artery is borderline, and beyond that is unresectable. Conventional chemoradiotherapy has been tried a lot of times, but every time in RCTs it has failed to improve or provide any overall survival outcome breakthroughs. But accelerated pre-op RT over time, we have been seeing, as we will discuss further, will minimize time of chemotherapy. Factors we have to remember: the systemic control and local control. We cannot focus too much on local control while compromising on systemic control. So in chemotherapy or a delayed long course RT, that we are providing a environment for oncology cancer cells to have a distant metastasis. So that's where SBRT comes in, where you are avoiding any of the problems that are associated with conventional radiotherapy of 6 weeks of treatment, where you off chemo period is too high, the toxicity is too high because you're treating a larger volume of disease, and that leads to poorer outcomes. So evolution of ablative radiotherapy for pancreatic adenocarcinoma started. First published literature was phase 1 study by Stanford group in 2004, where they called it stereotactic radiosurgery on lines of neuroradiosurgery. That's why we tried with 15 gray, 20 gray, and 25 gray single dose treatments. They proved that it was possible, but toxicity in the long run was very high. Phase 2, we tried conventional followed by single fraction radiosurgery. There also poor toxicity profile and similar overall survival, so we did not get any advantage. So by the time around 2015, SBRT or radiotherapy game was over, as everyone thought. But the game flipped after 2015 most of the times, when first study by Zhu et al., where they did a prospective analysis of different regimes of SBRT and chemotherapy combined, and they found that BED 10 dose of more than 60 gray was associated with improved progression-free survival and overall survival. That's when we got the first prospective RCT-based breakthrough. And then numerous trials have shown a lot of good results. The latest being the Herman et al. Study in 2015, where we got very good outcomes with single-digit acute toxicity, and late toxicity was limited to 11%. What factors in this regime is what chemotherapy drug was used along with that. So over time, earlier it was only 5FU, external RT, then they added different gemcitabine. After that, now it has evolved to gemcitabine, nab-paclitaxel, or FOLFIRINOX. So escalated dose RT fills the gap of fractionated RT. So Shi et al. Published the first data where they found that the use of SBRT has jumped by 22% in 2019. That happened because of the improved outcomes that were published in 2015 onwards. And a meta-analysis by Yang et al. Involving 12 head-to-head comparative studies definitively showed SBRT significantly improved both 1 year and 2 year overall survivals compared to conventional radiotherapy. For locally advanced pancreatic cancer, it was clearly proved that conventionally fractionated artery was not as effective, and we did not get any meaningful advantages in survival outcomes. But ablative radiation therapy, where BED10 was in the range of 100 gray, has recently demonstrated excellent local control and overall survival for locally advanced pancreatic duct adenocarcinoma. Again, in borderline resectable, meta-analysis of 7 RCTs confirmed superiority of neoadjuvant therapy combined with chemotherapy and SBRT combined, where 3 months of FOLFIRINOX or nab-paclitaxel was combined with SBRT, followed by again FOLFIRINOX or nab-paclitaxel, where they found superior survival outcomes. And in another study from Memorial Sloan Kettering, they mentioned that 1 year overall survival was in the range of 78% and 2 year overall survival was in the range of 38%. Local progression-free survival. Local progression again becomes very important, especially when we are talking about SBRT or local radiation. Local progression-free survival was also phenomenally great at 32% compared to previous cohorts. Then again for borderline resectable, this data came from Tata Memorial Indian data, where 89 patients were evaluated in a retrospective manner. 50 borderline resectable and 39 locally advanced cases were compared where FOLFIRINOX was used or gemcitabine plus nab-paclitaxel was used in combination with SBRT. Surgical resection rate was found to be 37% in borderline resectable pancreatic cancers, which is in comparison similar with the international trials, and no grade 3 GI toxicity. The median overall survival of patients who underwent surgery was 28 and above, and none of the patient has any local or regional recurrence. Again, another data from 2024 proved that among all the combinations that were tried, chemo plus escalated dose RT, ablative RT has found to be best survival outcomes. So SBRT utilization rate has also shot up, especially in US. Now, with MR guided SBRT, we are achieving a 2 year overall survival in the range of 40%, from 34% to 40%, especially in SMART trial, where stereotactic magnetic resonance based ablative radiotherapy was tried. So, toxicity is low, local control is very good. So, has found to be very effective in achieving better local control of 79% and 2 year overall survival rate in the range of 43%. This is again from Memorial Sloan. And operative RT appears to make non-operative management a realistic option for patients with pancreatic cancer. Thank you.
It was a very well-structured talk, Dr. Amit. Now I invite Dr. Sarthak for his talk on liver SBRT and to navigate the challenges between child poke, mean liver, motion management, how he will do it.
Thank you, sir. At the outset, before I begin, I understand that this is the talk that is standing between you and your dinner. So I'll try and make it as brief as possible. And I thank Gaurav sir and Dr. Ravi as well for inviting me here and giving our perspective of liver SBRT. We have a very robust SBRT program running in RGCI Delhi. And the interesting part is it's not about, the single modality. It's about how you use it in terms of how do you combine it with DACE, how do you combine it with DARE, how do you combine it with systemic therapy, and that's going to be primarily my focus. So, as you understand that why we need to understand why hepatic SBRT matters now, and that's because it is a non-invasive ablation. We do that effectively. We have certain broad indication spectrum which we can use it in terms of primary hepatic SBRTs for HCCs, for liver metastases, for oligoprogressions. What is new that is coming up is selected PVTTs. In fact, we have treated PVTTs, macrovascular diseases running up till IVC filters as well. So that's an important landmark that we have achieved in terms of SBRT and motion management, that we can treat these patients which would have gone for palliation. And the three pillars that remain for precision is that the most important aspect being tumor control, managing with whatever liver reserve that we have, and with certain motion certainty. So for HCC, what are the things that we need to consider, and probably what is the patient selection that we need to do? And these are primarily those patients which are unresectable and ablations unsuitable. So this is something that we have read through our training, that these are the patients that you go for SBRT. But now that has been expanding a lot. We do patients which have failed on TACE, failed on RFAs. We've started doing it for bridging therapies. Importantly, like I was telling you, we've started doing it for macrovascular disease invasion as well, for PVTT, especially with the newer data set that is coming up with immunotherapy. And I understand the majority audience is medical oncology here. And so this is something that is coming up, that you continue the therapy, systemic therapy, with the employment of SBRT, and that's going to be the trick and probably the newer management paradigm. We take liver metastases, which is for oligometastatic or oligoprogressive disease. That's standard. And we do for patients which are not suitable for surgery or thermal ablations. The best patients would be a CPA childhood A, LB 1 to 2, limited burden, but we do it till B7 as well. Obviously, if the patient is with decompensated cirrhosis, diffuse disease, the outcomes are going to be poor, and the outcome is generally later in these cases. So, what has changed? We have started incorporating this SBRT for hepatic diseases in your test guidelines. We have come up with the major randomized data from RTOG 1112. The Astro has come up with their 2022 guidelines, which have endorsed SBRT roles across these settings, which I've just labeled, and I'm not going to go in the details. We have a major ISRS meta-analysis which showed that a local control of 85% at 1 year can be achieved in these cases with manageable grade toxicities. And the supportive trial in the scenario of a PVTT plus combination studies with SBRT, immunotherapy, TKI shows promising signals. So these are the list of exhaustive. So this is something we are not backing it just with technology, we are backing it with hardcore evidence. And this evidence lies in terms of both randomized data series and as well as prospective single arm series. So the importantly, even with certain new age novel TKIs and combining with SBRT, concurrent nivolumabs, combining it with SBRT. So these are something that have given us enough evidence that we can use these therapies to prolongate your systemic therapy and without changing the next line. So, what is important is that with these novel agents, that the strong contemporary signals have come up, which have shown that even with patients with PBTTs and larger macrovascular diseases, they can be taken off the palliative and come for probably a curative setting line if you employ these combinations. So this is going to be the new thing that is going to come up in the management of hepatic or HCCs, and for patients which are generally not suitable for hepatic resections, and that is going to be the majority burden of Indian patients, patients which are B4, B5, B7, and these are patients which are going to land up with SBRTs and systemic therapies combination. So the clinical application, as I've told you, remains combination in oligoprogression in immune refractory HCCs. These are something that you give time your tumor and then continue with the systemic line. So my topic was dose where it counts, and that's exactly what is important with the technology. Now, here's something that the technology in oncology comes with flat. We're able to deliver a very high precise dose, as high as probably 54 gray in 3 fractions, 60 gray in 5 fractions, depending upon the location of the tumor. And I can something which used to scare us probably 5 years ago is that the proximity to duodenum, proximity to the GI adjacent lesions. I'm very well able and comfortable in managing these patients. It's a OAR limited plan. Obviously, I need to respect my organs, but it's easily done. I'm not going to go in details about what are the specific organs that we do. This is something which we easily manage. And this is something that we follow in our routine as to how which motion management you want to select. We have amplitude and we have a number of motion management techniques that are available for us. You employ whatever you want to do, which is best for you. Whatever you have your training in, whatever your institute is comfortable in, please do that. And that is, and we've seen it over our experience that it doesn't need high technology evidences. It just need whatever you have, you are sure and comfortable in using it. So I just have 3 cases and different scenarios I wanted to highlight, and this is the combination era, like I've told you. It's about SBRT and immunotherapy. So this was a 54-year-old male diagnosed with HCC PVTT with PVTT in Jan 25. PIFCA 577, a CPA, platelet about 2.5 lakhs, albumin 3.9. So we discussed this and it was decided that we'll continue with systemic therapy. The patient was not suitable for any other localized treatment. I'll show you why. So we decided to give SBRT to the PVTT lesion and continue the systemic therapy. So just look at the massive disease that was present in the left lobe, segment 6, segment 5, 4, and 3. So along with this long segment PVTT that existed in this case, and we treated this with SBRT and we continued systemic therapy. This patient is completely disease or the best disease free that patient that can achieve as of March 26. So this is something that is doable, achievable, and going to help these patients. Similarly, another taste failure patient which had a 5.4 centimeter lesion in segment 6 and 7. We did taste patient was started on lenvatinib, however failed. We salvaged this patient with SBRT and continued lenvatinib. This patient remains disease free with a 40 grain 5 fractions. Obviously, these are anecdotal cases. You can might as well put up that there might be evidences to go against these, but these patients did get a second chance of life with employment of SBRT. Similarly, this was also an interesting case. This patient diagnosed with the left lobe HCC with PVT underwent bridging TACE with Lenva, underwent LDL, the liver transplant in 23, recurred with a periportal lymph node. This patient would have been palliated in probably 5-7 years back earlier. However, this with the new technology that we have, GI adjacent lesions are not a concern anymore. We are able to do it with the kind of technology that we have. And this patient was managed by 35 gray with a center dose of 38 gray, and this patient is disease free. So my conclusions would be that we have to think beyond the current scope of treatment for HCCs if you want to increase the survival, if you want to increase the quality of life for these patients. And there are certain trials which are coming up for the combination. We need to watch for them. If you have good technology available with you, that's good. But that should not stop you from treating these patients with aggressive intent. Thank you.
Thank you, sir. Over to Gaurav Gupta.
That was a master class on SBRT on liver, Dr. Sarthak, I must say. So I would like Dr. Charu Garg ma'am once again to come to stage for felicitation, and I request our chairpersons to facilitate her.
तीन लेके जाओ I request our chairperson, please felicitate Dr. Charu. I request Dr. Sarthak, please join the stage. And Dr. Amit Jotwani, please. I request our chairperson, please collect their mementos from the memento desk. And I request Dr. Santosh, please give memento to our chairpersons. And before our melodious night, we have a interesting session on comprehensive decision making in the treatment of advanced ovarian cancer. Deliver this session, I invite Dr. Darshit Shah. He is consultant medical oncologist, a hemato-oncologist, physician oncologist, bone marrow transplant, Sir H.N. Reliance Foundation Hospital and Research Center, Mumbai. And to chair the session, I would like to invite Dr. Deva Dulal Vishwas. Please join the dais as a chairperson. Dr. Vikram Sharma from Ramakrishna Care Hospital. Please join the dais as a chairperson. Over to you, sir.
Good evening, everyone. I think I am the last one between the lunch dinner. I am also hungry.
That to melodious and that to melodious.
I would like to thank Dr. Ravi Jaiswal for inviting me. I'll quickly speak about management of ovarian cancer, and I think slides are not moving. Yeah. So, I am actually honored to have so much of audience at 8:45 p.m. And that was a wonderful, event organized by Dr. Ravi Jaiswal. We all know how ovarian carcinoma is treated. All of us, the primary thing is, we do germline BRCA testing, we do HRD testing, and if the patient is operable, we kind of, go ahead with primary cytoreduction surgery. Thank you. And thank God. So,
पीडीएफ है हाँ
चलेगा पीडीएफ चलेगा पीडीएफ भी चलेगा पावर पॉइंट था ना पावर पॉइंट था ना
कोड एलसी भी नहीं हो रहा देखो कोड एलसी भी नहीं हो रहा इनवाइट कर दिया था
पीडीएफ कैन बी जस्ट स्क्रॉल हाँ तो स्क्रॉल कर चलेगा ना तो स्क्रॉल कर लेते
हो नहीं रहा है अच्छा कैसे आना है कैसे आना है
फोटो खींच लो आप फिर मेरा
आप पीडीएफ ही बोल दो
यस पीडीएफ खोल लो पीडीएफ खोल दो बस
हाँ खोल रहा
यही खोल दो ना बस ये खुला हुआ है ना नीचे करो बस मेरे साथ रहो आप
कुछ नहीं हो रहा वो hang मार- नहीं हो रहा।
So, predominantly I'll speak here about niraparib. We all know, yes. Thank you. I'll just speak predominantly about the PARP inhibitors. We all know, like, we have so many options. We have olaparib, we have rucaparib, now we have niraparib. Predominantly, when we speak, we see that, the germline BRCA or HRD positive, we have all the three options. Either we can choose olaparib or rucaparib or niraparib. But especially when we talk about the BRCA wild type HRD, HRR mutations, we only have options of niraparib. We have seen that the stage 4 patients and stage 3 patients, nearly 25% of patients are only there who are long-term survivors. But 75% patients relapse after in 3 years. So they require some form of maintenance therapy, and niraparib is one of the options where we can offer them maintenance therapy. Uh, the tolerance is also fair, and we should be choosing them in options as one of the option. One thing I would like to mention is, niraparib has also resulted in the improvement in the PFS, and also the CA-125 decline also has been significant. So the patients who undergo primary CRS, they should be on niraparib. If the patient has received NSCT, if there is a partial response, if the CRS has been achieved, if there is R0 resection, then we should be giving maintenance niraparib to all our patients, predominantly BRCA mutation, HRD mutation, and also if they are BRCA or HRD wild type. So, yeah, I'll just quickly run all of you through this. You know, yeah. So estimated incidence, I think we can just skip these slides. We all of us here, as medical oncologists, we treat ovarian carcinoma day in and day out. Yes. Thank you so much. Incidents, I'll just skip this slide. Yes, this is where I would like to all of you to pay attention is there is always a chance of recurrence. As I already mentioned, 70% of patients recur in first 3 years despite all the standard therapies. So that is a big number. First line maintenance therapies have transformed patient outcomes in ovarian carcinoma. Yes. So we all know about Solo One, Paula One, Prima, Athena Mono. The olaparib was the first ARP inhibitor started in 2015, followed by data of olaparib and Bev. We had niraparib in 2020, where the patients who are achieved partial remission or CR were given maintenance, and now it is also available in India. So this is how so these are the basically the hazards ratio. We can see that in the prime and the prima trial, the hazards ratio for the BRCA mutation and HRD was 0.40 and 0.43. That's quite impressive number. We also in prime trial, the niraparib, the hazard ratio was 0.40. Yeah. So we see that if the patient is we always do BRCA and HRD testing. If the patient is BRCA mutated, we have options of olaparib, Ola plus Bev or niraparib. If there is HRD, positive BRCA wild type, we can still choose either one of them. If there is BRCA wild type and HR proficient, then we have options of niraparib or bevacizumab or rucaparib. So this is one of the options predominant in HR positive and BRCA wild type tumors. So, but BRCA and HRD status don't explain everything. This is a number which I was also not aware. When I was going through slides, up to 25% of patients who are BRCA mutated, they relapse in 12 months. That's a huge number. Despite being BRCA positive, despite receiving PARP inhibitors, there is a chance of relapse in one-fourth of the patients. And up to 30% with HRD tumors also relapse. So, some patients with HR proficient tumors may also benefit from long-term PARP inhibitors. So, what are the factors to consider? There are so many factors. Predominantly is the stage. The other factor is the chemosensitivity response. There are also other factors like time and outcome of surgery, but two most important factors are the tumor stage and the chemosensitivity. So, tumor stage, we all know that hardly we see patients stage 1 and stage 2. Predominantly in our practice, they are all stage 3 patients and stage 4 patients. So, yeah, I'll just skip these slides. We all know that primary cytoreduction or NSCT, the patients should be achieving partial response when we give NSCT. Yeah. So this is the both surgical intervention and the residual disease status are very powerful predictors of overall survival. I'll just skip this slide. Yeah. So chemosensitivity, whenever we talk about chemosensitivity, there is something called chemotherapy response scale. There also CALIM. CALIM is basically how the CA 125 decline is there. If the decline is very sharp, the response is favorable. So in those specific patients, when we have a chemotherapy response score favorable and CALIM score which is more than 1, the response to niraparib is very significant. And when the patient is having CRS 3, then it is associated with improved OS and the PFS. So these are the slides. The bottom line is the patient needs to have a higher chemotherapy response score and the patient needs to have a better CALIM score. Yeah, I think this is mainly the gist of the patients who are favorable and they should be offered niraparib. These are all the consensus which has supported this theory and the practice is also like this. Correct. So Yeah, I think this is predominantly the bottom line. I'll not take much time. So I would like to summarize that the majority of patients are diagnosed in advanced stage with poor prognosis. 70% patients relapse in up to 2 years. Complete CRS is one of the very, very important factor in advanced ovarian cancer leading to improved survival. Appropriate patient selection is critical for primary cytoreduction. Response to platinum-based chemotherapy is a potential predictive indicator for PAR benefit and should be assessed with RESIST, CALIB, and CRS. So, with this, I would like to thank all of you. Thank you so much for patience listening.
Thank you, sir. Any question from the audience?
Thank you so much. Thank you.
Thank you. I request our chairperson, please felicitate with memento to our speaker, and I request Dr. Maura madam and Dr. Ravi Jaiswal together join the stage for a memento. And I request our chairpersons, please collect their mementos from the memento podium, which is just outside of the hall. And I request Dr. Girish Agrawal. Dr. Girish Agrawal, please give memento to our chairpersons at memento desk, which is outside of the hall. Just. Once again, thank you all the speakers and chairpersons for the today's sessions. And I request you all join us a delicious dinner with some musical outcomes. Thank you. So there's a dinner which is getting set up, and there's musical gathering here. So please enjoy. Thank you.
Hey, hey, check. Hello, check. Hey, 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 hey. Hello, check. Hello, check. Hey, check. Check. Hey, hey, check. Hello, check. Check. Hello, hello, check. Hey, check. One, two. Hello, check. Hello, check. Hey, hey, check. Hello, check. Hello, hello, check. Hello, check. Hey, hello, check. Hey, check. Hello, check. Hey, check. Hey, check. Hey, hey, check. Hello, check. Check. One, two. Hello, check. Check. Hello, check. 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 Hey, check. Check. Hey, check. Check. Hello. Check. Hey. Check. Check. Hey. Check. 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 One, two, three. Check. Hey. Check. Check. Hey. Check. Hey. Check. 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 Hey. Check. Check. Hey. Check. Hey. Check. Check. Hey. Check. Check. Hey. Check. Check.